increased, they also causes, there will be some increase in the dermal collagen deposition. And coming to the medium depth peels, they penetrate the papillary dermis to the upper reticular dermis, and they cause extensive protein precipitation and coagulation necrosis. So TCA 35 to 50% and TCA 35 plus glycolic acid 70% gelatinous solution, these all comes under medium depth peels. Coming to the deep peels, they penetrate till the reticular dermis, and they causes denaturation of the epidermal keratin and dermal proteins, and there will be a complete epidermolysis and mid-dermal injury. Sometimes even subcuticular level also will be there. The damage will be there till that level. TCA more than 50%, and this Baker-Gordon formula comes under deeper peels. So these are the peels by depth. So, superficial, again there are two types, light and deeper. So these light peels are glycolic acid 20 to 50% and salicylic acid 20 to 30%. Superficial deeper peels are TCA 10 to 30% gelatinous solution, and remaining all comes under medium depth peels. So what are the factors which influence the penetration of the peels? So once we plan any peel, first we have to calculate all these things. So contact time is important, and frequency of the repeated sessions we need to consider it, and force of application, with what force we are applying, and how unnecessarily deep, and it should not be unnecessarily superficial. These things should be considered. So while choosing a right patient, we need to take the results. What are the results expected from the peel, and patient fears? These two matters. So what are the from patient point of view, they have a fear of treatment complexity. There will be a risk of complications. There will be a downtime and cost to the patient. So these two things should be balanced. Our results should be outweighed the fear of the patient complexity. So then only we can give a better results. So patient selection is very, very important. Skin type and sensitivity, dry skin is there or not, what is his outdoor occupation, photosensitivity, whether keloid tendency is there, and any unrealistic expectations, and psychologically disturbed patients. With these patients we should be very careful. So skin type, this is Fitzpatrick skin types. And before starting a peel, there should be a personalized pre-procedural consultation, because peels are available in different types of peels are available, different formulations are also available. So we can individualize the peel according to the patient needs. So first, before starting the peel, a detailed medical history should be taken. Skin examination, whether dry skin or what is the color of the skin, or sebum, how much sebum he is having, all these things should be considerations should be taken into consideration, and current lifestyle, expectations of the patient should be taken, and occupation. So this history is important, whether they have any herpes simplex infection, previous resurfacing procedures they have undergone, and the amount of UV light exposure, which is very, very important, because after deep peel they need photoprotection several weeks, and smoking, all these things should be taken into consideration. So then coming to the examination, so assessment of the skin color and degree of photoaging, all these can be taken. Sebum content, pre-existing any inflammation is there, then better to avoid the chemical peel. Even on dry skin, first you hydrate the skin, and then we need to do the peel. So examination first, what amount of peel they can tolerate, and after post procedure, what are the expected results. All these we need to consider before starting the peel or before considering the peel. So investigations, usually we won't do any investigation, but in case of phenol peels, we can go for hemogram, urine analysis, LFT, RFT, and ECG things. So how to choose a best peel? For peels can be, usually we do peels in case of acne, hyperpigmentation or aging and some pre-malignant conditions also, in cases of some pre-malignant conditions. In case of a comedonal acne, salicylic acid, pyruvic acid, Jesner solution, glycolic acid, tretinoin peels can be done. And in case of mild to moderate acne, salicylic acid 30%. Well, if it is an inflammatory acne, pyruvic acid, Jesner solution, glycolic acid can be done. And severe nodulocystic acne, pyruvic acid. So there are several studies even in comedonal acne, they have compared salicylic acid 30% with 30% TCA. Both showed equal results, but more recurrences with TCA. So any peel can be done, but we need to consider the patient choice and our choice mainly, and patient how he is going to react with the peel. And for the acne scars are polymorphic, multiple types of scars will be there, and we need to combine these peels with other modalities of treatment also. When there is a superficial or post acne scars are there, then pyruvic acid 40 to 70%, trichloroacetic acid 25 to 50%, and salicylic acid, these peels gives better results. And medium depth peel, phenol, trichloroacetic acid, and these can be combined with excision, elevation and subcision also. In case of darker skin, better salicylic acid peels gives better results, Jesner solution, glycolic acid and trichloroacetic acid. And how to choose the peel in melasma? Melasma is very difficult to treat, we all know, and we need to combine multiple treatments to treat melasma. But when coming to the peel, only superficial peels only better if we do in case of melasma. I prefer usually Jesner's peel, or else sometimes salicylic acid or glycolic. These three peels only I'll do, that to superficial peels. So melasma, we can go for the salicylic acid peel, Jesner's, pyruvic acid, glycolic, trichloroacetic acid. But in darker skin people, salicylic acid peels gives better results in case of melasma. Coming to the photoaging, glycolic acid, trichloroacetic acid, salicylic acid, and these are the better peels. And in case of post-inflammatory hyperpigmentation, again the same salicylic acid, glycolic, Jesner's, pyruvic. In case of rosacea, when erythema is there, salicylic acid peel 15 to 20% or up to 30% we can do. And in case of papulopustular rosacea is there, salicylic acid 20 to 30% can be done. So this is peel with kojic acid. And this is very difficult before and after pictures. We will take before pictures, after pictures often we forget. So this is salicylic acid 30% peel. After you can see the frosting, that is the end point. And in case of keratosis pilaris, GA 70% is gives best results, or even Jesner's peel also gives best results in case of keratosis pilaris. So coming to the end point, so once after applying the peel, we should know when to stop the peel or when to clean the peel. The end points are very, very important. In case of glycolic erythema is there, it is a superficial peel. When vesicles are there, either it could be a superficial or medium depth peel. In case of salicylic acid, erythema with crystalline precipitate will be there. That is the end point. Jesner solution, there will be a speckled frosting scene and erythematous base will be there. 15% TCA, there will be a transparent frost. 20% TCA, there will be a compact or a delicate frosting will seen. And in case of 35% TCA, compact or porcelain-like frosting is. These are the end points of a peel. So coming to the superficial peels, the advantage is they can be, in case of acne, generally superficial peels are very safe. That is the advantage of this. And mandelic acid and in combination with salicylic acid works well in case of acne and melasma. TCA to be used with caution in darker skin. So pre-peel priming and post-peel care, these are very, very important, and they reduce the chances of the complications, and also these two things, they modify the outcome of the peel result. So the essentials for a successful peel is more than an ablative technique, the process uses an inflammatory reaction and dermal stimulation to modify the skin. So this is the clinical concept which we need to consider. Pre and post procedural skincare is very, very important. It determines the reepithelialization and recovery time and remodeling. So coming to the conclusion, the treatment indication first we should we decide the indication and what peel we have to decide, and the desired depth of ablation should be taken into consideration, and pertinent exam findings. We need to examine the skin. Examination of the skin is very, very important. Skin type and relevant dermatological history, all these matters. So choosing a right peel and to the right patient gives outcome, a good outcome. And again, there is American Dermatology Society study shows that there is again research in the peel application or patients undergoing the peel procedure. So thank you. I thank DBN Murthy sir, Neta sir, and Sudharani madam and Bhumesh for giving me this opportunity. Thank you.
Thank you, Dr. Sudhavani Madam, for having a very good lecture on how I choose chemical pills. It is followed by Botox and fillers, my choice, Dr. P. Usha. I welcome Dr. P. Usha.
कर्सर इस पे भी काम करते हैं, इसमें भी काम करते हैं, ये भी काम करता।
हाँ करता हूँ।
राइट है, राइट कौन सा है? Good morning, everybody. Good morning, respected chairpersons, faculty, and Gandhi Hospital staff who has given this opportunity to me. Today, my topic is Botox and fillers, my choice. Even though it's a very difficult subject, I'll try to cover a little bit. So I don't know what to talk because toxins have various indications, fillers have various indications, patient expectations are completely different from what we do, and my choice will be limited to this area. Roughly, if we categorize the facial structure, facial anatomy will be divided into skin, muscle, fat, and bone. We cannot do anything about the bone structure, but what we can do is, for muscle layer, we can do toxin. Whatever deformities are happening because of the muscle, we cannot say it as a deformity, okay, cosmetic concerns. We can do Botox for the muscle layer. These are all the indications which we can do with the toxins. Like from forehead to gummy smile, we can correct so many things with the toxin. How much Botox we need with each and every indication, this is a rough indication. We can change according to the male and female also. In this, we are demonstrating the forehead Botox injection. We will do at multiple spots very superficially. We are targeting the frontalis muscle. This is the glabellar indication, where we have done procerus and now we are doing corrugator muscle. And next will be the crow's feet. These three are the commonest conditions in the cosmetology practice. Crow's feet, we are targeting the orbicularis muscle, very superficial injections we will be doing. Next comes the fat pocket. These are the superficial fat pockets which we have in our face. Whenever we need to correct the facial fat pocket positioning, then we can use fillers. Either when the deficiency is there, we need to fill those deficiencies, or we need to reposition the fat pockets. These are all the indications which we can do with the fillers. But today we will discuss mostly about the choice. That's why I'm briefing these things. Okay, this is the filler which we are doing for the theatre of deformity, the under eye darkness, the theatre of deformity. This is for the cheek lift we are doing. This is for nasolabial fold. Nasolabial fold, the medial part will be a little bit deep. Coming to patient expectations. Patient expectations are too high nowadays in cosmetology practice. Roughly, we categorize them into positive aging patients, correction patients, beautification patients. Positive aging patients, it's the commonest presentation. They come to look good, they want to look less tired, less sad, less saggy, and they want to look more youthful. So they want the procedures to be done without changing their natural look. She's a young lady, not a young lady, she's a 50 years old software employee. She came for all these indications. So what we did is the frontalis muscle wrinkles were there, the subordinates are thinking that she is unapproachable and angry. So we thought we will do 12 units toxin to this area. And she was, the crow's feet is giving her a lot of aged look, so we have done 10 units each side of the crow's feet. And nasolabial is very saggy, so we did one volume of filler over there. And her jowls are drooping a lot, so we did 2 volume of fillers to uplift the cheek. Actually, we have not done the filler over here, we have done it over here so that we can uplift the cheek. See, 50 years age only with Botox and fillers, we cannot completely cover the things. The neck is the commonest area where we will show the aging. So these are the platysmal bands. Because she is 50, they are very prominent. We have done 50 units toxin to the neck. This is the result we could achieve after doing the procedure. Next comes the correction patients. Medically correction patients, usually they come with hemifacial atrophy or post-traumatic scars, or sometimes Bell's palsy patients. For them, we can do whatever correction is needed. She is a patient with hemifacial atrophy. Right side, there is a hemifacial atrophy in, sorry, the marker was wrong. There was a hemifacial atrophy on the right side profile was good, and lot of this thing, and nose septum got deviated because left side muscles were dragging those things. So we did only filler for the right cheek. It got corrected. Next comes the beautification patients. They want wow effect. They want to be seen like, they need noticeable visual improvements. They want slight changes. They don't want many changes. They don't want to transform. So she's a young girl, 23 years. She came for theatre of deformity. She's main concern is only for under eye. So we did 1 unit, 1 filler for the under eye thing. But her face is looking broad over here. If you see carefully, her face is looking broad over here at the lower part. So we did few units over the masseter, so that is giving that jawline contouring effect. And her chin is very small. So we did little bit of chin filler to increase that. So this is the side profile picture of that patient. The profile will improve with this. Slight changes, the profile will completely improve. Next comes the transformation patients. Transformation patients, they want to look good. They want to transform themselves completely. 1 minute. She is a patient. We did only 2 things for her. We did her nose correction and we did her chin correction. Here her chin is very small, so we did a little bit of chin anterior and inferior projection. Her nose is very saddle, there is no proper line is there, so we created a proper line. And eyebrows were thin, so we did some cosmetology procedure for that. So this is the result we could achieve in her case. Now comes this is the side profile picture of that. Now we discussed about the toxins, we discussed about the fillers, and we discussed about the expectations, but the choice is only this much, right? So when the factors which influence the choice is definitely age, So depending upon the age only, we need to choose the treatment, and gender, we cannot feminize a male face simply by doing all these things. And expectations, patient's expectations we discussed right now, there are many expectations from the patient. And ethnicity, definitely we need to consider. We cannot make a South Indian face for a Mongolian person. And occupation also important. If the person is dancer, we cannot completely knock off her muscles. And budget, of course, budget is the main concern in our cases. Usually they give 1 or 2 fillers cost, they will give you a chance of 1 or 2 filler and few units of Botox, but they want to transform completely. The time limit, usually they come before function, 10 days, 15 days before any occasion and all, they want every changes. We cannot correct everything, that we need to understand. She is a lady who is 43 years old. Her main concerns are under eye and nasolabial fold and marionette lines. She was demanding to fill this nasolabial fold and marionette lines. We explained her, don't go for the procedure, don't go for the nasolabial fold correction and marionette. If we do the filler on these areas, your face will look moon-like. But she denied that. She went to some other dermatologist, she got it corrected. This is the face, which after correction. This is the moon face. So again we highlighted everything, and again when she came back, we started correcting her features. So we just did 12 units of toxin for the forehead, 15 units for the glabella, and under eye we did 1 filler, and 8 units on the chin, because already she is exhausted with the budget which she is having. So we could not do filler for the chin, so we did only for mentalis, we did 8 units toxin. And here if you see, we could correct this. Her face is South Indian bulky face. We cannot correct everything. We cannot create a sharp jawline in her case. Even if they give 12 fillers also, we cannot create a sharp jawline in her case. So we lifted this part of the cheek, so we could achieve this much of result. If you start tracing out each and every fold of the person, it's very difficult to correct those things. We cannot trace out each and every fold of the person, even though they demand. Patient expectations will be different and indications will be different. So there are so many indications in her case. If you start doing all those indications, her face will look different. What is good for her, that we need to decide, that will be the choice. In her case, even though the topic is toxins and fillers, so we didn't discuss about the threads, but we did 4 threads also for her. Otherwise, this sleek appearance will not be there. Thank you. Happy client always gives you your pleasure.
Thank you very much, Dr. Usha. So I request you to go to the photo booth to collect your presentation. I request next speaker, Dr. Evitas John, to come and then give his presentation. He needs no introduction because we have already seen him in the basics, and then so he will be talking on ablative and non-ablative lasers. Dr. Evitas, please.
I don't need the laptop. Slide. I thank Bhumesh Kumar sir and DBN Murthy sir for giving me this opportunity to give my ideas on ablative and non-ablative laser. This is just a little bit of an overview, but a little bit in-depth on fractional laser, because that is one which we all use. So basically, lasers we are doing for a lot of things, like from hair removal to vascular, and this is mostly about treating the collagen part of it by using the chromophore water. So basically we are shutting down, we are not talking on all these aspects, we are only talking on this. See, how a laser is, it comes into the market is, they study these. Okay, why is the pointer not working? Okay, you had green pointer? Okay, fine, no problem, no problem. So you have this peak at 2940. So it means that there's a lot of chromophore absorption there. And if you see CO2, the peak is not so much. So please remember that it is not like the more absorption of water means that the laser is good. It means that the wavelength also matters. If you see 1064, it is a very long wavelength. That means it works deeper. So that is why we can't use your erbium for your keloids and hypertrophic scars, but you can use CO2 laser for erbium for keloids and hypertrophic scars because it has to travel deeper. And you have these small peaks which comes between the star from 1200 up, it goes 1000 to 1000, 2000, you have a lot of peaks there. That is where all your erbium glass comes, thulium laser comes and all that. So we have got a non-ablative in that spectrum. So we have ablative, which is CO2 standalone and fractional. Your erbium is an ablative laser. Partially ablative or quasi-ablative, we have got different technologies, some dealing with your erbium, some also dealing with your 1064 also is an ablative laser in 1450 nanometers. So that's also there. Then you have your erbium 1550, your 1565 fiber, which is with the erbium. Again, these are all non-ablative lasers. So coming to CO2 laser, there are only 3 different modes of an operating CO2 laser, not CO2 fractional. We have got your continuous wave, you got your super pulse, and you got your ultra pulse. So those are 3. Now how do you choose the power? Power is in watts, and normally for any beginner start from 5 to 10 watts for a standalone CO2 laser. Though the machine gives 30 watts, in my practice I never even crossed 15. It's too powerful after 15. And you got the on and off time. Remember, in continuous wave, it is a continuous wave. It's not going to pulse. So the pulsing will come only with super pulse and ultra pulse. So super pulse, it is in milliseconds. So when you fire, you actually hear, you can actually hear that pulsing. But with ultra pulse, you can't hear the pulsing. It will be something like that. That is what you hear with your CO2 fractional when you do. That is because it's ultra pulse. So in your company sells you an ultra pulse machine of a CO2 fractional and tell them it has got CO2 also. It doesn't have super pulse mode in that. So please don't trust that it has super pulse. It has only ultra pulse. You have to work with an ultra pulse. Now, what is the difference? See, if you're dealing with a large lesion, say a linear abdominal verrucous nevus or something, sebaceous nevus, something like that, you remove 80% of the lesion with a CO2 continuous wave. The remaining 20% you work with ultra pulse or super pulse of what is comfortable with you. Because if you try to use a continuous wave, it burns more than what you want and there will be a lot of scarring. So please be careful not to remove the whole lesion with a continuous wave. So this is just linear abdominal verrucous nevus done with only super pulse and ultra pulse. This is just one session. This is the improvement you can give, but you have to work carefully. The thing is, we are removing something, we should not form a scar. So if you are not comfortable with it, you tell the patient, I'll do it over 2 sessions. Remove 80% of the lesion, the remaining 20 I'll remove after 6 weeks or 8 weeks, like that you tell them. So this is just when she came for a second session. Always I don't have the end photograph because as madam told, once the patient is cured, they don't come and meet you. So you can see that the scarring from that is less, but pH is yes. pH is a common thing which everyone of us know how to treat it. And this is a very important thing which you have to understand. What is ablative and non-ablative? If a company fellow comes and says that my ablative laser is very good, it will not burn, no PAH. See, thing you have to remember is when you are dealing with a fibrotic scar, you need to take off some of the tissue out of that area or else collagen will not rebuild. For that you need vaporization. Vaporization means there should be a chunk of skin which has been removed from there. So that vaporization, if it doesn't occur, you cannot treat fibrotic scars. So boxcar scars cannot improve much with non-ablative. When you talk about non-ablative, there is only heating and there is collagen remodeling with no vaporization. So, sir, why should I buy that? Yes, you can buy that because distensible scars you can treat, wrinkles you can treat, stretch marks you can treat, all skin tightening you want to do, you can do with your non-ablative laser. So nowadays, your CO2 laser itself is coming with a combined erbium glass. So you can actually have the option of having both in one system. So that is very good now. Coming to CO2 fractional, this is one of the panels. You have a lot of different machines in the market. You have to understand that what you have to calculate is the energy per point. Some machines you have only power. Now, when you give more power, you actually have more energy, more damage. When you have more duration, it also creates more damage. So both these two things create the same thing. So when you multiply both these two values, which is watts and your milliseconds, you get millijoules. That is the energy per point. If you see 30 into 1 is 30 millijoules. So if you read in a journal that they say 50 millijoules used, means what? It is either 50 watts into 1 millisecond or 25 watts into 2 milliseconds. But there is a slight difference in that. I will come back to it with an image. Then the distance. Distance is the distance between the dots placed with a fractional laser. I am talking about a fractional laser, sorry. Now the distance is determined on the energy. High energy, distance has to be longer, distance has to be more. Lesser energy, you can come closer. If you are doing superficial work, the distance can be closer. Now, for example, you are using for epidermal remodeling you want to do, you have to use the lower energy, preferably between 10 to 15 millijoules. If you want to do a dermal remodeling, it should vary between 30 to 45 millijoules. So there is a difference in that. And some machines, if you buy, it will be written not distance, it will be density. Density will be in fixed values, 1, 2, 3, 4, 5. 5 being the highest density. Density means more dots in an area. So don't put high power and more dots in an area. And in some machines, it will be in dots per area. It can be varying from 50 dots all the way up to 300 dots per square centimeter. You work in a 2 by 2 centimeter square in a larger spot size of a CO2 fractional. In that many dots. So you choose the number of dots according to the energy. In some machines, it will be in coverage area. It's the same value but different meanings. Coverage area means it will be in percentage. So if you're using a very high energy, then coverage area should be between 10 to 15. If you're using a very low energy, coverage area can be between 30 to 35% of the total area. Yes. This is what I wanted to say. 20 into 1 millisecond is 20 watts into 1 millisecond is 20 millijoules. This is the damage. What if I do 30 into 1.5? 30 into 1.5 is 45. Okay. What if I do 15 into 3? It also means 45. But the damage is different. Meaning you actually have a much wider damage at the epidermal surface. So if you're using a very low power CO2 fractional, please be very careful. Don't try to bring the dots closer, because with the low energy, the spot size, the damage it creates is very, very much. So you need to compensate for that by increasing the dot space. Then you have normal and random. Now this is nothing, but normal means it starts from 1 point, ends in 1 point. Fractional just fires all over the area. Why we have to use that is normal is painful. Random is little bit less painful when you do it on the patient, but the thing is, for every place we cannot do random. I'll show you why. Now there is static and dynamic mode. Don't get confused. It is nothing but normal is called static and random is called dynamic in some machines. Then you have overlap and times. That is the same area, how many times you want the machine to hit. Meaning that you should not move the handpiece. Keep the handpiece on. You put 2 times, that means it will hit the same area twice. Now, coming to your erbium has different handpieces by different sizes, like 7 by 7, 9 by 9 dots per area, like that. So, depending on what you're which area you're trying to treat, the handpiece changes. The total energy depends on how much, maybe 5 to 10 millijoules per dot you will be using. If you're using around 50 dots, then you multiply the total energy. So that's all with, in journals what you read, this is what it means. So you have to understand that. Energy per beam depends on the number of dots as well as the energy being used per dot. And nowadays erbium is not much used. It is used, but everyone likes CO2. Everyone calls CO2 the boss. CO2 fractional is the boss. And stacking, what is stacking in erbium is nothing but times. The same place, but there's a slight difference. Some machines, what it does is every dot it will hit. If you put stacking 3, every dot will be hit 3 times before it goes to the next dot. Sometimes it will fire all together in one, again one, again one. It's a powerful system. Frequency is done at 2 hertz in erbium. Can you play this video? So can you just play this video? So this is just showing you what is a normal mode, what is a random mode and things like that. So this is a normal mode. Starts at 1 point, ends in 1 point. This is for a distensible acne scar. The patient doesn't have much deeper scars. This is a this is the random mode. It starts at 1 point, ends in 1 point. Problem is you cannot leave the foot switch. You have to keep the foot switch pressed because halfway you can't stop it. This is called the feathering because in between if you have left some places it is bad. Plus this feathering should be done at the edges of the treated area also so that when the patient comes after 2 weeks they don't have that kind of a deformity where it looks odd, you know, lighter skin, darker skin like that. So you have to do. And this is one trick which you can do using a wet gauze piece. You can cover the area which you don't want to do and then you can do the laser. If you do it like that, you can cover areas which you don't want. It, like say near the ear, you don't want to go over the ear, but you don't want. See, what you can do is you can change the spot size, but every time you touch the screen with your bloody hand, so better not do it. So better to cover it and then do it. So a scar like this, we need to treat the fibrotic scar. This is subcision already done. The center part of it has been treated with CO2 fractional. Now what you do is you treat the epidermal side of the scar also, a little bit on the sides. So what you do it like this with a little bit of feathering also if you want. Please remember this kind of results will only occur when you are treating the temples or the forehead. This kind of scar will not improve in the cheek area. Very difficult to treat cheek area. Most of the time I tell the patient we'll try fractional. If it doesn't work, we need excision suture. So it actually helps very well. The epidermis grows over the fibrotic tissue because that is what we want. Now any thermal device, remember one point, this patient we did, he improved. So, and this is after 4 sessions. Then the patient said, sir, this is not improved. I said, you had already done 4, you come after 2 months. This fellow comes very late, almost after 9 months after the last session. See how his scar has improved. Why? Because any thermal device will continue to remodel over a period of 6 to 8 months post-procedure. So, fraction laser patient doesn't have a response, tell them, sir, you are a slow responder, come after 2 months, come after 3 months. They will always respond. It is never a failure. Please don't try to do another laser on top of the patient. That's when the complication arises. And where you can use CO2 fractional in other cases is when you do tattoo removal and then if you end up with this kind of hyperpigmentation, you can do your 532 with a low fluence with the fractional CO2. You can actually knock off the pigmentation and the discoloration. Just a small tip, this is not a laser, but this is a new technology of, time over? Yes, okay, so I'm getting. So this system is just a thermomechanical ablation system. Why I wanted to tell you this is, if many of you are working in 2 to 3 hospitals, please see that you can't carry around your CO2 fraction. So this is one device where you can actually use for more indications, which is, this is much smaller than this now, the latest one. It does a thermomechanical ablation, meaning it creates open pores, meaning the epidermis is not burnt, rather it is vaporized but not burnt or charred like a CO2 laser. It has a, I'm sorry. Can I go back? What happened? Sir, it's stuck. Stuck. Yeah, okay, thank you. Sorry about that. So it has a handpiece which actually is made to heat up to 400 degrees centigrade and touches the skin in milliseconds. So it is it is not going forward. Can you change in that? Okay, so it has just 2 parameters and the third parameter which is just stacking. It has got the contact time and the depth you want to penetrate the needles into. Not a needle, it's a pyramids into. It is a good system, definitely a good system for transport. What it does is it does something called open channel, meaning in melasma patients you can do this and you can give them tranexamic acid. The holes close in 20 minutes in most of the thermal ablative lasers. In this it closes in 6 hours. So patient can apply tranexamic acid. Same thing goes for your any kind of vitamin C or anything you want to apply you can do. You can do it on active acne with scars. It gives good results. This is after 1 session, this is after 2 sessions and this is after I think 4 sessions. So it improves, the scar also improves with it. So it's a good system to think about. The same thing, this is another patient with scars treated only with Tixel. So you have good result. You can do it over the eye. Very, very good. For wrinkles around the eye, you are scared to use your CO2 fraction. This is one system where it has multiple indications. This is periorbital wrinkling which has improved with just 1 session. This is the CEO of the company whom I did.
Sir, excuse me, sir.
Yeah, finish sir, it's over. These are the other 2 lasers which are coming up, but they are not into the market in a big way. So to conclude, we have to understand the various mechanisms of an ablative and non-ablative to use it in which indication we want. Confidently, energy per point is very, very important. The thing you have to remember is epidermis, don't try to go beyond 15 millijoules point energy. And always do a thermal ablative laser only once in 6 to 8 weeks. pH is common, but we all know how to treat it. So please, if anyone comes and says you, oh, CO2 laser causes pH, no, don't worry about it. pH anyone can treat, so don't worry about it. And thank you. Sorry, sir.
Thank you, sir, for a very nice, lucid presentation on basics in lasers. Please collect your memento. I request all the delegates to keep their mobiles in silent mode to prevent the distractions. Thank you. The next topic will be on basic dermatology techniques by Dr. Neta, sir. Sorry, basic suturing techniques. Over to you, sir.
Very good morning. Today, given me the chance to talk on basics, requirements and knowledge for dermatosurgery. One should know basics. Given me the chance to talk on the basics things in dermatosurgery, who is going to start, so that we must know the certain basic things. So I would like to concentrate on that. Everybody must know who is this person. He is the father of ancient plastic surgery and anesthesia. Susruta. What is this? As you know, dermatologists in India, both institute-based or individual practices, increasing performing the surgical and cosmetic procedures on outpatient basis nowadays. So, dermatosurgical surgery is an important and significant component in dermatology practice nowadays. Regarding the dermatosurgery unit, what is that? What is the purpose? To establish, the main aim is to increase the safety of the surgery with the most economical use of manpower and other resources. For that, we must require for this unit trained personnel, sterilization, disinfection services, basic and advanced cardiovascular life support system. What is that? This is basic requirement. Whenever is any emergency arises in the theater, we must aware of how to do the cardiovascular life support system for all the members who are working in the theater, familiar with that basic and advanced life support system. It consists of dermatosurgery unit having the 3 zones, as you all know. Unrestricted zone, restricted zone, laser zone I will discuss later on. This is the unrestricted zone. In that simple, just a small practitioner will start like this. Waiting hall, reception and consultation, unrestricted dermatological procedures where directly patient and doctor can enter with the same dress. What are the procedures? As you all know, these are just for the sake of completion. Small simple procedures will be done in unrestricted zone as I showed you. Electric artery, biopsies, chemical cautery, sclerotherapy, soft tissue augmentation, botulinum toxin, chemodenervation. These things are small procedures that can be done in unrestricted zone. Both patient and dermatologist can enter the operation theater in routine clothes, need not to change. Here, topical infiltration anesthesia is usually be used. Other major procedures, it must be done in restricted zone or measures in theater, like vitiligo surgery, nail surgeries, hair restoration and liposuction, etc. Dermatologists must change their dress, head cap, mask and use separate footwear must be there. Usually in this general anesthesia and intravenous anesthesia are permitted. Provision definitely must be there. How ideally dermatosurgery unit to be established? That should be, area must be the quiet environment. It should be freedom for noise, other disturbances, and contamination free and cross infection should not be there. Protection from solar radiation should be there. Adequate water supply, ventilation, electric supply and fire extinguishers must be available. Common features of OT for both restricted and unrestricted types. Common things, these are the basic things everybody must know. One should be dust proof and moisture proof must be there in the area. Corners or junctions of the walls and seals must be rounded. And dimensions of the theatre at least minimum 3 into 3 and 4 into 4 millimeters. Height at least for the 3 meters height must be there. These are the ideal things, I am insisting upon that. Lighting, as you know, shadowless light must be there. It should be delivered 3,000 to 800 feet to candles. Other things, basic things I am insisting upon. Electrical outlets while planning. 3-pin outlet located about the 1.5 meters above the floor with good earthing must be there. 5 amps and 15 amp sockets required. 5 amp sockets on average 4 should be located on each wall. These are the basic things, but I am insisting where we are going to start the theatres. Online UPS must be required. Standby generation, if it is there, is good. Regarding the operation table, always prefer the stainless steel operation table with adjustable head, foot and arm rest. With it might be hand manual or electrical power control maybe. Okay. Dimensions of table minimum must be the 1 meter's length, 30 centimeter breadth must be there. And also important multiparameter to record the pulse rate, blood pressure, cardiac activity and oxygen circulations. Gases like oxygen cylinders, nitrous oxygen cylinders must be there in the theatre premises. Anesthesia, major theatre, biles operators always should be there, then only we can operate the major procedures. These are the biles, monitors, endotracheal tubes, the chair for the manual surgeon's chair, all you can see. Instruments, basic instruments like trolley, everybody known as a Myers trolley, should be covered with the rubber sterile sheet. Surgeon stood with the wheels, just I have shown you. Air conditioning is mandatory for major theatres. It should be filter like 10 microns dust filter should be there. Temperature of the theatre must be maintained 21 centigrades. Humidity must be maintained 50 to 55%. These are the basic things everybody must know. Basic dermatological surgery instruments one must have because these knowledge one must have this any surgeon or dermatosurgeon. Proper knowledge and instrument on the instrument is important to ensure optimal safety and surgical outcome. Proper maintenance, cleaning and disinfection enhances the safety. Care must be taken to avoid the injury to the surgeon during the surgery. These are the instruments everybody knows who are practicing now. I don't want to go in detail. These are the special instruments for the nail splitter, nail elevator, and for the hair transplantation. These are for FUT. Scalpels, one must know. Many people they don't know. The sizes, different sizes and blades also. Commonly, things I would like to insist on that. Blade number 15 is commonly used for the dermatosurgery. Incision less than 5 centimeters. If the more than 5 centimeters, usual blade number 10 and 20 will be used. For 11, definitely used for the abscess drainage and shaving abscesses. And regarding the needle holder, many people there doesn't know what to use. We must be aware of that. Cryle wood needle holder used for the needle number 30 to 20 suture needles. Castrovich needle holder for the number for 6 to 7 suture needles, rider needle holder for the 4 to 5 suture needles. These are the basic things one must know going for these surgical procedures. Regarding these are very much important. Devices for the life support, these must be there definitely. Without that, no one should not go for the surgical procedures. One must be the ambibag, laryngoscope with the different sizes, endotracheal tube with the different sizes, 6 to 8 numbers, and IV cannula with the pediatric. These are all everybody knows, but I want to insist on that. Drip set, IV airway for all sizes, stethoscope, BP apparatus, cardiac monitor with built defibrillator. One must have it. This is very much important. Oxygen cylinders with the connectors, suction devices and disposable syringes. These things I already mentioned, minimum things I am mentioning here. Regarding the drugs, these are very much required. Any situation we should be able to tackle. So we must have basic needs of the minimum drugs. I have written number, quantity. Adrenaline 1 in 1000, atropine, sodium bicarbonate, chlorpheniramine malate, hydrocortisone, injection furosemide, aminophylline, dopamine, methemphetamine, normal saline bottles, 5% dextrose, normal saline, and dextrose 25%. These are the very much minimum one must have before starting for the theatre, doing for any procedures. We doesn't know, because this is also very much important. Maintaining the records, it must contain the patient identity, name, address, phone numbers, everything. Diagnosis must be written, procedure what we are going to do it, persons involved, who is surgeon is going to do, who is anesthesia is going to do, all these things must be mentioned. And complications expected, we must explain to the patient. Consent of the patient is very much important. One should not forget, we should preserve the records after that. Regarding surgical drapes and attires, one must know what is the purpose, why we are using. Drapes for covering the patient while doing the surgery. It may be reusable or disposable, available. It must be sterile. Mask, everybody knows, protects from the splash of blood. Pore size must be around 1 microns, that is the ideal. Surgical cap, prevents the contamination. Surgical suits, clean but not sterile, wrapped for this restricted zone of the theatre. Gowns, patient suits, gloves, these are all things everybody knows, that's why I don't want to go that. Regarding the washing, 2 types, because I am doing for the major surgeries, 6 steps must be followed. These are the things for I don't want to go. Everybody who is practicing well version about this. I would like to insist on that alcohol-based scrub, usually isopropanol, ethanol, N-propanol, chlorohexidine or iodophores. These are the used for the hand scrub. Regarding the disinfection, the purpose, they eliminate most of the pathogenic organisms except for the bacterial spores. Instruments are usually for disinfected by the liquid chemicals, in that 3 categories: high level, intermediate level, low level. Usually for the high level, eliminates all the mycobacteria spores, fungi, bacteria, virus, all these things. Usually the ethylene oxide, butyraldehyde, formaldehyde. I will finish up. Another important thing is, for theatre, one must know the fumigation, how to do it. 500 ml of the 40% formalin in 1000 ml of the water for 1000 cubic feet of the OT for area fumigator is ideal. Chemical sterilization, usually used for the cleaned, disinfected, dried and instruments. Usually used by 2% glutarate for 8 to 10 hours. It can, after 10 hours, you have to autoclave the water, dried and packed stores in the sterile tray. These are the how to autoclave. These things are everybody knows. Just I would like to insist. Sterilization requires 121 centigrades for 15 minutes. Pressure around the 2.4 bars. These are important. How to dispose. The last slide I would like to insist on that. Everybody must know. Black for the what? This is the non-infected waste products. Second thing, the red. Sorry. yellow plastic cover with the blood-soaked gauze, blue plastic cover for the latex gauze, white plastic for the gloves, paper with plastics, plastic pin for the sharp needles and syringes. This is the last conclusion. Dermatosurgical procedure is deemed to successful if it is a aseptic wound healing, painless surgery with minimum bleeding, then only it is successful. To achieve this, one needs clean, unobstructed workplace, good set of instruments and OT, advanced life support system. WHO calls for sober down to earth planning and design of theatre. OT is not place for luxury, but place of high standard of patient safety with most economical use of manpower and other resources. Thank you and all.
Thank you very much, Dr. Neta, for giving us a recap on some specifications and clarifications about the instruments and the other theatre ambience. I request Dr. Neta Narasimharao to collect his memento at the kiosk. Thank you very much. I thank the organizers for giving the opportunity to chair this session.
Yeah, I now request Dr. B.N. Reddy, sir, who is a former professor and HOD, to kindly take on the next to start the session 2, which is on management challenges of acne and scars. Sir is presently working at Medicity Institute of Medical Sciences. He is the professor of DVL there. I'll hand over to sir.
Second chairperson, Dr. A.G. Rao, sir, because of some personal work in the college, he could not attend. So we request Dr. B.N. Reddy, sir, to take over and do the proceedings.
Thank you, Dr. Gumesh. Now we are going to have management challenges in acne and their scars. So I would like to call today's moderator, Dr. Avitas John. So this is a panel discussion till 11 a.m. They can sit here. Now I request Dr. Avitas to call his panelists.
We have 4 panelists. Madam, are you there, Chandravati Madam? Dr. Madhuri. Dr. Divya. So we have our esteemed panelists. They are from experienced to someone who is trying out new things. So you will get an overall view of how each one of them are treating a particular condition like acne scar and acne. So how will this panel discussion go is mostly it will be targeting what is the type of treatment and what is each one's choice. So, and we'll have an algorithm of treatment after that first discussion. Any innovative procedures is there, they will be discussing about that. And a little bit of ablative, non-ablative and non-laser technique also will be discussed. So, Madam, I'll start with you, Chandradi Madam. Madam, Madam needs a mic. Sir, the chair is careful. So, we all know the medical management. So, for beginners, Madam, as a grade 1 approach, if I'm a new doctor, a patient comes to me, sits in front of me. So, how do I tackle this apart from the medical management? What do you offer the patient, Madam?
Basically looking like more papular lesions
Yes,
and scars are present. So of course medical treatment is also required. Along with that, first in the very beginning usually how I practice,
Yes,
I will tell. I usually suggest them to go for chemical peels first.
Okay.
So start with glycolic sulfuric acid peels.
Yes.
Then once all these papular lesions and all that they come under control, then what are the type of scars we have to look into?
Depending on that.
Yeah, depending upon the scars, we plan the treatment.
So, do we do comedone extraction in the first visit? Do you plan for that? Do you advise?
Yeah, first I start with medical treatment.
No, as a procedural thing.
For 1 month, I look with the medical treatment. If they're not responding, then I go for the comedone extraction. Usually, I don't do it in the very beginning.
Madam, you have any opinion to share on that, Divya, Madam?
I would go on with comedonal extraction usually simultaneously with my medical treatment. So that's what I would prefer.
One thing, yes, that's a good point. As Madam said, it differs because senior doctors we treat differently. Young doctors, we go more proactive. So that is why I wanted that answer. Now in this comedone extraction, be very careful. Don't do the comedone extraction on the pustules. If you touch the pustule with your comedone extractor and then you go to the normal comedonal acne, you will infect every comedone. So please be careful. Don't touch your comedone on a pustular acne. So this was done with microdermabrasion. This is what I did, microdermabrasion with comedone extraction and medical management. This is just one session. The whole patient improved within 3 weeks. So that's a faster clearance we can do. So, Madam Divya, Madam, about grade 2 acne. Do we go for procedure first or medical management, then procedure?
Ideally, I go for medical management to begin with.
When do you want to start the procedural thing?
Procedural, I would want the new concept of scarers is something in the back of my mind all through these days.
Yes.
So I just wait for about 2 to 3 weeks to understand the thing. And more importantly, these days I'm looking at the family history of the intensity of acne and scarring. If that is the scenario, I would be a little more active. Just combine chemical peels early to start with, maybe on after a priming of 2 to 3 weeks. So that, and I also go to a range of maybe these days I've become very pro isotretinoin. I'm not like, if they say it's a nodulocystic and severe grade acne only is isotretinoin. But I think I've gone non-conventional here. If I am seeing a scarring tendency, I am not backing to start an isotretinoin here.
Okay. So isotretinoin you might give if you feel that the patient might end up with
the scars.
Okay. And one key important point which Madam said was wait. First study the skin for 2 to 3 weeks. That is very, very important for all beginners. Don't try to do a procedure straight away on a grade 2 acne. So this is what we did, and I did a pyruvic acid peel with a little bit of there were milia-like formations which were removed with electrocautery, and that's the end. Yes, this is grade 3 and grade 4. Madhuri Madam, your choice. How do you go about it in procedural? Apart from medical management, I have given medical management for 2 weeks. Now I'm going to start something. I think the mic is not on. It's on? Yes, okay. Yeah, it's on.
In this left side,
yes.
We are seeing lot of inflammatory acne also.
Yes.
So in this case, after first proceeding with the normal initial courses of antibiotic along with the topical benzoyl peroxide and adapalene preparations, then we'll move on to, if there are any comedones, we will extract them, as she said, and then I'll proceed with the chemical peels. Probably the salicylic and glycolic, if at all some hyperpigmentation
Percentage,
is there.
madam?
Salicylic, I usually go double strength, sir, 20 to 40%.
Okay.
And glycolic, if very well primed patient, even I try up to 50 to 70% also. And next, I would like to add some mandelic acid preparations also, if at all the PIH is going to happen. And then in the other slide, they are grade 4 almost, nodulocystic. So there I would like to add initially, along with the regular antibiotic treatments, a little course of oral steroid, mild oral steroid for a few days, and also treat the nodulocystic lesions with intralesional steroids. And earlier I used to have IPL. I was using for these cases, especially in grade
3.
Yes. That is very useful.
Yes, very useful. Now, one key point to add in this is drain the pus in the first visit itself. Drain the pus out, then you give you antibiotic, you can give you steroids. Don't start isotretinoin straight away. This fellow will not let it heal properly. Start isotretinoin. After 2 weeks, in that time, you can do all your blood panel and things like that. So that's how we did this. And when the patient ends up with the condition, when it comes to an end with isotretinoin, immediately start on microdermabrasion, because the fibrotic scar is very soft. If you can do it, in 2 sessions you can actually transform the scar to this without any laser, no ablative procedure required. So you can actually shift it like this. So think that microderm is also a good procedure to do post isotretinoin. Madhuri madam, this one madam, acne conglobata.
Yeah. So this is only on the face, or is it there on the trunk also?
This patient had only on bilateral face and the forehead, madam.
Yeah.
This was the most...
yes. So basically, yeah, this is quite severe grade of acne. You have to consider acne conglobata and plan for pus drainage, number 1.
Yes.
And give intralesional Kenocort.
Yes.
Approximately around 2 mg per ml. And
how do you dilute, madam?
Normally what I do, sir, I take it in 40 units of insulin syringe. And if I want to do it 2.5, I take 40 mg per ml, sir. I don't use 10 mg.
Okay.
So I take 2.5 mg of Kenocort, and the remaining thing is xylocanoatrinolene.
Okay.
So if I want to make it 2.5 mg per ml of dilution.
Okay. So
that is how I do it.
How many units of Kenocort, madam?
So in this, sir, basically
no,
after
in that
the
syringe, how much you're going to take in a 40 unit insulin syringe? How much of Kenocort 40?
2.5 mg. If I want 2.5 mg per ml of dilution, I take 2.5 mg of Kenocort.
Okay.
Basically 2 units of Kenocort,
yes.
And the remaining is xylocanoatrinolene.
Okay, got it.
So that will come to 2 mg per ml of Kenocort.
Yes, ma'am. Yes, ma'am.
So after aspiration of the pus, we can give 2 mg per ml of Kenocort and simultaneously start with oral corticosteroids.
Yes.
Approximately around 0.5 mg per kg body weight.
Do we need isotretinoin for this patient?
Yes, you would definitely need isotretinoin, but not at this point of time.
Yes, okay. So
because if any comedones are there, we need to remove. So start
yes.
with oral corticosteroid around 0.4
yes.
to 0.5 mg per kg body weight. Continue oral corticosteroid for about 4 to 6 weeks. And by 3 to 4 weeks, we start tapering it. And after 4 to 6 weeks, we can consider restarting isotretinoin. So we can taper off oral corticosteroids by around 4 to 6 weeks, and then isotretinoin will take over.
Yes. So that's what we did. Whatever they said, that's what we did. This is after 2 weeks. This is after 6 weeks. And luckily, this patient, I didn't start on isotretinoin because she just improved. I don't know. She just improved nicely. And finally, with this, I just did a little bit of microdermabrasion. And this was end, and she didn't want to go for any scar treatment. But okay. So this case, we actually, luckily, the patient didn't need isotretinoin. All the other treatments which we did was very useful for it. Chandravati madam, this is a case of acne fulminans. Patient went to another doctor. Doctor saw grade 4 acne, started on isotretinoin. Patient ended up like this in 3 weeks. Immediately came and told the doctor gave something to me. My face became like this. Now, what do you first tell the patient, and then how do you manage this case?
Basically, it has increased because of the isotretinoin treatment. So we have to assure that the patient these acne lesions have increased because of the treatment. Yes, but we can take care of these lesions. First, I always start with an antibiotic first, always.
Yes, ma'am.
So take care of that, and then after that, some comedone and pus, something it is
Clean
there,
it
we
off.
have to take care of it, yes. And also a short course of oral steroids also helps very much in these cases.
So what madam said is perfectly correct. You need that steroid for this. Stop isotretinoin immediately. Why I asked madam, that is many of the juniors, when we start on isotretinoin, when they end up with this, they will go to senior doctors. So the senior doctor has to, you know, many a times senior doctors might put down the junior doctor, so we should not do that. Ideally we say it's just an exacerbation. Don't worry, this you are already healing. You just take this, you'll become all right. Because when you start on steroids and the antibiotic, immediately the patient recovers within a week. So the problem is solved. This is the patient after starting isotretinoin, after steroid therapy and things like that. Madam, any take on limicycline, madam?
Yeah, I do use limicycline also.
Do you like the product, madam?
Quite a
Yes.
good product, very good. Actually, sometimes when I see that when the patient is not responding to doxycycline, these things, I switch over to this limicycline. They do respond to limicycline.
Sorry, something wrong with the slide. Okay. Now, the role of BioLite. Divya, madam, you have anything to say on BioLite? That is including IPL and all those.
Yes, so very new to the curb. Only the LED domes
Yes,
are coming
yes,
up.
yes,
That's
that's
what I mean. I haven't ventured to speak about it so much right now.
Okay. Madhuri, madam, anything on that targeted BioLite treatment? Yes.
Yes, sir.
That is targeted, I want. IPL will definitely give the response because see, the thing is it works in millisecond pulse and it is given in a shorter course. It actually targets the chromophore much more intense than in BioLite. BioLite, you have to make the patient lie down for 30 minutes. Initial practice we have because we have a lot of time to treat the patient. We are jobless actually. But the patient be sitting in the OT for 30 minutes. We can't do that in serious practice. So that time, yes, it definitely you can use your BioLite and IPL, madam, Madhavi, madam, you are using IPL?
No, sir, I don't use IPL.
Madam, then you can tell IPL, madam.
So that blue light range is very useful. So usually we'll be keeping the power around, according to our machine, around around 15 to 20 joules, and the pulse width comes around between
Yeah,
5
madam,
to
that
10.
3, 4, 5 you can. Yes,
That's,
perfect.
according to the thing. And I call the patient.
What is the filter you used, madam?
Blue filter, sir.
Okay, okay.
I call the patient weekly once, sir. And in 4 sessions, we see that
Yes.
very good improvement is there in the.
One thing, I want just one small correction. If you're buying IPL for the first time, for a blue filter, start with 8 to 10 joules. Don't try to go 18. 18 is after you start using the machine and you have done more than 8,000 shots. So, because most of us would start doing IPL on acne only after hearing some of my talks. So, naturally, the machine is a bit old in that case. So, it definitely gives a good response. This patient was treated medically and with IPL. This is just in 20 days. The improvement in texture, color, pigmentation and everything. This is a very classic patient who actually was on topical steroid, but she refused that I am not using any steroid. This is normally it came. Then I told her, use this face wash, this one. She said, I don't want any treatment. I want some procedure. I said, we can do peel. I said, I've done enough peel. I want it out. So, it's a very difficult patient. This was the first patient in my whole life. I treated her only with IPL because rest all she refused. So in this case, we started with green and yellow light, and this is the response after 2 sessions. Now you see there are scars, you employ the orange light inside. So yellow and orange light, that is the filter I'm talking about. This is after 4 sessions. So you can actually improve a scar which is in formation. Please remember, IPL cannot treat a scar which has already formed, where you need ablative or non-ablative laser in that thing. So coming to acne scars, Chandradi madam, ice pick scars.
So,
First mode of treatment.
Yeah, I do TCA cross on it.
Yes.
Straight.
TCA cross is the only thing. Do you have any machines which you can, any lasers or non-laser machines which we can use on this?
I do a CO2 also.
Okay, CO2 fractional.
CO2 deep mode.
Okay.
The deep mode, I will give that small.
Yes, 0.12 mm spot size. Correct, madam? Yes. That's with the luminous systems. It's a bit costly, but that is a good thing. Next is any you want to add, madam?
No, sir. Except for TCA cross, I haven't ventured.
Okay,
anything.
you can add MNRF in this. This is where MNRF will be useful, and the new technology which I told about,
So
Tixel.
to
Tixel also.
interject, did you see a good result? Because I tried MNRF, but I was not very happy.
No, see, madam, you have to use 0.5 to 1 mm depth, and you should do the same area 5 minutes, 10 minutes, 15 minutes. That position you have to keep rotating in that area before you go to the next area with a low energy. I don't know which machine you're using, but on an average, we need to use around 4 to 6 watts. And if you're a beginner, please use a 49 or 81 pin. Don't try to use a 25 pin with MNRF. You will burn the patient as a beginner. Boxcar scars, I think you can tell. All procedures.
Yes, sir. Boxcar, the shouldering is one thing initially we start with.
What is shouldering? That is, you can use a electrocautery, or you can use even your CO2 laser to actually shave off the edges of the scar so that it doesn't have a big fall like this thing. You have a sloping edge. So you need to create that first. Then,
depending on the stretchability again
yes,
of the scar, let's just understand if there are any tethering.
Okay.
So subcision would help in some of them. And once that is done, I prefer doing a microneedling radiofrequency.
Yes, okay. So subcision is very, very important in this. The only problem with subcision is once you do subcision, patient will say my scar became big. That is because the scar is like this. When you do subcision, it becomes like this. It comes to the surface. And what you see on the surface of fibrotic skin, it is going to look like a bigger scar. You will need a procedure to improve that surface by making the epidermis grow into that fibrotic skin. For that, you need CO2 fractional, microneedle RF, and things like that. Yes, ma'am.
I usually do subcision.
Yes, ma'am.
And at the same time, I do CO2 laser also.
Yes.
Sessions at the same
Yes.
time.
Yes, it can be done. It is dangerous. I have done it. I will show you in the last slide.
For this type of scars, subcision, the same anesthesia I'll take to the laser.
Yes. Yes, if it's more, yes, got it. Yes. Punch elevation, punch flotation, there's a slight difference. Punch elevation, we don't cut the base. In punch flotation, we take the graft out, wait for 30 to 40 seconds, put the graft back slowly, and just put a micropore tape on top of it so that it is in level with the skin. The next one will be distensible scars. So, what is a distensible scar? You understand, madam, when we stretch the scar is not visible. That means there is no fibrotic thing which is holding it back. So, in that case, what all procedures you think will be useful in that, madam?
So, if it is a distensible scar, that means
Yes.
when you are stretching it, it is not
Yes.
visible. That means there are not much tethered bands there.
Yes, perfect.
So,
madam.
depending on the type of scar, basically, all fractional ablative lasers or microneedle radiofrequency will be useful, sir.
Okay.
Whether it is fractional carbon dioxide or erbium YAG or microneedle
So,
radiofrequency.
in this fractional laser, when you are dealing with the distensible scars, would you like to keep the dot space closer or far?
That would depend, sir, basically.
Okay.
Because erbium YAG in the machine which I use, I can't adjust
Erbium
the
is
dot
ultimate,
space.
madam.
Yeah.
Yes.
I cannot adjust the dot space, basically.
Yes.
But if it is distensible scar, if it is with fractional CO2, we can keep dot space far away, basically.
Okay. So, are you
And in microneedle
can you mention in
radiofrequency
millimeter, or you want to say in densities, madam? Like, is it 0.8 to 1.2, or do you want to use number of dots per area, madam?
I didn't get you, sir. I'm sorry.
No, see, the distance between the dots, if you're using a
Yeah.
CO2 fraction, would you like to
Yes,
keep the
yes.
dots far away or closer, madam? Depending on the scar and the energy you are using.
CO2 I don't use much,
Okay,
sir.
fine.
Actually, mainly I use erbium
Yes.
YAG, actually.
Okay, madam. So here, this is what we covered for this patient. This is where I use one small technique called tunneling. Tunneling is using this 1.5 to 2 inch gauge needle, 26 gauge needle you can use, and you just go in like you're doing a thread lift. You just like a fan thread lift from one point. There is a temporal nerve there, be very careful, touch it and then do it. That enough to volumize that scar. So please, that is one technique which you can do. It's just starting at one point, go in, come out, go in, come out, go in, come. Keep doing 3-4 times in the same area. This is only for the temples, very difficult for this area. But you can still do. There's nothing wrong in doing the cheek. But think, if you can learn this technique, your threads will become very easy for you to do. Now, keloids, hypertrophic scars, Madam, Chandraji Madam, both keloids and hypertrophic scars.
I always go with interlesional steroid injections.
Okay.
I give around, I start with 5 milligrams per ml IL steroid injections into this, and I see that how they are going to respond. Then next I'll plan for the CO2 laser also.
Okay.
These are the ways I do.
In any that 3 dose injection is there, na, madam, with 5-fluorouracil, hyalase, and this one.
I don't use 5-fluorouracil on the face.
Okay, that's a good point to take because it's for the body. That's what I wanted to hear. You can't use that there because it is given that it can be given in keloids. Please don't use that 5-FU there. It's very dangerous. It will scar badly. Correct, na, madam? So, coming to the algorithm of treatment, this is what we have been discussing on how to go about it. We can do different kinds of peels. Divya madam, any point on post-acne pigmentation? Because it's very easy to treat. What are the peels you suggest in that? What are the peels? Just the peels.
Mostly I start with salicylic for acne control. And glycolic is one thing I'm happy with the post-acne pigmentation, sir. And these days, Ferulac peel is something is my new
Ferulac
favorite.
is my go-to product. I started using Ferulac in 2007. It's a classic one. It's a beautiful peel for any beginner because it cannot cause a complication. It cannot cause a complication. It can only give results. That's all. But you have to do it the right way. That is the thing. Don't underdo it. So these are all the surgical and laser techniques which you can do on a mild superficial scar. You can take a snap of it. Why I put this is because everyone won't have everything, but you will have some of it. You can actually mix match these things to actually get the result you want. For moderate to deep scars, it goes like this. Peels were discussed, so we need the deeper peels to work. Derma roller also works. Remember, derma roller is a mechanical damage to the collagen. The remodeling of the collagen is not long-lived. Only a thermal damage can increase the longevity of a collagen remodeling. So derma roller is for just a use, but don't rely on derma roller for everything. Because I've used derma roller extensively, left it out in 2010. I've used only derma roller for now, only giving PRP for scalp, that's all. So these are all the options which you can do for for keloids hypertrophic scars. Yes, it's been mentioned. We have bleomycin also can be given, but preferably not on the face. Back acne, yes, we can try it. Little bit painful. Bleomycin is painful. Silicone gel sheeting is still a difficult thing. We all studied, we all started, but we don't like it because it doesn't stick there properly or the patient doesn't follow what you say. Now, non-laser approach. Anyone using microdermabrasion? Divya madam using microdermabrasion?
No,
Madhuri madam? Yes. So, microdermabrasion is a good tool, can be used. So, which all indications you think microdermabrasion will set in treatment of acne and acne scars? Madhavi madam, anything to add? Yes. Yes. Okay. Now, yes. Now, microdermabrasion, remember, it's all depends on the suction of the machine. If the suction is not there, your machine is not going to work. How do you find out it's not working? You move the handpiece like this on the patient's face. If the powder just comes and falls out, something wrong with the machine, you have not serviced it properly, you don't know how to service the machine. So every time after a procedure, the machine, if you are keeping it for 2 to 3 days in a stretch, you have to clean the machine, keep it without any powder, run the machine empty, without any powder in the canister for at least 2 to 3 minutes, then store it. That's the best way to have the microderm. Microderm can be used pre-peel. You can do a diamond dermabrasion and you can use Ferulac peel. You can use it for comedone extraction. You can use for wrinkles, superficial scars. All microderm works. You can even use, there is this hydrojet which comes with microdermabrasion. Anyone would have seen it. If you can do it on an old patient above 40-45 years, then give you a filler and see the response. It will be miraculous because the skin is well hydrated. Because in old patients, when we give filler, we need more volume. We need more volume of the filler. If you hydrate the skin, give filler, then again do this hydrojet, you have to see to believe it. The response is different from just giving a filler on a patient. So when you buy a microderm machine, see that it has got hydrojet. I'm not talking about hydrofacial. Hydrofacial is different, hydrojet is different, okay? MNRF. Madam, MNRF?
No, I don't have any.
Madam, MNRF?
MNRF with PRP is my favorite, sir.
Okay, so MNRF, your machine, does it have multiple pins?
Yes, sir, it does.
Okay, so do you prefer non-insulated or insulated needles?
I'm a rule abider right now because I've started very new, so I'm using insulated ones only.
Okay. Madam, any difference of opinion, madam? Okay. Mahadev, madam, anything? Okay. Now there is a debate. Now how to identify which is best? See, think like this. If you want epidermal remodeling, then use non-insulated. If you want only dermal remodeling, wrinkles, skin tightening, then go for insulated needles. Remember, there is something called time delay in MNRF. Meaning, if you enter a value, the needle will go in like a derma pen without any RF. Then it will come on. Meaning, it is piercing the epidermis without burning it. So naturally, that is where you add the time delay in a machine. So remember, your machine has time delay. Please see it where it is and find it out and use that parameter to your liking. And uninsulated is used by many doctors now. Non-insulated, insulated needles is becoming less, but non-insulated has become more in the recent times. And as a beginner, start with 49, 81 above pin. Please don't come to 25. You will burn the patient. You won't know how to use a microneedle RF. So please be careful. Microneedle RF can cause a complication. I will show you. Anyone who has done RF subcision, Dr. Somesh Gupta's technique, this is. I have not done, but I just wanted to know if anyone would have done it. It's a very new technique. Insert a cannula, and with your RF, you just touch the exposed part of the needle. It will actually cauterize inside the scar and burn out the fibrotic tissue. So this is like targeted, not sweeping inside fully. Because there was a company which brought out the RF you can put inside and sweep it out completely. Yes, it was good initially, but there were a lot of complications because of it. Sometimes you go too deep, there is loss of fat, the patient's skin actually goes inside. This is targeted RF subcision. Put a cannula inside, take a RF needle and touch it. The only problem is, this is that you see that exposed part of the RF needle, see that it doesn't touch the normal skin of the patient. You will burn there. So if you are putting a cannula, put a gauze piece under it and then put it, then bring an electrocautery needle, you will be touching it without touching the skin. So be careful of that. Pixel, yes, I told you about it. So we know that we can use that. Okay, this is a result of a microneedle RF. You can see boxcar scars, you can see ice pick scars. So this patient is not an acne scar, but we did CO2 fractional to improve a scar which was been there since she was born. Like a child, something happened to her at that time. We are able to improve the scar, but I am not getting that. That final touch I am not able to get. I am doing my CO2 fractional, not happy. Added 2 sessions of MNRF, it just boom, it went off. This is, I did in 2012. So that's when I started believing that MNRF has something to do with a betterment of a scar. So if you have both the technologies, it is very good. Nothing wrong in using 2 technologies on the same patient. So if you have CO2 fraction, you are not happy, wait 4 to 6 weeks and then review the patient and then put on MNRF. And as I told you, if your CO2 fraction is the only machine you have, please wait. If the patient don't have any response, tell them to come after 2 or 3 months, then have a look. Because some patients are slow responders. It all depends on the heat shock protein which they have. Now coming to laser approach. Madam, you have CO2 and CO2 fractional, madam?
I have CO2 fractional only.
Okay.
I don't use continuous.
Okay. So continuous wave was one which was used in 2003, 2004. I used it there, where we ablate the whole skin. Now since the fractional came, it's a different thing, but it ended up with a lot of PAH and scarring. So continuous wave CO2 laser we don't use. Sorry, the ultra pulse CO2 standalone we don't use. We use the fractional one. Now, where do you use, madam, you have any experience on these two? RBM. Madam? CO2 and RBM. Okay, so what do you think is, which is good? Why you should not compare both? Okay, yeah, I understand what madam is saying. Okay.
No.
Okay. Yes.
No, one
Madhavi,
thing
madam,
is
anything to-
Evitas,
Yes,
one
ma'am.
thing is HM glass is non-ablative.
Yes, I'm coming. I just want to get the idea of each and everyone. Madam, your idea, madam. Okay. Yes. You didn't like it. Yes. Now see, the thing is, because the company promoted it wrong. RBM glass is a non-ablative one. Can you combine both in the same case? Yes, you can combine both, because RBM glass doesn't do epidermal damage, CO2 does epidermal damage. If you want to reach the depth which an RBM glass goes without non-ablative, we have to use more power in a CO2 fractional, thereby you get more epidermal damage. So they said RBM is safer, but RBM doesn't vaporize the fibrotic tissue. If you don't vaporize the fibrotic tissue, we cannot achieve a good result in a boxcar scar. So in that case, a CO2 fractional is needed. But every patient who has boxcar scar is not only having that, he is having other kind of scars also. So in that RBM works. So you can actually do both in the same patient. If you have both in, because now machines come with both in the same unit. Any idea about using the quasi long pulse or the spectra mode or the genesis mode of long pulse NDAC, madam?
To decrease this, it's more like decreasing the sebum secretion has been like we're using the carbon and heating up with the quasi-long.
Yes.
About 2 passes initially and then blasting it off.
Yes.
So that the penetration is better into the pilosebaceous unit. So that's what we've been doing, sir. But there is also paradoxical increase with this. So selection of patients is still a little dogma here.
We are still studying on it. So quasi long pulse is not Q switch. It is not long pulse. Long pulse is in milliseconds. Q switch is in nanoseconds. Quasi long pulse is in microseconds. That is the difference. It is mainly used for dermal heating. So it is they proposed it to be useful for open pores, wrinkles, and improvement of minor scars. So yes, ma'am. Please. Are we audible without the mic? Madam,
Quasi-long pulse in genesis mode is very good for erythematous macular scars, sir, actually. When we are using as part of the laser toning, it's extremely good for erythematous scars, and in fact it also improves the superficial atrophy which is there. And what Dr. Divya has mentioned, the infusion and a little bit of acne flare, yes, it can happen for some people, but if we pre-prime them with any of the adapalene derivatives or do one salicylic peel prior and treat their seborrhea if they have and all, then the chances of acne flare is lesser actually. We can use it in very nice way actually.
Madam said as macular erythema scars is after acne heals down, you have this red circle, abnormal kind of things. Those are these macular scars, and that for that we need the quasi long pulse. If you don't have, your IPL green light and yellow light will help it. So if you're having IPL, you can use that also to improve it. So a CO2 fractional we end up like this. Chandravati madam, you tell me how to get rid of this. How we can prevent this, or what we should have done so that this doesn't occur on table, before procedure and on table.
The dots you are talking about? Sometimes
they complain of, sir.
Sometimes.
Not all patients, darker patients, people like my color.
Not all the patients. Once in a while, yes, we come across these dotty things. It takes longer time to go. That's what, of course, little camouflage, the time only will solve the problem.
Yes.
And some pigmentation removing creams and those things. That's what I do.
To lighten the surrounding area so that this doesn't look well. This doesn't look bad. Madam, any idea you have? Madhuri, madam?
Probably priming and all that.
That's a good point. I will come to that. Yes, ma'am. Correct. Perfect.
Reason. And on table, probably the power, what they have kept, and the
I did.
The spots. Distance between the spots, spots, and all those things also have taken care of.
Madhuri, madam, anything to add, madam?
So, probably determining the skin type basically based on Robert's pigmentation scale would have helped.
Yes.
And this was done in a exact grid fashion.
Yes.
There was no feathering done.
Yes.
If some amount of
Yes.
feathering would have been done, probably this demarcation would not have been there.
Okay, so you got the answer. Pre-procedure, we need to prime it. That is what Chandraji madam is doing. After the procedure, he had to do it. We do it before only, so that even if it occurs, we escape from it. Okay, so that pre-procedure with the retinoic acid, kojic acid, hydroquinone, you want to give you.
CO2,
Yes.
I always do it 1 month before.
Yes.
Otherwise,
So that's why you are not seeing it nowadays, I suppose.
But without priming, CO2 should not be done.
Yes,
Otherwise,
yes, perfect.
In our Indian scenario, PIH is so common.
Yes, North India no problem, South India very careful. And very important point on table is the feathering. If you do the feathering, it will merge with the surrounding. You will not have the demarcation line with the CO2 fractional. Now, this patient ended up with PIH CO2 fractional. Now, the patient was primed but still ended up with PIH. Anything you can do procedure wise other than creams. Remember, if you are giving a triple combination for this, many of us, our hand will immediately write that. If you are using it, tell them to apply for 30 minutes and wash only for 7 to 10 days and come and meet you. It will go off. Don't tell them overnight application. It will make it worse. Yes, ma'am. Anything else procedure wise?
Procedural wise, I haven't tried.
Peel. No, madam.
You said, sir.
No.
Okay,
I
peel
said,
is the only thing.
Other than medical management, I said. Peel
Peel
which
is
peel?
the only thing. I'm actually very happy with Ferulac these
Yeah,
days.
Ferulac spot peel is enough for this 2 sessions, but you can call the patient in 10 to 15 days and do for this. Twice spot application is fine. 5 minutes is there, sir. 5 minutes is there. Okay, I'm end of the talk, okay. This what happened, okay, I do MNRF on the other side, give the training doctor the MNRF and I went for T. He changed the parameters and he did this. This was very bad. I had applied epidermal growth factor region D. This is after 4 days, 5 days of region D. Patient comes like this. Marriage is in 4 months. Now, you get this complication. Patient comes and sits in front of you. What happens? Your face, I will look whiter than now. I look whiter than now. My whole throat is tough now. I cannot talk. My hand is sweating and shivering. Now, that is because we are looking it as a complication. Now, this patient doesn't come to me. He goes to, say, Madhuri madam, he goes. Now, Madhuri madam, you look at this. See, Dr. Avitas did like this. Madam, I hang marriage in 4 months. Please do something. Will you feel the same emotional, this thing which I felt? No. Why? Because now you look it as an indication. That is what I tell all my people. If you look at a complication, you look it as an indication, immediately your mind clears, you can do the next step straight, dead on. You immediately tell confidence to the patient. Don't worry, we'll fix it. Now, what do you think you can fix for this patient, madam? It's a bad case.
First thing I would like to address is hypopigmentation, sir, so
Okay.
that he feels comfortable with that.
Okay.
Next, for the scars which have become like more deeper and
Yes.
box scar type, we start doing subcision
Yes.
and then go for if a lot of atrophy is there, some topical silicone
Okay,
gels and all
okay,
will
okay.
also improve the thing.
Okay.
And
She said shouldering. Shouldering.
box
Okay.
scar, whatever we
Shouldering.
can do for
Remember that. Madhuri madam, anything to add? This I did microneedle RF, so don't say microneedle RF again because patient will now run off from the clinic.
So, if this scar is actually what we are seeing approximately around 10 days to 2 weeks post the procedure,
Yes, yes.
then probably the depigmentation or hypopigmentation is because of incomplete reepithelialization.
Yes, yes.
So in Indian skin, probably by 3-4 weeks, the D or hypo will become
Yes.
hyper.
Yes.
So what we can plan is we can align him, and usually our skin types pigment faster. So we have 2 choices. We can continue microneedle radiofrequency,
I'm
alternating
scared.
with erbium yak.
Okay.
Alternating with erbium yak, sir, so
Okay.
that
Oh,
there
yeah,
will be
got it.
color match.
Yes, ma'am.
And the atrophy will also improve. So when we are doing erbium yak, we can do the shouldering part. That is one option.
Yes.
The second option is basically...
RBM yak 2940.
Yeah.
Yes.
The second option is we can do microneedle radiofrequency, alternating with laser toning also, actually.
Okay.
Because that would help for if any post-inflammatory hyperpigmentation is there, that would help for that also.
Okay, so now what you heard, you have to have multiple lasers. Sir, I don't have multiple lasers. What to do now? I have only... Yes, you can try, definitely. If you have it, please.
Also is a good choice.
Wanted to add that, madam said that, good. See, now this patient has 4 months. So, I have already damaged the patient. No, I thought what to do now. So, I do subcision, shouldering, PRP and CO2 fractional on the same session. One session, dead on. Patient comes after 4 weeks like this. I am like, wow. No, sorry. There is one more. Oh, I lost the slide. This is after the second session of that. So this is after 2 months. So sometimes, and PRP, please remember PRP is something which helps. Don't discard it as a myth. It works in some cases. Better give it to the patient. If it works for him, he is lucky. Okay. So we still write our names in small cards and put it in every booth, hoping that we gain a prize from the booth. So we do that. Might as well give a patient a chance of that also. Now this hypopigmentation. Now the scar from this bad to this bad has improved in 2 months. God's grace, touch wood, it would have even gone worse, but something it worked. Because we just used the basic ideas which we developed from whatever we have learned. This hypopigmentation, how to treat?
One is I give tacrolimus.
Okay.
And then I think targeted some eczema, you
yes,
can use it.
that is the answer. If you have targeted phototherapy, you give it 2 sessions, it will become all right. Sir, I don't have targeted phototherapy. What you can do? 2 hours all, sun exposure. Put 0.5 ml in 1 liter of water, mix him and give him, don't tell him what it is. Give him in a small bottle, tell him to touch and apply in those white patches with the Johnson's earbud. Every 5 minutes, 3 times, and then expose in the sun for 10 minutes. Within a week or 10 days, this will repigment. Luckily, there was not much damage to the hair. If the hair was damaged, then the repigmentation is very difficult in this case. So last, Madam Chandradi, Madam, anything to add to this, Madam?
So,
Like if an acne scar patient comes, if we have missed out any points, if you want to say something.
no, acne scars comes, each patient is, individual patient is different, so we have to treat them in a different way, and depending upon the stage and all that, and also depending upon the patient mentality. That is also very important, whether they want the procedures, they don't want the procedures, all these, so many factors are there. You have to see those factors and then you have to treat accordingly.
Counseling, that is what Madam is saying. Counseling is very important because the time factor has to be told to the patient. Sir, I am having this military selection in 10 days, please remove this scar. No, don't attempt it. Tattoo removal, don't attempt it. You can't do it. Don't even tell the patient I will try. You tell them you give me 4 months, 5 months, I will do it, or else can't do. You attend the next interview. Don't go this time. Madam, any message for the youngsters when they start? If you want to talk about finance also, you can talk, or you want to talk about procedures, anything which you felt was difficult.
Procedures, once I understood is, I ask what is bothering more to the patient when especially touching scars. Because I see one thing and they see the other thing. So I rather start with tackling what they want first. That's all it is.
Madhuri Madam, any final words?
Pre and post photographs are very important.
Very important. As a beginner, they will not trust you. You know, when we do HIFU, I do half the face, show them in the mirror. Do you like it? Yes, I will do the other side. You do the whole face and show the mirror. I look the same. It's very sad. So even in procedure photograph also is needed. So before, in procedure, after procedure, and sometimes after becoming better, they don't come. But at least you will have a record to show the patient. It happened to me because there was even the patient brought police to my clinic because hair removal was not. They said hair has grown much. I had all series of photographs. She was looking like a man. When she came back, she had lost 80% of the hair, but she complained that the all hair was still there. I showed it to that fellow. The police just walked off. That's all. The case was over with just the photograph. Nothing was added. He just shouted at that lady and took her out. So always have photographic evidence. Madam, anything last to add, Madam?
So for acne scars, what I feel is important is basically treating the existing acne and preventing new acne formation.
Okay.
Because for scarers, even a tiny comedone also must matter.
Okay.
So we are treating old scar, they develop new acne, new scar, ultimately they will not be happy.
Yes, perfect.
So preventing and treating scar, new acne and using oral isotretinoin in a right way is very important. Judiciously, basically.
Be
because
very careful with isotretinoin.
It would add to the collagen benefit. It would add more to the improvement of the scars.
Please don't write isotretinoin just to get a name. I wrote this patient became all right. Patient said, oh doctor, you saved me, I suffered for some. Don't give like that. You give isotretinoin only to a deserving patient. Don't give for everyone because there are a lot of complications in isotretinoin. I've seen every possible complication. Even attempted suicide has come to me. So it is very difficult. Please be very careful with isotretinoin. So to conclude, time heals all wounds and pains. That is the quote. A wound heals, but the scar remains. That is also a quote. But try to treat the scar and see what the patient gains. This is what we are trying to establish today. And I thank all the wonderful panelists for giving out all their views beautifully, clearly, sharply. And I hope that the audience have benefited from this panel discussion. Thank you, organizer. Thank you, sir.
Thank you.
Thank you, Dr. John Avitas. Thank you, Dr. John Avitas, for excellently moderating and showing us all your own patients' pictures. They're all nice session. I would like to thank all the panelists for their wonderful presentations. Now, we'll go on to the next session. For this, the moderator is Dr. Anup Kumar Lahiri. So this is, he is going to moderate on scars, keloids, and
Thank you, Dr. B. N. Reddy, for inviting me and the organizers for doing that. I would like to call my panelists. I think the CV is not on, so Dr. Satyanath is a consultant dermatologist and one of the leading practitioners from Hyderabad. Okay, Dr. Anand is consultant dermatologist working in KIMS. He is more known as a hair transplant surgeon. And Dr. Jyotsna, she is a trained dermatosurgeon and quite a senior practitioner in the Secunderabad area. And Dr. Rakesh, is he around? Yeah. I think it's a request if you all can get rid of your mask because the audio was not audible when they were talking. So you can take a chance, all are vaccinated. So our discussion today is on scars. And there is a little bit of overlap because I am trying to include all the scars which are commonly faced in our day-to-day practice. And so acne scar is one of the most common one. So we will just brush through it and probably we all can add a little bit of what has been missed by the other panelists. So this is box scars. We have already discussed or heard the previous panelists talking. Can you add something to it?
Can we add John also?
He has done his part. I think you should now add to whatever you can do to that. Anyone can take up what you can add to what has been already told?
So few techniques like punch flotation.
Okay.
And recently...
Yeah, punch flotation, punch excision, fractional, subcision has all been discussed. Anything more you need to add?
Plain PDO threads in that area in a crisscross fashion to increase the collagen input in that area.
Okay. Using PDO thread in a crisscross manner, it will give a general lift to the area, so it will shallow the depth.
Yeah,
Anything
it will
else?
stretch the skin.
Let's make life a little bit simple. I'd rather first do a derma rolling, subcision followed by derma rolling with vitamin C serum.
Okay.
Watch it for about 6 weeks. If the scar is improving, do another session of that.
Yeah,
Then we can
we
go
all know
for
that it's a
lasers and-
multimodal and multiple settings, so we would need to do that. Anything, Dr.
And
Rakesh, you want to
MNRF
add?
would do quite a
Yes.
good.
MNRF will do good.
Pretty similar, sir. Subcision followed by derma roller. Maybe we can add even a little bit of PRP sessions for give the patient a chance.
PRP is a new addition. If
So we
you
have-
say, yeah.
We have superficial fillers also used for filling up these acne scars whenever there is an urgency in treating. Whenever a patient
Okay.
lands up in the last moment before the occasion, I do fill it up with a filler.
Yeah,
So do a subcision and then
in
fill it
cases of when they have some D-Day like marriage
Yeah,
or something,
yeah.
we can do that. Regarding MNRF, I just wanted to ask something. Do you use MNRF in the single parameter mode, or you change the parameters as you change the pass? Dr. Satyanath, when you're using a parameter,
I prefer a single parameter.
okay. Have you heard of double layering of
Just
the
now
MNRF?
John said that we can do in two parameters.
Yeah. So if anyone doing that in two
So
parameters?
I do it in two parameters, sir.
Yeah, can you give a little bit detail to the audience?
So whenever we see different type of acne scars, like box scars and then superficial stretchable scars, so I do one pulse. I vary the depth of the needle depth so that we are dealing with both the superficial and the deeper scars. Collagen remodeling happens in two levels over there, just like doing a subcision in two-level way. So microneedle parameter change in depth also adds up to the results.
And do you change the fluence also, or you keep the same fluence at both the
I
depths?
usually change only the depth, sir, not much with the fluence.
I think it's better to change the fluence also when you are doing a shallower depth, because otherwise it may cause more pH, which is not at all seen in MNRF, but if you do like that, it will. Second is, what type of needle would you use? Do you use an insulated needle or a non-insulated needle when you are doing this? When you are doing an MNRF in bilayer or two layers, your preference is an insulated or a non-insulated needle?
Insulated needles, sir.
Can you explain why?
Because I feel the pH part will be more, like as you have mentioned, energy part I am not changing, and I am not using a non-insulated laser. The epidermal burn might be more and I might end up in pH, so I usually prefer a insulated needle in such cases.
Yeah, because in insulated only the tip remains uninsulated, and since we are moving the depth, so we are using only that part of the needle to heat up. Though in research they have found that both insulated and non-insulated needle, the middle part of the needle gives out the maximum heat. This is the second one. Don't ask me the answer how we deal. All of them are linear scars. I don't know how we manage. So any opinion on this?
These linear scars you can exercise also. You can exercise.
Pardon?
The linear scars you can exercise and put stitches also. 6
But there are so many of them. How many will you excise?
So we can initially try a
Big one.
subcision, sir. They all look fibrotic
Yeah,
and pull
subcision
down.
is the sheet anchor for everything. We do a subcision. Then
So after subcision, I feel we can do a pressuring up with a RF cautery probe, and we can use a adhesive glue also for some time to close up few scarred areas.
But
Or a
okay,
single
you want
full
to make the depth raw and then use adhesive glue.
adhesive glue and
Okay.
close it up with a collagen sheet or a PRP.
Anything else?
RF subcision, right?
Yeah.
Followed by fractional CO2.
Okay. Have you heard of chemoabrasion? Would you like to do
Enlighten us,
that?
please.
TCA, sir.
Yeah, abrasion followed with chemical peel. So the depth of the peel is increased. So you may get some benefit when you are doing that. Like either you can do a diamond phase microabrasion followed by TCA or Jesner's peel, or you can do even fractional CO2 and then apply that thing so that it penetrates it. So you get a medium depth peel. So that may also improve sometimes. So this is a, you can say, grade 1 scarring because mostly it is macular. There is no depth or no change in morphology. So how will you manage? This patient was, there are few scars, but the patient is more interested in getting rid of the redness. So what is your choice of treatment?
So I usually prefer IPL for such cases.
Yes. So IPL vascular filter 560 will do a good job. 4 sessions, early every 3 to 4 weeks, we can get a good clearance of this. Anything else? If you don't have an IPL, you can try an anti-inflammatory peel, salicylic acid. That may help sometimes. These are not ice pick scars. These are, many times we see that there are shallow pits which may not be related to acne. We have seen many cases. How do you do that? How do we manage them?
CO2 pixelated or MNRI.
Okay. Anything else?
So I prefer, as you mentioned, the microdermabrasion with a TCA.
Yes.
Or a PDO.
Or
PDO threads.
Okay. Yeah, you are very fond of threads, I know that. Okay. Yes, and even again, I would prefer to do sequential or combo peels when using either TCA, GLA or Jessner's and TCA and all. So that will, in multiple settings, will cause some amount of smoothing of the skin. We may not be able to get rid of completely, but much better than what it is there. Okay, these are another common things which we see. This looks inflamed, but these are actually cystic lesions, small cysts we see mostly on the nose and chin areas. How do you manage? Other than the medical, we give isotretinoin, we give topical antibiotic, anti-acne preparations. Other than that, they don't go. Then?
Radio frequency?
Yeah, what do you do radio frequency? You shave it off or you, what do you do?
No, we target each lesion inside.
Intralesional radio frequency, yes. Anything else?
Sometimes I do intralesional RF followed by micro doses of intralesional steroid also.
But nose, madam?
Only into the cyst, just to cause some atrophy, mild atrophy in that area.
You said steroid, triamcinolone.
Yes, sir.
That would be
10 milligrams.
10 or 5?
Usually I go with 10, sir. Never went with 5.
Actually 10 is a bit too high for 2.5 to 5 is the maximum what we can do.
Okay.
But yes, maybe if it works for you without any complication, good. Don't ask me what those dots are. Those are technical problems. So the next one is this. So this is how it was adjusted. So RF shave was done in this case, and this is how it looked in about 10-15 days time. And finally this was the result we did in the RF shave. So each bump was shaved off to the skin level and allowed to heal with secondary intention, and this is what was the results. Now, these are again another case of cystic lesions on the chin, which is a very common thing. What all can you do? What we have already discussed, other than that, what all can we do? I think we can add MNRF in this case. And another method is, I'm just showing it on the other area. You can enter each cyst with a small needle like an insulin and then coagulate it using an RF. You touch the needle, so the inside part of it coagulates and it closes. Okay. Now, this picture may or may not be very clear to you, but there are bizarre large scars, deep scars on the cheek. Other than fillers, which will be a temporary thing, what else can you do?
Excision of the scars and rearrange them along.
They are too big scars. If you see them, they are almost a centimeter or 2 wide and 2 centimeters length, some of them. Excision is probably difficult. Anything? Fillers is one, okay, it will give you immediate relief, but it will not last
First
long.
would be RF subcision.
Okay, yeah, subcision is must.
We'll have to
in all
do
of
a
them.
subcision.
Yes.
Maybe the last scars can be excised and sutured back.
It is difficult. Actually, this is not so clear, but in practice, the scars are too wide to excise.
Okay, we do a subcision, then we do an MNRF or CO2 pixelated, multiple sessions. It should improve only by 50%, not more than that.
Okay. What I did for this patient was, I did a dermabrasion, electric dermabrasion under GA, and if you are seeing those lumps of flesh, those are dermal tissues which is taken up from the thigh, and the depths are filled with the dermal tissue, and the dressing is done over it. The dermal tissue is taken up on the grooves, and they shallow the depth of the scars.
So this without dermabrasion, can we insert it like subcision?
We can do, but there were too many of them to do. So easier was to dermabrate and just lay the graft on that. And this is how it looked. This was a fresh picture, so the color change is still there. They will regain the pigmentation. I won't say good, but at least we got a more than 50% improvement on this deep scar. The scars in original looked much bad. This is a traumatic scar. She fell down from the scooter. How do we manage? And this almost similar case was run by Avitas.
She will require an Z-plasty.
No, there are multiple scars. There is no pointer here. There are multiple scars in a zigzag manner.
So I prefer to do fractional CO2 and in between PRP sessions.
Yes. Fractional CO2 and PRP will make a difference in these cases. Now this is a post-burn scar on the neck, chin and on the front of the chest. What can we do? What all we can try? Pardon?
Refer to plastic surgery.
That you can do when you have a Range Rover. Otherwise, you can't.
You have to relieve the scar. First.
Yeah. Some of the points where there is contracture, you need to do a Z-plasty there. But on the whole, as a dermatologist, what can we do from our level? But such a large area, whole chest almost.
So I usually do fractional CO2 and triamcinolone little bit only on the flexion areas, thicker areas. And after few sessions of fractional CO2, I do Q-switch laser to target the hyperpigmented areas.
Okay.
And in between PRP also helps out in dealing with this.
Now, this is the difference. This patient I treated with fraction laser initially. After 2 or 3 sessions, I didn't find much relief, so I added PRP to that. So you see the rejuvenated skin on the other side. If you see the cosmetically, it is much better looking than the previous scars. So fraction laser followed with PRP. She is still undergoing this. She comes once in 3-4 months to get the procedure done. So fraction laser with PRP is improving the texture, the appearance, which is what she is looking for. Now this is from Dr. Rakesh, a yellow keloid. So you tell us what you have done.
So this is present both on the anterior and posterior surface.
Okay.
So like a bilobular. So I had done a fillet flap repair for this case, in which we raise a flap. We raise a flap so that there is no requirement of a graft from other place. The flap is raised from the skin covering the keloid tissue itself. The keloid per se as a core is extracted and the flap can be used to recover the surface. The advantage with this is that there is no tension because the flap is sufficient enough and the wound closure will be appropriate. And because we are closing the wound perfectly, the chance of secondary infection or a reoccurrence of keloid is very low.
So can you tell me how you have taken the flap? Is it from the periphery or center? How do you have taken it?
In this case, I had oriented with the base of the flap posteriorly and the tip of the flap in an anterior fashion.
So it's like a flap from the kettle.
Yes.
How you see, it's just a flap. You need to do a C-shaped incision all around the periphery, leaving a hinge, and then raise it and remove the core. The only problem with this fillet flap technique is you need to be careful when you are removing the skin or separating the skin from the core, because you accidentally, you may, if your hand shakes a little, you make hole in the flap. So that's a risk. So I modified this technique, which I will show you later. So in this, the idea is to remove the fibroproliferative core, which is the one which will cause the recurrence. So this is how the flap was taken.
Also anterior and posterior?
So it depends.
No, he has done it from one side.
If it's a very large flap, then there is a chance of tissue necrosis in the end of the flap. So in that case, you can make it half from anterior, half from posterior, and suture it in the middle.
Excessive skin will cut it.
Excessive skin will trim it off, sir.
So
and for these kind of ear
this
keloids,
is the classical fillet flap, but you can modify if you want to avoid necrosis.
Yes, sir. Good thing is, even if there is necrosis, the chance of recurrence is very low.
Recurrence is very low in these type of things once you remove the core tissue. So this is how it looked in the end.
This is almost after 2 years, sir. 2 years post.
So many a times in auricular keloid post-core excision, you may not even need intralesional steroids. So that is one thing good about this thing. You may even, maybe 1 or 2 you may need initially, but after that, most of the time you don't need them.
Any other non-surgical options for that cases?
See, such a big nodule, you can't do intralesion. I don't think anything will help. One.
Sir, I have tried fractional CO2 followed by intralesional steroid in multiple stages for such cases, and even larger than these lesions, sir. And there was not much recurrence. I went in stage wise, once in a month, abrading a little bit and preserving the overlying skin. So I used to scoop out with a CO2, burning the internal core tissue.
No, you have removed the core tissue, you are keeping that, you are ablating.
Only with CO2, not with any surgical.
Yeah, I know. With CO2, have you removed the core tissue or you have left the core tissue and ablated it?
No, core tissue I am ablating in a stage-wise pattern with intralesional steroid.
With fractional?
No, CO2, plain CO2.
Plain, continuous mode?
Continuous mode.
Okay.
And maintaining, preserving the
So
external...
you have opened the epidermis,
yes,
ablated the core?
Yeah.
Okay.
And went on till the base in stage-wise pattern, checking with intralesional steroids. And at the last, either I completely abrade till the surface to maintain the shape, or if required, I do a small suturing with the left-out skin flaps.
Okay. Can you tell me what is the advantage of CO2 over surgical excision?
So it's my, CO2 is my fancy subject, so I usually venture out with it.
Other than that, anything science behind that?
No, sir. It's a probably comfort for the patient also, because no need of the bleeding.
No, CO2, in addition to what you are doing, it also reduces or inhibits TGF-beta, as well as prevents deposition of type 1 collagen. So that's an added benefit when you are using CO2 instead of surgical excision. Yeah, Anand, you wanted to say something?
I did intralesional radiofrequency sequentially, like
yes,
once in a week.
That
like
also works, but only risk here is the cartilage is quite nearby, so that is a chance.
We can even do a intra-regional cryotherapy.
Yes. But all these things, we have a problem about the cartilage being nearby. We can do probably for the lobe. Earlobe we can do, but near the helix it may be a little bit difficult. Okay, the next case. This is a big keloid on the shoulder area, and this is a sessile one. So if you excise it in toto like a shave, you will have a big raw area which you will not be able to close its first as a primary closure. You have to leave it open. Chances of recurrence of keloid becomes very high. So what can you do? This is almost maybe 6 centimeters by 4 centimeters size.
Post-excision radiotherapy we can service.
Post-excision radiotherapy. How many of us do send for radiotherapy?
Low dose radiotherapy we can.
Yeah, that's theoretical, yes, but we have no source to refer so easily for a radiotherapy. Anything else?
Using intralesional steroid or bleomycin reduce the size and later on.
You see the size. When will you? You will take a 5-year plan. for doing this.
So I prefer
Pressure
international
dressing.
cryosurface.
After excision, you can recommend pressure dressing also for a few weeks.
Okay. Rakesh, you should come out because you have done one. You can do this also.
But this will require much bigger flaps, sir. Maybe you have to harvest the flap initially and
You
then
have to
transpose
modify
it.
on table. This is what I did. You make it into quadrant. Do like a cross. Each flap you remove 25% like on each side. Remove the whole core and then trim the extra tissue and suture it. So the size will not, you need not always go like a book that you need to do a fillet flap or you can make your own changes. So this is how it looked after a few months, and it is still maintaining the same size. Of course, he is needing intralesional steroids in between. Every 2-3 months he comes and takes the intralesional steroid. So patient is very comfortable able to wear his shirts without a problem. He is still coming. Every 3-4 months he comes for intralesional because it is growing. So, but we are able to maintain a smaller size than what he had, so he is more comfortable.
Does a pressure dressing help?
Yes, but keeping on a shoulder area is difficult to have a pressure dressing. So that is a problem. If it is on the extremities, we can do it, but this was on the scapular area, so keeping a pressure dressing on that area becomes difficult. Now, this is what I was trying to tell. I do in a different way. This is a bilobed, one is on the anterior, one is on the posterior. It's a earlobe keloid. Here, what I did is I did a core excision, same as what Rakesh did, but here I split it open like how we do a sebaceous cyst. So I did an elliptical incision on the summit of the swelling, and then removed the flap on either side, removed the core, and sutured it. And this is the healed one. Believe me, this patient is almost 10 years old. Post-surgery, not a single intralesional was given to this patient. She was maintaining without an intralesional injection for so long. So we can do either a fillet flap if it is a smaller size one. If it is bigger, you can do it from elliptical one. You can excise it from the sides and then remove the core. Usually I add to this, when we remove the core, post-core session, I give a 5-FU soak into the pit so that will destroy whatever leftover fibroproliferative fibroblasts are there. So maybe with that 1 or 2 minute soaks we give and wash it off, so that will add to your prevention of recurrence. 5-FU soak. In a gauze you wet 5-FU and pack that thing, keep it for 2 minutes and wash it off. And always, whenever you are doing a keloid surgery, always better to combine xylocaine with steroid when you inject. That will prevent the immediate relapse what you get, recurrence. Now this is what I wanted to show you. Pardon? Yeah, please.
Similarly, bilobed keloid, recently I have done with a fractional CO2. So initially I have given intralesional steroid 2-3 times to shrink the size of the keloid so that the overlying skin becomes little flexible. So I started opening at one end, similarly destroying the core tissue with a fractional CO2. And I reached till the base. I sutured the skin surface, but simultaneously after 2 weeks I started doing fractional CO2 with the intralesional steroid every 2 weeks because I don't want that core tissue or any of the remnant keloid tissue persist in that area. So I started resurfacing again that tissue with a fractional CO2 with the intralesional keloid. So this
Okay,
has done 1 month back. I should wait for the results.
Yeah, so the multimodal approach, whichever giving results, we can follow it up. Now this is just to show you. Yeah, Rakesh, you want to say something?
But if we intend to do a flap surgery, it is better to avoid intralesional steroids initially, sir. Otherwise, I find that the skin is very thin. The flap keeps tearing and it becomes very difficult during the surgery.
There is a thing, because when you are giving a steroid along with the xylocaine, you are reducing the proliferation of fibroblasts, you are reducing the collagen synthesis, you are reducing the glycosamine formation, which will happen immediately in the healing phase. Okay, so that is what we want to avoid. You don't have to give 40 mg, you can give 10 mg of Kenacort mixed with xylocaine in equal amounts. It works. This is a standard practice of doing surgery for keloid. Now this is what I wanted to show you is how to do radio frequency, intralesional radio frequency. We can use a vein flow. The size will depend upon the size of a keloid. Introduce the vein flow into the tissue, and at the base of the thing where the plastic covering is there, just scrape it out so that your needle is exposed, and touch that needle, the metallic part, with your RF needle. And the end point is seeing whitening of the tissue on the top. That is that there is enough coagulation. And then post that you inject the Kenacort or 5FU, whatever you want to give. So that syringe is attached which contains the Kenacort. So this is the result you see in the same case after about 3 or 4 sessions. The ulceration, what you are seeing, this is probably at the point of removing the needle. This is because this patient was given 5FU and that caused that ulceration. So while pulling off the needle. So this is a good method. This is giving good results. So coagulate with radiofrequency and inject the steroid or 5FU, whatever you want to give.
Is there any specific ratio you are using, combination? Like 3:2 parts or something?
No, if you are using 1:9. 1 is the steroid, 9 is the 5FU. Okay. Now what do you do in multiple keloids like this? We can't give intralesion because there are so many, you may finish 2 vials in one session. So what else can be done?
Try other intralesionals, sir, like bleomycin with multiple puncture, although it's a little painful.
Okay, you want to give bleomycin. How many units will you give in one session, bleomycin?
Not to exceed 2 or 3 units.
Okay, so 3 units, your vial is 15 units. You dilute it with 5 ml, you get 1 ml. 1 ml, 3 units bleomycin. Can you finish all the keloids?
1 ml, 1 unit dilution, not to exceed 3 units. So maybe with 3 ml.
Yeah, see, 15 unit is the vial. You dilute with 5 ml, you get 3 units per ml. So many of them are there. How much can you inject? That is our problem here. Your one session of bleomycin should not exceed 3 units. So we cannot, I don't think we can fulfill all those things with that small quantity.
Intralesional cryo.
Okay, for so many of them, you will be
Do
sitting half a day with the patient.
Do it in sessions, not everything at once, because the pain also
No,
will
the
become
problem
intolerable.
Is, if you do in session, by the time you come to the second session, the first one grows back. That is a problem we are seeing. See, have you heard of using topical in like tattooing method or pricking method? You can do that. So you can do either, you can do a dermal roller and then apply 5FU on the top or a Kenacort on the top from the micro pores that have opened up. Some amount will penetrate. So the quantity you are using for this will be much less. It may not give you results as good as an intralesional one, but when you can't do anything, at least something can be done with these things. Either you can do dermal roller or you can do a laser. That's what you call as laser assisted drug delivery. You can do a fractional laser and then apply the corticosteroid on that or 5FU on that. And they have been saying that though there is lots of controversy about the time duration the pore remains open. Okay, some say it is few seconds, some say few hours, some say it in few days. So benefit of doubt, I usually do is after this I ask the patient to apply a potent corticosteroid for 1 week, twice a day post this procedure. So that helps sometimes. Now this is from Dr. Satyanath. What will you do? Probably pressure garments, and you can probably try the same tattooing method. You can even, I forgot about bleomycin also can be used. It gives very good results. In fact, they say that bleomycin gives better result than 5FU in case of doing pricking method or tattooing method or even in intralesional. So you can do in a limit.
This case was a small child.
Yeah, that we have to find a solution for in some way we can do. Just 3 minutes. Huh? Okay. This is another linear scar on the cheek. How do we manage? I think we have to rush through it. He has already gone through scar revision. This is following scar revision. Again, it widened up because the movement area, so it will widen.
So one thing is when you're doing the scar revision, even subcuticular buried suturing is also advisable, sir, because of all the...
They always do two-layer suturing. One is subcuticular, subcutaneous, and this thing. So in spite of that, because it's a movement area, it widens over a period of time. So he didn't want to go through re-excision and suturing again.
He's an ideal patient for subcision followed by PDO, sir.
PDO. How will you close the gap on the surface?
No, sir. It's only like probably with a fractional CO2 resurfacing and a little bit of shouldering, we can improve the efficacy of that part.
Dr. Avitas, if he's here, he is told that fractional CO2 on the cheek area doesn't work much good as compared to the forehead and temple. I did a dermal grafting, removed the dermal tissue from the thigh and pushed it underneath the groove. 50-60% improvement is seen on that. This is how the dermal tissue is taken. The epidermis is dermabraded, dermis is taken up in slices and then pushed underneath the groove.
Sir, your experience with PRF in such cases, sir?
PRF, somehow I find, by the time I inject it gets solidified, so I've given up that doing. I don't know, probably I'm missing some steps, so I don't do PRF. PRF will also work. It's also good.
Fat grafting, sir?
Yeah, and fat grafting, yes. This is a zoster scar. What can you do for her? I think you have to rush through. I've already rang the bell.
Fractional and Q switch, sir.
Yeah, fractional, Q switch, even cross. TCA also can be tried. A little bit of improvement after TCA. I did TCA in this. This is another from Rakesh. What can you do?
This I found. It's tough to even resuture it. So because of the size of the scar. Need your opinion in this.
You need to do a serial excision, I think, first thing, because we can't get horizontal, it is difficult.
Yes.
You need to do a vertical, maybe vertical we can do, but then the eyebrows will get closer, so there's a chance of, I think better is to do a serial excision, remove in vertical manner, half and half, so it should give you probably results in a year's time.
Even CO2 fractional.
But the depth will not come up so much.
How about punch elevation in such cases?
It's too big to get a punch. Multiple punch elevation you can't do. It has to be in the border of your shoulder. This is a stri. What are the modes you treat? I'll show you some more stri. We have to finish faster. So how do you do, what do you treat stri with? Okay, MNRF, fractional CO2, and do you follow it up with something or just do that? No, on the same session. Tretinoin is for application, yes. We can add TCA. We can add TCA to that, 15 to 25% TCA post-fractional or MNRF. That gives good result. In about 3 sittings, you can get result.
As a peel, sir? Is it as a peel, sir?
No, you do fractional and then follow it with the TCA application. This is a post-steroidal wide scars, very commonly seen in the practice. Again, probably we can do the same thing, follow up for this. I should close up. My next. This is for Dr. Josna because our favorite is earlobe repair. Now the patient wants to wear earrings immediately after repair. How can you do? How can you retain the hole after closing the? This is the last one. Thanks. After closing the extra thing, how will you retain the hole?
So ideally it needs to, if we want to retain the hole at the same place, we need to do a flap rotation technique in that area, sir.
You are making it too complicated. Anything simpler?
Or else usually don't.
See, this is what you can do. Close partially, put a IV cannula for pediatric IV cannulas are there. Put it there and close it. Let the cannula be there till you remove the sutures. The hole will be intact. It's a much simpler way. Thank you.
Thank you, sir.
Thank you, Dr. Anup, for excellently dealing with the scars and keloids. And I would like to thank all panelists, Dr. Rakesh, Dr. Jyotsna, Dr. Anand and Dr. Dr. Satyanath.
Chalo.
Old
Thank
age.
you. Thank you all my panelists.
Now I invite the chairpersons for the next session, Dr. G. Manmohan sir and Dr. N. Ramesh sir, for the session 3, pigmentary disorders. Please sir, come on to the dais.
Hello. Good morning. Once again, welcome all the guests for this pre-conference workshop. This is the third session. Yeah. The third session, we have two parts. The first part would be moderated by Dr. Sujala Aradhya. I invite Dr. Sujala Aradhya onto the dais, please.
Excuse me, the tea will be served continuously. Please stay here, so the session will continue.
Dr. Aradhya, is she here? So we'll go ahead. Yeah. Since Dr. Aradhya keeps us waiting, we'll go for the next session by Dr. Sanjeev Aurangabadkar. I invite Dr. Aurangabadkar to be the moderator for this session.
Okay, fine. Back, right.
Yes, Dr. Sanjeev, you can go ahead and inviting your panelists.
A very good morning, everybody. It's a pleasure to be here in Telangana CUTICON 2021 at the fag end of the year. It's good to have a physical conference and to see all the faces in front of you rather than seeing on a small screen. So I welcome all of you for this interesting panel discussion. I would like to invite my panelists who are Dr. Gurunadham from Khammam. I hope he's here. Dr. Gurunadham. And also I would like to invite Dr. Madhavi, Dr. Rekha Singh, Dr. Swapna Priya, and Dr. Venukumari. So I hope my panelists are here in the hall. There has been a bit of reschedule, so I guess we are moving a bit ahead of time. And I request all my panelists to be on stage. Dr. Bhumesh, can you check on Dr. Gurunadham? He's supposed to be here. So I think we have 3 ladies over here and we are waiting for the gentleman to arrive. So I'll give him another few seconds. If he's not on stage, I guess we'll have to start the session rather than, wasting time. I think there should be one more panelist. Oh, she's not there. Oh, okay, fine. So I think only we have 4 panelists. Yeah. Has Dr. Gurunadham arrived in Hyderabad? Has anybody met him? Dr. Gurunadham? Yeah, I think he's here. Please come. You can straight away walk on stage and take your seat. Good. So he just made it in time and we will start rolling our session. So I would quickly like to introduce our panelists. So we have Dr. Madhavi Pudi. So she is a consultant dermatologist at Dr. Madhavi's Advanced Skin and Hair Laser Center at Balkampet. So the next panelist we have is Dr. Gurunadham, who is from Khammam and also from Hyderabad. So he has a center both in Khammam and in Hyderabad. He's a well-known figure in dermatology fraternity. And we also have Dr. Swapna Priya. Again, she works at Care Hospital and the Cosmosure Clinic at High Tech City. She's a gold medalist. And also we have Dr. Rekha Singh. She's a consultant dermatologist and training faculty at Oliva and also a consultant dermatologist at her own clinic at Malkajgiri. So with this brief introduction, we will start with our session. When Dr. Bhumesh spoke to me, he wanted to have a kind of a focused session on pigmentary disorders. We all know that pigmentary disorders is a vast area which involves both nevoid conditions, non-nevoid conditions, so and as well as acquired conditions, congenital lesions. So we are not going to focus on all those aspects. We are going to only focus on 3 important topics. We chose these 3 important topics because they are of significant relevance in clinical practice. We see a lot of these patients and we are seeing a more and more number of these patients who come for treatment. So these 3 topics which we are going to cover are lichen planus pigmentosis. We are going to cover post-inflammatory hyperpigmentation as well as tattoo removal. So we'll start off with the, one of the challenging conditions which I would call in dermatology, which is lichen planus pigmentosus. So I would like to start with our panelists and ask them how often do they see LPP in their practice. Dr. Swapna?
LPP probably monthly 2 to 3 cases.
Right. So it is definitely on the rise, isn't it?
Yes, definitely.
Yeah. Dr. Madhvi?
So around 8 to 10 cases we see.
Every month you see. Yeah. And Dr. Rekha, what is your opinion?
Somewhere in between, sir. At least 10% of the whole basket of hyperpigmentary concerns that we come across.
Correct. And Dr. Gurunatham, what do you feel is the incidence of LPP in our practice? I think, can somebody give another mic? Yeah, it's working now. Yeah, Dr. Gurunatham.
Yeah, it is on the rise, sir. I started my practice 20 years back. In the initial days of the practice, we used to see once in 6 months.
Oh.
And after that, the cases are on rise. And now we are frequently seeing the cases. And most of the cases, there is a hormonal link. When we see the LPP, sometimes, most of the times, we find hyperthyroidism. And also, the females are more affected than the males.
Right. So you find the incidence is more in females than in males.
Yes, sir.
And what do you think are the triggering factors for LPP in our patients?
Exactly not known, sir.
Yeah, I mean, generally, what do you ask for in history? Do you ask for history of hair colors? Do you ask for history of cosmetics? Do you ask
history
for
of cosmetics? They use more cosmetics.
And also, as you said, thyroid and other disorders also you look for, correct?
Yeah. Yes, sir.
Right. And also, what do you do when you see a case of LP? If somebody comes to you and initially, do you directly take them up for laser treatment? Or what is your protocol for managing the LPP medically? How do you stabilize the lichen planus pigmentosus?
Yeah, initially, we'll do the blood test, including the hormonal profile, thyroid, T3, T4, TSH, and complete blood picture. And once...
Any role of vitamin B12, vitamin D?
Yeah, we check B12 also, sir.
Yeah, because I find some of the patients are low in B12.
We check that B12 also. And also, in some cases, we found ACTH levels are elevated, serum cortisols are low in levels. Then we refer to endocrinologists. They told it was due to autoimmune adenitis. So in that cases, when you start with low dose steroids, there is a good response. Straight away, we never take to the laser.
Right.
We wait at least for 6 months to stabilize the disease.
Okay. Dr. Rekha, what is your opinion of how do you manage LPP initially? What is your medical management? And as well as when do you start the patient on lasers?
Yeah, lichen planus pigmentosis, once the patient arrives, history taking is more important. The first thing is we have to identify the triggering factors, the most common being hair dyes, followed by perfumes and also home remedies like turmeric and sandalwood containing materials. So first thing I would ask them to stop those things, those triggering factors, whatever I find in history. And as Dr. Gurunatham said, we should never start the laser treatment. We have to wait for the disease to stabilize.
Right.
So we can look out with dermoscopy, and if we are in dilemma, biopsy is always
A
best thing to
choice,
do.
yeah.
Good choice to do.
What are the dermoscopic findings, Dr. Rekha?
Yeah, majorly in lichen planus pigmentosis, you see dots and globules, against the gray background, and also there is perifollicular accentuation of the pigmentary network. That is a major thing, and there are some other things which are seen like Chinese letter pattern, which are more and more described, which is the most common finding that is seen. Apart from this, clinically also we have to be more vigilant because sometimes we get carried away with dermoscopy. Clinically also we have to dig into the history, ask the patient whether the patch has been extending.
Correct.
Sometimes we ignore that fact. After that, if the disease is active, then we have to resort to oral medications. My favorite being oral cyclosporin, because within 2 to 3 months, I have seen that the disease stabilizes.
Right.
Then slowly switch over them to low dose oral isotretinoin, like 0.2 to 0.3 milligram per kg body weight.
Okay.
And then you should decide about doing the Q-switch-YAG laser.
And what is your topical agents of choice?
My topical agent of choice would be definitely 0.1% tacrolimus twice a day in a lotion based preferably, because ointment once again
It's very
causes lot
sticky
of
on the
irritation.
face, isn't it?
Yeah. Of course, sunscreens would add to the...
Right. Dr. Madhvi, do you have anything to add? Medical management.
Apart from the points which other doctors have mentioned,
history of some herbal things, even the mustard oil application and amla oil also sometimes they can aggravate. Some people have the habit of using the perfumes on the shirts.
Right.
They think that that is not the culprit. So we have to insist on that also.
Right.
And coming to the management part, even I would like to make the patient use immunosuppressants.
Immunosuppressants.
So cyclosporin is the first choice.
Okay.
And in few cases I have used azathioprine also, sir.
Okay.
In few cases. And oral antioxidants and isotroin if there are no contraindications.
Okay. And what about oral steroids? Does anybody like to use any steroids?
Patients who cannot afford and we can always use a pulse therapy oral steroids also, just like.
Correct. Dr. Swapna Priya, anything you want to add?
Another is scrubbing habits. Many a time people do lot of scrubs on the face where they do everyday scrubbing. They think their skin is darker and still they try to scrub it more to remove the darkness.
Kind of irritates the skin and
Irritates
disrupts
skin
the barrier
more
of
and
the
everything.
skin.
And particularly when they have seborrheic type of skin, they use kerchiefs and everything where they rub their skin a lot.
Right.
And in the management aspect, particularly, I sometimes even prefer methotrexate, which is weekly dose, and then shift them to isotretinoin. And then once and low dose of topical steroid lotion weekly once or to have a faster resolution of the changes.
Okay.
I do use it very low dose, weekly once basis.
Okay. Okay, now let's come to the procedural management. Okay, all of us have treated the LPP, we have stabilized the condition, and now the patient you want to start on where there's no activity of the disease. One way to know the activity of disease is to do a biopsy or a dermoscopy. You do a biopsy. In biopsy, if you know that there is no interface dermatitis, only pigment incontinence is there, then you pretty much know that the disease is stable. So once the disease is stable, then what do you do? How do you start? So you can start, Dr. Madhvi.
If the patient is really insisted about the faster recovery and usually marriage going ladies, they usually approach us.
Yes.
So in those patients, after thorough counseling, if the patient is willing, usually I prefer the LPP on the face, especially to be treated with the lasers.
Right.
Q-switched laser I prefer with the wavelength of 1064.
Okay.
Always I advise them to go for a patch testing first.
Okay.
Small patch testing about 1 into 1 centimeter or 2 into 2 centimeters, small patch testing. If they're improving and if they're happy after 4 to 6 weeks of assessment, I would like to go for the remaining part of the face.
Okay. Is there any role of skin lightening agents, Dr. Rekha? Does it work? Is it required in these patients? And do you even do priming before starting lasers?
Yeah, lichen planus pigmentosus, as we all know, it is more of a dermal pathology.
Right.
So there is no role of skin lightening agents to be given in as well in the treatment of lichen planus pigmentosis as such. But of course, if we are using good energies and if the gap interval between 2 consecutive sessions is lesser, then probably we should prime to prevent rebound hyperpigmentation.
Right.
So for priming we can use, but not for the treatment as such for LPP.
Okay. And now we'll go on to the cases which you people have treated. There are some before and after pictures which I'll be showing. We'll straight on jump onto the cases. This is Dr. Gurunatham's case. Dr. Guru, what did you do in this case? This patient obviously has LPP right on the face. You can see on the neck as well.
Yeah, we have done around 12 sittings of Q-switched NDI laser, sir.
Okay.
4 to 6 weeks the
interval.
Yeah.
What are the parameters that you have used, Dr. Gurunatham?
1064 and spot size 4 mm and fluence is more than 950. Fluence is more than 9 joules, sir.
Okay. Okay. And why are you using 4 mm spot size? Because I feel it's a little smaller spot size. I think
because
you need to penetrate deeper. You need to have a larger spot size.
Yeah. If we increase the spot size, the energy levels
are dropping down.
Yeah,
that's
dropping
why.
down. Initially, I tried with 8 mm spot size, and after that, there is an improvement. After that, there is no much improvement. Then we decrease the spot size and increase the energy levels.
Because in my experience, I don't use anything below 7 or 8 mm spot size.
I always,
I think 4 mm you might get depigmentation and confetti like hypopigmentation, so which I don't think is ideal. But yeah, your results are impressive. That is something which I can agree that you've got a good result. So point is taken there. But I think we'll have to. What is the other panelist's experience with the Q-switch laser? What is the spot size that you choose?
I use somewhere between 6 to 8 spot size and do with a very low fluence, probably
Right.
multiple sessions before I can say that the patient is not getting result. At least 4 to 5 sessions before we comment
Right.
that he is getting result or not.
Right. Anything else, Dr. Madhvi?
Larger area, always 6 to 8 mm spot size.
Right. Rekha, would you like to add something?
Sir, if the pigment load is high, I initially start with a low spot size like 5 mm. 4
Okay.
mm I don't do. 5 mm, the machine which I work delivers 6.1. That is the maximum fluence it delivers.
Right.
So maybe once, within 2 to 3 sessions, the pigment load comes down, I switch over to the larger spot size to laser toning method.
And in all of your cases, what you have treated with the Q-switched Nd:YAG laser, once you got the result, how long have you follow up the patient, and then what is your recurrence rates? Have you seen any recurrence of LPP?
The follow-up is majorly for 1 to 2 years. In one case, I have seen recurrence.
Okay. But otherwise, most of the patients, they are quite stable and they're not, there's no recurrence. Good. So we'll go to the next case. This is again your case, Dr. Rekha. So can you just go through this patient and, what did you do for her?
So this is a case of 52-year-old women who constantly applied hair dyes week on week. Then she started developing itching followed by hyperpigmentation, as you all can see, spreading from face towards the neck. So my challenge was, she was 52-year-old, so I was little skeptical about starting oral cyclosporin, but yes, I did. I did her lipid profile, complete blood picture, blood counts, everything, and started her on oral cyclosporin. She was little non-compliant, non-adherent to my prescription. I had to call her continuously every week for checking her blood pressure. Then within 3 months, I could stabilize the condition, and then I started her on Q-switched YAG laser, same protocol, 5 millimeter spot size, then 1064 top hat mode. And then I did at least 3 sessions in a row properly. I lost her for a follow-up, but then I had to be behind her to come back for the sessions. Finally, I could finish with 5 sessions, and this is the result. And topically, as I said, I gave her topical tacrolimus and lotion-based sunscreens, of course, and mild cleansers.
Okay.
That was my treatment.
Also, I would like to highlight that it's very important to use barrier repair creams, especially your ceramide and other creams, because many of these patients with LPP, they have a barrier disruption because of various scrubbing, etc., cosmetic use. So that is something that we should always remember. So that's a good result, Dr. Rekha. Okay, this is a couple of my patients which I would just like to show you all. So this is a case of LPP. Again, you can see the mottled hyperpigmentation, ashy gray pigmentation all over the face. And the patient responded very well to 6 sessions of Q-switched Nd:YAG laser. This is another case of LPP. Again, this patient had a really bad LPP. She was being tortured at home by her husband because of this pigmentation. So then she was really distressed and upset about it. So we treated her with Q-switched Nd:YAG laser, and you can see a remarkable change. So it has practically transformed her life. This is another case of lichen planus pigmentosus that we have treated. This is about 6 sessions later. You can see a really nice improvement in the pigmentation there. Another common case that we come across is Reels melanosis. So I guess all of you also see a lot of Reels melanosis due to use of cosmetics, Fair and Lovelies, etc. And then again, this is another indication where the patients respond very well to Q-switched Nd:YAG laser. So do you have any experience with the Reels melanosis? Any of you?
One patient I have done, sir. Got good improvement with 2 sessions itself.
Itself, 2 sessions itself, it gave good results. Good. I also do, typically in these situations, what I do is I do interventional priming. Means before starting the Q-switched Nd:YAG laser, I always do glycolic acid peels, not for clearance of pigment, but overall for like a priming effect, where after that the laser generally tends to work very well. So you can do that, interventional priming can be done, and then you can start with the Q-switched Nd:YAG laser treatment. So we'll come to the next topic, which is the post-inflammatory hyperpigmentation. So I think this is a very, very common problem that we face in our country, and especially acne scars with pigmentation is something extremely common. So this is one of my patients with acne with PIH, another case of acne with PIH. I would like to start with Dr. Rekha. How do you manage these cases? They are so common. I'm sure all of you come across a lot of acne with PIH.
Yeah, I would begin with my personal favorite would be 10% TCA peels to deal with this kind of pigment, followed by laser toning.
Followed by laser toning.
Yeah, because it can also modulate the collagen to a good extent.
Right. So we are not going to discuss about medical management, use of isotretinoin, all those things, even topical application with the HQ and non-HQ products we'll discuss afterwards. But I just want, in these 2 cases, what is your procedures of choice? So, Dr. Madhavi?
peels, glycolic acid peel, ferulic acid peel, apart from peels, the patient wants, nowadays patients are asking for the lasers.
Right.
So I do two type of lasers. One is IPL with pigmentation mode.
Okay.
With combination of peel.
Right.
Second thing is carbon peel.
Carbon peel, yeah. That's a
QC
good option
chip.
in such situations. Dr. Swapna Priya?
If patient is using proper moisturizers, TCA peel can be preferred. But I think in this, I can see still it is excoriated and more. I would prefer first glycolic in the first 2 sessions, then switch on to TCA peels. After 3 to 4 sessions, if still I feel the clearance is not better, then I would prefer laser toning in these cases.
Okay. Dr. Gurunatham?
I'll go with carbon peel simultaneously with the SM peel.
Okay. How many sessions of carbon peel do you recommend?
3 or 4.
3 or 4 sessions.
Along with SM peels.
What is the interval between the sessions?
I'll do with a gap of, if there is a function or emergency thing, we'll give a gap of 2 weeks.
2 weeks gap.
Yeah. Otherwise 4 weeks.
Okay. Now,
After the carbon peel, immediately we do SM peel also.
Right. Which skin lightening products do you prefer in PIH? Now, we are just not talking about acne-induced PIH, we are talking about general PIH. So, what is the skin lightening agents do you prefer? Do you prefer hydroquinone? Do you prefer azelaic acid? Do you prefer non-hydroquinone products like kojic acid, licorice extract, arbutin? So, each one quickly, you can just tell what is your choice of skin lightening products.
Kojic acid, tetrahydrocurcumin, arbutin, licorice, non-HQ products.
Non-HQ products. Dr. Rekha?
My favorite is azelaic acid, followed by other creams like containing a combination of kojic acid, arbutin, etc.
And what percentage of azelaic acid? Because we know azelaic acid is a bit irritating. Many patients tend to get irritation with azelaic acid. So what is the percentage that you like?
I like 20% because definitely it gives good results, but I prefer using liposomal
Delivery kind
so
of
to avoid
preparation.
any kind of irritants.
Okay. Dr. Madhvi?
Face, even my favorite choice is azelaic acid, 20%,
Azelaic acid.
micronized. If it is on
Micronized
other
azelaic.
parts of the body, glycolic acid creams.
Okay. What about Swapna Priya?
I would prefer glycolic acid in the first part. Once the adapalene component of the creams is decreased, then I would prefer azelaic component creams containing preferably.
Okay. So practically what we come to know from our panelists is that none of them like to use hydroquinone. Though hydroquinone is considered gold standard for skin lightening, most of us, we tend to use either combination of non-HQ products or azelaic acid, because azelaic acid is as powerful or as effective as hydroquinone, provided the irritation component is taken care of. So what peels do you prefer in PIH? You can start.
I prefer glycolic peels 35% to start with, and then move on to the peel-off peels along with the combination of retinoid peels after counseling the patient with the downtime. If they are comfortable with the downtime, then I prefer to use the combination of phenol-based and with yellow peel.
Okay, and what about cocktail peels? There are a lot of combination peels available. So do people use that? Do you like gel-based peels or, alcohol-based peels? What do you prefer?
Gel-based peels are definitely more safer in the practice,
Right.
though the result is bit less when compared to the alcohol or water-based.
You
but
need more
definitely-
sessions, basically.
Yes, more sessions.
But it's safer.
Safer in the practice, actually.
Okay. And when you deal with PIH, apart from acne, again, what lasers do you like? Do you use Q-switched Nd:YAG laser, Rekha?
Yeah, for other types of hyperpigmentation, secondary to other disorders, it could be fixed drug eruption or it could be any other thing. My choice would be definitely Q-switch YAG laser only.
Okay, Q-switched Nd:YAG only.
Q-switched
Maybe at 1064 or 532?
No, 1064 because 532, I think in Indian skin, definitely there is a higher risk of hyperpigmentation.
Yes.
So I prefer 1064 top hat mode.
Right. We'll move to the next case, which is by Dr. Madhvi. I think, Dr. Madhvi, you have seen this case and you have treated this. It's a classic case of post-inflammatory hyperpigmentation on the cheek. How did you manage this case?
After a thorough sunscreening and priming, sir, we have done 2 sessions of Q-switched Nd:YAG laser.
Okay.
532 nanometers I have done, sir, in this patient.
That's, pretty courageous. Because 532 can be a little tricky, especially in Indian skin type. You can end up with PIH. But you did manage to get good. Can you just tell us about the parameters that you used?
Actually, this patient, I think I did 3 years back, sir.
Oh, so you don't remember.
So I don't remember. I have to.
Okay, anyway.
Low fluence only I have used, I think so.
Okay, only 2 sessions. And
Sessions
did you do some peels in this case or just
Only with the creams and laser.
Creams and laser. Okay, that's pretty impressive again. And I'm glad that, the patient got a good result. So this is again a very common case that we come across. Winter season, patient has dryness, perioral area, and then ends up with the PIH. So if you can notice the nasolabial folds, the perioral area, it's dark. So what would you do, Dr. Gurunatham, in such a situation? How much time do we have?
Sir, peels.
If we started early, we'll have 10 minutes more.
10 minutes more, fine. Okay.
We go with sunscreen and peels also, sir. Chemical peels.
Chemical peels. What peels do you prefer? Glycolic acid, kojic acid, or a combination?
Combination peel.
Or a yellow peel? What do you like?
Combination peel.
Combination peel. Anybody else would like to add?
Mandelic acid peels also will work well.
Right. It's quite mild also and doesn't irritate. Lactic acid peel?
Mandelic acid and even now combination like lactic and pyruvic acid peels.
That's right.
And retinol peels also works well for this patient.
Right. Dr. Rekha?
Yeah. Yeah, first is we have to rule out any underlying seborrheic dermatitis also.
Yes.
We have to treat that probably if it is,
We had checked her, she did not have any flaking in the scalp, so there was no this thing, but it was classic history that, she got a lot of dry skin around the mouth, probably use of some other topical agents, and then she ended up with pigmentation. So what I normally do is I tend to use a lot of moisturizers around the mouth, and then use sunscreens on top of it, and then skin lightening agents at night and do some peels.
So
Lasers also can be done. You can use a carbon peel also in this case, which I'm pretty sure.
B12 deficiency.
I don't think so. So she was otherwise a healthy person. So this is another common case that we come across. The patient has seborrheic melanosis. Any of you can take up this case. A young boy who's got acne. He's got a lot of seborrhea as well as seborrheic melanosis. So I kept this under PIH because, it is typically pigmentation. So anybody can take this case?
So as I said, hyperseborrhea definitely leading to melanosis of the seborrheic areas is common. So we can medically, orally we can give oral isotretinoin, low dose 0.2 to 0.3 milligrams per kg body weight.
Right.
And then go ahead with salicylic mandelic acid combination peels initially.
Yes.
And then we can also, post that we can give yellow peels or TCA plus leave-on retinol peels.
So any role of lasers in this particular case?
Yeah, once the thicker skin that we see in the picture goes off, then we can definitely do laser toning. That will give him a
Because in
dermal component.
Madhavi.
I did a fractional CO2 laser with the Q-stitched combination I have done in 2-3 patients, vacant dose nigricans. So similarly in these patients also I have tried, sir, with very low resurfacing with fractional CO2 with Q-stitch.
Okay.
Apart from peels.
Yeah, what I also like to do in such cases is use erbium YAG fractional, because CO2 fractional is a little aggressive and it can cause post-inflammatory hyperpigmentation in our patients. So I tend to use, fractional erbium YAG 2940, which is quite a good wavelength because it doesn't cause so much of thermal damage and does not cause so much of a problem. And then you can also use your laser toning or a carbon peel in this situation. Okay, we'll come to the last topic of our panel discussion, which is on tattoos. So, can any of you tell how do you assess the number of sessions required? When a patient comes for tattoo removal to us, the first question he's going to ask is, Doctor, how soon can I get my tattoo removed? How many sessions will I have to undergo to get the tattoo off? So, how do you assess this? Rekha?
So basically, tattoo, it's very dicey for us to give the exact number of sessions. So it is better for us to follow the Kirby-Desai scale.
Right.
Kirby-Desai scale includes certain components like the skin type. There are certain points given to each components, like Fitzpatrick skin type or location. For example, if the tattoo is located on the face and neck, then the number of sessions needed will be lesser. But whereas if it is located on extremities like feet or hands, probably you will need more number of sessions. So for each parameter of the mentioned, which I mentioned on the screen, you have points. So you have to add up all the points, and that will give you the estimator, roughly the number of sessions a person would need to get rid of the tattoo.
Correct. So it's very important to know this scale, which is called the Kirby-Desai scale. So you give a numerical value to each of these. If the patient has had the tattoo and he tried to remove it by some other means like dermabrasion or something like that, and if there is a scarring, then you will end up with a worse result. So when you add up these things, then you come to a conclusion as to roughly, it's an estimate. Remember, this is not an accurate scale, but it is an estimate. But it is a proven scale that it helps us to tell us how many sessions a patient will require for tattoo removal. Now, another point I would like to ask my panelists is, when a patient comes for tattoo removal and he is on isotretinoin, if you look at any Western literature, the first thing they say is take a history of isotretinoin. If the patient was on isotretinoin 6 months, in the past 6 months, then you don't do laser treatments. So what is your take on isotretinoin with Q-switch laser for tattoo removal?
According to the olden literature, at least 6 to 8 months we have to wait because patients have a tendency of choroidal tendencies.
Right.
But new articles are showing that we can do the tattoo cases.
Correct.
Because the lasers are being advanced.
Yeah. So anybody else would like to add isotretinoin? Do you treat with Q-switch Nd:YAG laser?
Yeah, as of now, the latest updates, we can probably definitely do
So
it.
if you are careful, if you use your parameters correctly, if you don't go overboard, use very high fluences, then you can easily use Q-switch Nd:YAG laser with a patient on isotretinoin. Now we'll go to the next slide. So this is again Dr. Madhvi's case. This was a case of a tattoo which was on the arm. And you can see the patient underwent treatment. So Dr. Madhvi, what laser did you use, what wavelength, and what parameters?
This patient also almost 5-6 years back, sir. At that time I used to have passive laser.
Okay.
So
a
that's
smaller spot size
smaller
laser,
spot
right?
size. So the scarring also is little bit scarring is there.
Exactly. So the whole point of putting this slide is, if you use a very, very small spot size, then you will end up with scarring. So make sure that there are 2-3 parameters that you should look for in a Q-switch Nd:YAG laser. One is it should have a top hat beam profile. That means equal energy distribution over the spot. Number 2, make sure that the machine has a large spot size. So when you're treating a tattoo, where is the tattoo particles? They are in the dermis. So you want to reach in the deeper levels. So you want to use a large spot size, somewhere around 5 millimeter, 6 millimeter spot size. If you're using 2 millimeter, 3 millimeter spot size, then you will end up with what you can see on the screen, that is scarring. We don't want scarring to occur. And also very important in tattoo removal is do not stack too much and do not overlap too much. Then you will end up with blistering and all. So if you notice that the patient's red line is still there, the heart is still there. So for that, you will have to use a different wavelength. So for a black ink, which wavelength do we use?
Black 1064.
Correct. And if you have a red tattoo ink?
532.
532. So you're going to use a different wavelength to treat the red colored ink. So we'll go to another slide. So this is a patient who has a multicolored tattoo. Remember that amateur tattoo is easy to treat. Multicolored tattoo is more difficult to treat. So in this case, if the patient wants to clear this, of course, we know that 1064 is what we are going to use for the black colored ink. Red, already Dr. Madhvi just mentioned that you're going to use 532. But if the patient wants the greenish blue color to be cleared, so which wavelength would you prefer?
755 Q-switch Alexandrite would be better, but personally...
That's right. Yeah, but we generally don't have multiple machines. That is the problem. So the blue and green colors are very difficult to treat. Of course, if you have a picosecond laser Alexandrite or a Q-switched Alexandrite, then it's a good option for treating that. Now, we'll just go, this is just for our audience. So these are the wavelengths that are generally used with the Q-switched Nd:YAG laser for the different colors of tattoos. So if you're treating blue-black, then you use a 1064 nanometer. If you're using a laser for the red coloring, then you use 532. If you want to treat purple, teal color, then you use a 755 Q-switched Alexandrite. For green color, again 694 ruby, but again ruby is too dangerous in our skin type. And of course, if you have picosecond laser, that generally tends to work better in our patients. And now, coming to this, we see a lot of such cases which are permanent eyebrows. The patient goes to a beauty parlor, the beauty parlor just does tattooing, patient does not know what they're undergoing, and they end up with this ghostly appearance. So have you come across such cases? What do you do for this, Swapnapriya?
Probably like a tattoo removal parameters only we are opting and doing the sessions, starting from 4 mm spot size.
Right.
Depending on the frost.
But then they have hair on the surface. So what do you do? How do you penetrate? The hair is going to come in the way and you're going to get, whitening of the hair, bleaching effect of the hair.
So partially removing in that part probably might be better because the light definitely is taken up more by the hair than the tattoo.
Correct. It's going to be scattered. So once it is scattered, it's not going to penetrate deeper. So what do? You can shave off the eyebrows. You can do the treatment. And remember that Q-switch laser does not remove hair. Okay, so your hair is going to grow back. Of course, you have to tell the patient that initially they will look a little weird with no eyebrows, but then eyebrows are going to grow back. But you will get a leukotrichia or a whitening effect or a bleaching effect if you treat over hairy areas. So please tell the patient that this might happen. Okay. The other way, what to do is you can use a micropore tape, kind of slowly, put the tape, separate the hair and then treat. But that's a tedious procedure. So this is another patient who had a fresh tattoo. Now this is again very common in our country. They get a tattoo done, God knows why, and then within a month or two they want it to be removed. So how do you deal with such patients?
So probably first the counseling. Is really the wound healed or not? First, post-tattoo, sometimes the wound has not yet healed, or sometimes the scaling of the skin still is present, where it is still in the healing phase.
Yeah.
So that is very important.
And the ink particles are too dense. They're compacted, dense particles in the dermis. So
low fluences when compared to normally we need to do, and splattering will be more when it is a fresh tattoo when we are doing.
Correct. And blistering also can occur. So you have to be very careful about taking up such cases. Anybody else would like to add? There was one interesting case where the patient had a tattoo and he wanted it to be removed. When I told him that it takes 3 months, 6 months, then he just went and re-tattooed something else on that. He had the name of a person, then he tattooed a design on top of it. So that solved his problem. So what are the newer techniques for tattoo removal, Dr. Gurunathan? R20, we hear of R20, R0.
I have not tried, sir.
You have not tried. Anybody has tried these newer techniques, Dr. Rekha?
Yeah, I have tried R20 protocol, wherein you repeat the laser process with a gap of 20 minutes. Because when you do Q-switch YAG laser, the heat transmits to the cells and there are certain air bubbles which form up, which can prevent the penetration of the laser. So we give this 20-minute time for the air bubbles to settle down, so that the second pass would treat the residual pigment in the dermis. And R0 is again a very useful method where you can save the patient's time going about for 4 passes. R0, they use perfluorodecaline, which I haven't used personally, but I have used R20 protocol quite a while.
Yeah, so this is the perfluorodecaline which Dr. Rekha was just mentioning. So this is the compound which absorbs the gases which are formed once you do the first pass of a Q-switch laser. Then there's vacuolization in the cells and there's gas bubble formation. So it will act like an opaque window where the light will not penetrate further. So to prevent that, what you do is you apply this solution, and then this absorbs the gases, and then it allows the laser to be used once again immediately rather than waiting 20 minutes between the session. So this is one of my patients. So this patient had an amateur tattoo on the forearm, and the patient was in a great deal of hurry to get rid of it. So we did a R0 technique. That is, on the same day, we did about 3 to 4 passes of Q-switched Nd:YAG. In between the passes, we applied perfluorodecaline, and you can see that in just one single session, the tattoo is near 100% cleared. Now, what is new is that we get what are called perfluorodecaline infused patches. So instead of using the spray, these are patches by name Describe patches. These are available in the Western countries. So where you apply this patch, which is already infused with perfluorodecaline compound, and then you do a lasering on top of that. So if you notice on the picture on the right side, half of the tattoo was treated with perfluorodecaline patch, half was not treated with the perfluorodecaline patch. So here you can see there is a lot of whitening or frosting which is seen on the left side, whereas on the right side with the PFD infused patch, you can see that there is a complete clearance of the whitening. So this is the advantage of using what are called perfluorodecaline patches. Now this is again a common problem that we see: a patient who undergoes tattoo removal, somebody does tattoo removal very aggressively, and they end up with what is very classic hypopigmentation. So any of our panelists would like to add, what do you do for these kind of situation where you are stuck with this hypopigmentation?
Probably excimer lamp is the better option to try in these sort of cases when they have severe hypopigmentation.
Right.
And topical tacrolimus or pimecrolimus is additional thing.
Yeah, Rekha?
Yeah, targeted phototherapy, and there are case reports where they have used high percentage of TCA also.
Okay. Yeah, TCA also can be used. Another thing is bimatoprost, letanoprost. These are again some agents which can be applied, and they also tend to give some amount of free pigmentation. Tacrolimus, of course, can be used, and excimer. But it is a difficult situation, isn't it? I'm sure all of you will agree that the patient is not going to be very happy with this. Now, another common problem which we see is hypertrophic scar formation. So a lot of patients end up with this kind of situation if you use very aggressive parameters. So the point I would like to highlight is do not be very aggressive in tattoo removal, or else you will end up with, again, hypertrophic scarring is a possibility, even though Q-switched Nd:YAG per se is a non-invasive laser. So I think we are running out of time. So, okay, because it just sounded the bell, so I thought it might wind up. Okay, so now suppose that the patient has this hypertrophic scarring, how would you manage? Madhuri?
Intralesional corticosteroid.
Right, intralesional corticosteroid.
And fractional CO2 laser.
Right, any role of silicone dressings?
Silicone dressings also.
And silicone, you have these compounds with heparin, hydrodoid, and these kind of creams. So
creams per se doesn't play much role.
Right.
Tight pressure dressings.
Pressure dressings, silicone dressings, as well as intralesional steroid. So, but the important point is to prevent this, avoid stacking, avoid being very aggressive. Absolutely, there should not be any blistering or very aggressive purpura should not be there. So you have to make sure that your fluence is correct. Now, there are also a lot of patients which we see with tattoos where they get an allergic reaction to the tattoo, correct? So what are the colors that give allergic reaction in tattoos, and how do you manage? Do you use Q-switched Nd:YAG or do you use something else there?
Usually allergic reactions are more common with the professional tattoos because they have azo dyes and other heavy metals like cadmium and mercury.
Yeah.
So those things will be causing the...
So cinnabar is one of the most common causes of allergic reaction in tattoo, which is the red ink. So red is notorious to give allergic reactions. So if at all a patient has an allergic reaction, you see there is a little bit of swelling, you see the patient has itching on the area. How do you manage, Dr. Rekha?
So the best thing is, if it is a fresh professional tattoo, then it is better we do a patch test. So if somebody has an allergic reaction, we will get to know in the patch test itself. Then we can add a course of antihistamines right on the day one and continue till for 1 more week. And we can also club it with ablative erbium YAG or CO2 laser to speed up the transepidermal elimination of the particles so that the...
Right, so you use a fractional laser instead of a Q-switch laser. Yeah. What about role of topical corticosteroids if they have an allergic reaction?
Yes, if the tattoo area is smaller, definitely we can give a course of topical
steroids also. Right, and anybody has any experience with picosecond lasers? Dr. Gurunatham? Okay. In the audience, does anybody use a picosecond laser? So we all have experience with Q-switch laser, though of course Q-switch laser is still the gold standard in our practice. But then picosecond lasers have certain advantages where your pulse duration is even smaller. It is 10 to the power of -12th of a second. So it's much shorter wavelength pulse duration than a Q-switched Nd:YAG laser. So the advantage is higher peak powers that are delivered. And they have a couple of benefits, particularly for tattoos. They're not so useful for pigmentary disorders, but for tattoos it is definitely useful because it can speed up the clearance of certain colors, especially blue, green, purple, these colors which are generally very difficult to treat with Q-switch. Then the picosecond laser has the advantage that it can clear this pigment a little faster compared to the other nanosecond lasers. So I think we'll wind up with our session. So the take-home messages here are that post-inflammatory hyperpigmentation, LPP, and tattoos, these all can be comfortably treated with our procedural methods. Of course, we use a lot of topical agents, but in certain situations, lasers do help, and these lasers are commonly which are used are the Q-switched Nd:YAG laser and the picosecond laser. Another thing that we do for tattoo removal is the use of combination lasers, that is fractional lasers along with Q-switched laser in the same session. So that also can be done. And another few points that you need to remember is there are certain poor prognostic factors which Dr. Rekha already touched upon. So these poor prognostic factors for tattoo removal include a person who is smoker, then the presence of colors other than blue and black, that is red, green, purple, blue, these are more difficult to remove, whereas black color is easy to remove. And then if a tattoo is larger than 30 centimeters square in size, so a very large tattoo, again, it is very difficult to treat. And then tattoos on the legs, again, these are pretty difficult to treat. They don't tend to respond very well. And also, what is important is if you try to avoid treating a tattoo every month or every 2 weeks or every 4 weeks, even if the patient insists that, doc, I want this to be removed faster, so do not fall for that and don't try to remove the tattoo every 2 weeks or every 4 weeks. Ideally, the interval between tattoo removal should be 8 weeks. So with that, I wind up my session. I thank all my panelists for their wonderful inputs and their photographs that they shared, and I appreciate the audience's patient listening. Thank you so much.
Any questions?
Any questions? You're free to ask. We still have a few minutes. So anybody has any questions for our panelists? Yeah, Dr. Anup?
And the layers of thing, how do you know that?
There is a chart which you can use. So like red ink has more points, black ink has less points. So like that. So there's a chart that is there with that. So depending on which color, you have the number given for that. And the layers also, they give the protocol. Yeah. You can do you can do a dermoscopy and check what is the density of the color there.
Sir, where does PFD is available?
It's available with certain companies, I think, and also another very important point is ophthalmologists also they use it, so you can ask.
Can we use that one?
Yeah, we can use that one because they use in the vitreous chamber.
Surgery they use it.
Yeah, for vitreous surgery they use that, so you can source it from your ophthalmologist, and certain laser and pharma companies they do can source for you. And of course, describe patches are available abroad, but they're pretty expensive.
Yeah. One more situation, sir, where black tattoo did Quisi-Chandiyak, then tattoo became very dark.
Yeah, that can occur especially for cosmetic tattoos. Especially if you have ferrous oxide, it turns into ferric oxide and becomes more darker in color. So any of these situations where the tattoo which is used for lip liners as well as to recreate the areola after breast surgery. So in such situations, then there's a chance that the ink might become more darker. So if it becomes more darker, the treatment is again you continue to laze. Yeah, or you use a combination of fractional along with the Q-switched. But you continue to laze, it tends to clear up.
Yeah.
Yes, Dr. Pratap.
Last time in basics, Dr. Srinivas said in LPP, we have to use this triple combination is better than the kozic acid and others.
Oh,
but this time,
yeah.
I have heard that...
Sir, triple combination I have stopped using.
But he said that...
He said that, yeah, but I don't, I don't agree with that.
You have also, you were also there and...
yeah, but I don't agree with that. Anybody else, panelists, what do you have your opinion?
I don't agree, sir. I never use triple combination.
CR said...
yeah, anybody else, triple combination, do you use? Correct, and the risk of overuse is a problem, misuse is a problem. So that is the reason why at least I don't use triple combination in LPP. Anybody else has any questions? Feel free to ask. I think, Mike, please.
In case of tattoo removal, how do you follow that session-wise? Do you decrease the power or increase the power? Once there is a lightening of the pigment going on,
right?
What are your parameters?
Actually, with every session, we have to increase the fluence of the with whatever machine you're working with, because as the amount of pigment comes down, it is difficult for the laser also to identify the pigment there, tattoo pigment there. So with each session, you can increase the fluence by 1 or 2 joules. Again, test spot, looking out for frost, adequate frost, making sure that there are no bleeding points or petechia or purpura. Waiting for 3 to 5 minutes would help.
There is actually a study on this where it has shown that a progressive increase in fluence is required during tattoo removal. Progressive increase in fluence is required to achieve full tattoo removal. So ideally, you tend to increase the power rather than, it's something like, you do hair removal. You use, say, with a diode, you use 25 joules. But the hair is very thick. You use a larger pulse duration, you do a laser hair removal. As the hair becomes thinner, finer, you have only 2 options. Either you have to reduce the pulse duration or you have to increase the fluence. Otherwise, your absorption becomes less. So that is how, similarly with tattoo removal also, you tend to increase your fluence successively with each session. Sir.
The thing is, after having yellow peel, one patient has come to me saying that he has got irritation, then some sort of lot of irritation.
Retinoid dermatitis is common.
The thing is, I advised her this moisturizers, but she says after applying moisturizers, she said it is increasing.
Oh.
So I have to do
patch test or
give
something.
her give her only that topical steroid, and then of course
yes, sir.
Steroid, systemic steroids also to reduce the inflammation.
Yes,
does it affect the peeling, the effect of the peel? Yellow peel.
I don't think so. See, the problem with the yellow peel is it causes retinoid dermatitis. It's just like using your tretinoin cream. If you use tretinoin cream 0.05%, definitely the patient is going to end up with retinoid dermatitis. So how do you counter this? Either you have to use a moisturizer, or you have to use alternate day therapy, or you have to use weekend therapy. So that is how you adjust your topical retinoids. So I'm sure yellow peel, I think our panelists also can throw some light on that. Do you have any experience with that? I mean, retinoid dermatitis?
Barrier management is very important, sir. So that's why we have to give them mild cleansers, because most of them use salicylic acid or other
So we have given, I have advised a Cetaphil cleanser. Still, she is not happy. That is maybe dermatitis.
Maybe she's got a very sensitive skin also. Okay. So then you're, again, you have to treat that patient as a sensitive skin patient. Okay. Thank you so much for a patient listening. Thank you.
I thank Dr. Sanjay Varghese and all the panelists on this occasion, and ask them to come for a photograph here.
Actually, this very memorable moment. The Aurangabadkar has taken lasers in a Aurangabadkar hall. So, on the memory of his father. So, actually, we should.
It's a pleasure and honor to be in the hall which was named after my father. Thank you so much.
There's a photo session there. I now invite Dr. Aradhya to start her panel discussion. Dr. Aradhya and her panelists will discuss the management of periorbital melanosis, lip melanosis, and melasma.
A pleasant good morning to one and all. I would like to apologize for a little delay on my behalf and causing a slight change in the scientific session. I am Dr. Sujala Sachinanda Aradhya, a consultant dermatologist and dermatosurgeon from Bangalore. I would like to call upon my panelists for the day, Dr. Rajilakshmi Konathan ma'am, Dr. Satya Sai Teki, Dr. Indra Pavan, and Dr. Shobha Reddy. So I would like to thank the organizing and scientific committee of Telangana CUTICON 2021 for giving me this opportunity. With this, we'll start off our panel for today. So how do I manage melasma, periorbital and lip melanosis with different methods? This will be a case-based discussion. So yeah, we have our panelists on the stage. With this, I would like to mention that there's no conflict of interest. I have used a couple of photographs with some brand names on it, but I'm not promoting any one of them. So we'll talk about melasma. This will be an open question to anyone of the panelists. So when you have a treatment-naive patient, doctor, how would you like to start the patient on a treatment?
So actually the treatment-naive melasma patients, whenever we see, the first thing what I do is first we have to take the history and then any medicines they are using and what is the cause, and if it is diagnosed as melasma, then the first thing is the sunscreens. liberal use of sunscreens. We have to advise and explain to them and how to use the sunscreens. And later, I'll just give in the night the demelanizing agents. So these are the things which I usually start early. And then later, once in the follow-up period, depending upon the response, I just tend to add on.
Yes, ma'am. Anybody else? Yeah.
I just start with spending few minutes with that patient to take the history about what are her expectations and any family history of melasma, and also about whether if she's a lady, because she's a lady, whether she's pregnant or not, because there will be mask of pregnancy or cloasma. And then about the aggravating factors which are present in her daily life. If they are now software engineers, they are work from home, but the LED screens, they also have the UV rays. So we have to assess how much sun exposure, hormonal changes and everything, and then proceed followed by examination. Then I can treat her properly.
Absolutely, ma'am, yes. So discussing with the patient regarding their history, use of any other medication, any aggravating factors is quite important. Because melasma is going to be a long-term condition. Even though they respond to treatment, it can always come back. So counseling the patient and letting them know the importance of use of sunscreen is quite important. So yes, do you insist sunscreens? Yes, ma'am, please.
For this one, sunlight is a 100% etiological factor for the melasma. So first and most thing is we have to explain about the sunscreens. That should be broad spectrum sunscreen. I think we will explain this one.
Yes, ma'am.
And one more thing, as Dr. Satya said, we have to avoid the triggering factors. We have to ask about the drug history. If they are taking OC pills, we have to stop the OC pills.
Absolutely.
And even the thyroid dysfunction also we have to see.
Yes, whether any hormonal etiology is present. So we know the answer for this. Yes, we do insist sunscreen for all our patients. But what about chemical versus physical sunscreens? Is there any preference over one over the other?
Shall I take?
Please, ma'am, yes.
Yeah, first of all, sunscreens, it should be broad spectrum. Neither it's a chemical or physical. It should be broad spectrum. Why? Because now recent etiology is telling not only the UV light, even the visible light is also, even the infrared rays
Yes,
also penetrating. And that is causing more of inflammation, and that is the main etiological factor for melasma. So that's why always choose a broad spectrum sunscreen rather than going for only chemical or physical sunscreen.
Absolutely, yes, ma'am.
Particularly nowadays.
Please, ma'am, please.
Actually, I was about to focus on this. So nowadays we all know post-COVID.
Sorry for the interruption. I now invite Dr. Manmohan to be part of the chairing persons.
Coming back to the sunscreens.
1 minute.
So as we all know.
Hello. I'm extremely sorry. Actually, I was on time. The session started before the time, that is at 11:15, I think. 11:20 was the scheduled time. But anyway, I really heard the lectures. They were very good. And please carry on.
It's always a pleasure, sir, to be with you. And then coming to sunscreen, we all know post-COVID, we all are like exposed to long hours, not only to the sunlight, but now today like prolonged exposure to the gadgets, the blue light being emitted continuously. So here the tinted sunscreens are playing a great role. Here it's like broad spectrum, not only UV, the visible light, particularly the blue light, and then infrared, where we have these micronized iron oxide molecules being integrated in the sunscreens. They do reflect back the visible sunlight and they're more effective. Not only this, they have more cosmetic appearance. Nowadays we get lots of tinted shades matching with the skin color of the patient. So nowadays like these tinted sunscreens, they give cosmetic appeal and prevent this white patchy ghost appearance, and also more protective. So definitely we do go ahead and use sunscreens. One more thing, routinely we come across it, patients ask us, do we use sunscreens even indoor? So definitely nowadays we are seeing even school children with the prolonged online hours being exposed to the classes, they're coming with the
facial pigmentation. So we do tell them to go ahead and use that.
Absolutely. So it's a broad spectrum sunscreen, preferably to cover even the blue light that we are coming across of late, and to definitely use sunscreens even when indoors.
Actually, as Dr. Indra rightly told, even for children what we are giving, I think physical sunscreens can be given to the children.
Absolutely. So in a younger age, physical sunscreens preferably. So what about these cosmetic options that we have? We have a lot of 5-in-1, 7-in-1 creams. So do you advise that these can be used, or is it has to be purely a sunscreen?
I feel it has to be a purely sunscreen. I don't advise all the combinations.
Sometimes, since it's like Google era where patients pick up from the online market, we see that contact dermatitis, and when some of the ingredients in the sunscreens themselves inducing the pigmentation, post-allergic reaction. This is the common thing. So better always discourage this practice.
Absolutely, agreed. Some patients...
One more thing I want to add here is sunscreen, the frequency of application is different compared to other cosmetic creams. See, sunscreens we have to apply every 2 hours, and we can't apply the moisturizer very frequently. So sunscreen should be separately applied, and if they want to apply, they can apply moisturizer first, then followed by the sunscreen, because the quantity and the frequency of application of sunscreen is different from the other cosmetic creams.
Absolutely, ma'am. Yes, ma'am.
Always tell them moisturizer immediately after bath, and while going out or when you are about to go to work, sunscreen should be the top layer.
Absolutely, yes. So, please, sir.
See, this physical sunscreen, sorry, I am not a panelist, but
no, sir, please.
As the interest of these physical barriers when you apply, we cannot do it uniformly. So there is a likelihood of cornea pigmentation coming up, cornea-like pigmentation, because of the spaces. So we prefer to use a combination of physical and chemical together.
Yes, sir. Yes, sir. Yes, sir. So we do have some patients asking us this also, like when we advise them to routinely use a moisturizer and sunscreen, sometimes they pose a question saying that can we mix the two? So would you advise this? No. Absolutely no. So as the panelists have already highlighted, yes, do your moisturizer layer first, then in case of any medications, and then finally comes your sunscreen. Cosmetics only if absolutely necessary towards the end. But do a repeat application of sunscreen even when indoors. So what about the panelists? Do you think there's any role of face wash in melasma? And if yes, what would be the preferred composition? Dr. Satya?
I usually give glutathione face washes because it causes, I don't know how much effective it is, but the patient has a good feel after, because it improves the skin brightening and also improves the elasticity, so they'll feel good after face wash. And always the soap causes excessive dryness, so that can be prevented by these face washes. And also I use vitamin C face washes, and as you know, 1 to 2% salicylic acid and glycolic acid face washes are also available, which cause the peeling effect, so that the lightening happens and they feel good about it. So I use face washes.
Again, not promoting any brand, but what about mandelic acid or glycolic acid face washes?
One thing I want to add here is, in melasma, according to the recent guidelines of etiological factors, the barrier dysfunction is the most important triggering factor. So that's why we have to use face washes which should be mild and avoid soap. So generally I use moisturizing face washes, but if the melasma is associated with acne, we can go for exfoliating face washes such as salicylic, as Dr. Satya said, and glycolic exfoliating face wash also good.
Absolutely.
Like we can treat as a sensitive skin.
Dr. Rajalakshmi ma'am?
Yeah. They give good additive effect actually.
Yes, yes. So even in case of treatment-naive patients, we can probably have this as an addition along with our sunscreens and topical depigmenting agents. So when we talk about melasma, we know that there's a classification that we all come across. So what about the pattern of distribution? Does this have a bearing on the course of treatment? We know that we have the malar, the centrofacial and the mandibular types. So does this have any bearing on the treatment outcome?
This one, I studied in a recent article that as this is an old classification based on the site, but we can calculate the Massey score by this area of involvement. If you see the centrofacial, we see the forehead, cheeks, nose and even the chin. So the prognosis compared to malar melasma, centrofacial is little bit difficult. Maybe the Massey score, we can use it as a Massey score guide,
Yes, ma'am.
guiding the treatment. That's what I'm thinking. I think you can add.
Absolutely.
So when sometimes in these patterns of centrofacial, we have to take even the history, like particularly when it is involving the forehead and the temple area and the mandibular, we have to take, even sometimes they over the counter, they start or from the other prescriptions.
Absolutely, yes.
They keep using kojic preparations, HQ and all. So they themselves sometimes cause irritant contact dermatitis with PIH. So these are the very important things. And as Shobha said, when centrofacial, almost the malar component which starts in the beginning, mostly it is a mixed type, the dermal. So that takes little longer time, and we have to counsel the patient accordingly. Our patients has a tendency, they come once, they think that it has to go.
Yes.
So proper counseling, that it will take little longer time. They may require the second line and third line of therapies that we have to counsel. That plays a role definitely in the treatment.
Absolutely. So yes, to take a proper history, a clinical history and medical treatment if at all they have undergone, because over-the-counter use is very rampant in our country. So to ensure that they have not used topical steroids or hydroquinone-based preparations, and accordingly counsel the patient regarding the treatment course. Similarly, we also have another classification based on the point at which the deposit of pigmentation occurs. We have the epidermal, dermal and the mixed type. So do they tend to respond differently to the same treatment? And how do we
Definitely.
counsel the patient then?
Yeah, definitely. Whenever the patient comes, always the clinical examination plays a great role. We can go ahead and examine them with the Woods lamp or dermoscope if you have that. Derm light, I do have both the things. And like whenever you go ahead with the Woods lamp, enhancement of the epidermal pigment is seen. So this definitely plays a role in counseling the patient. So in which sort of like how long it may take and all that.
Absolutely.
According to SLAM, there is another type also added called indeterminate type, which is in most commonly in the dark-skinned individuals, type 4 to type 6. So accentuation of pigment happens in epidermal type of melasma, and no change with the dermal melasma, and mixed in some parts it can happen. But now the concept, as Kang et al. Has said, confocal microscopy, every melasma should be considered as mixed type because of the presence of pendulous melanocytes, which will be protruding into the dermis. So confocal microscopy is very helpful, but I don't think we started it.
Yes, ma'am.
See, actually, there is no epidermal component as such we see in our clinical practice. Mostly it is mixed thing. So we can say in other way, the ratio of epidermal to dermal component rather than dividing it into epidermal and dermal. And one more thing, the number of melanophages present in the dermal layers in the different patches of melasma, rather than classifying it as epidermal, dermal and mixed, we can according to the recent lines, the ratio of the epidermal to dermal component is more important.
True, very true. Yes, ma'am.
Exactly, that ratio, that is for us to examine. And regarding when it comes to the patient thing, once we examine and we know that it is a mixed and all that, usually what I do is I just explain to the counsel the patient, saying that, see, there is the internal layers also are involved with the pigmentation. So what we are treating is mainly the upper layers. So initially the upper layers might respond instead of telling them the negative thing. So I usually tell them the upper part usually responds within such time. So you be patient, and later we'll just think about the inner deeper part. So I explain to them there is two components, that is epidermal and dermal, which is a mixed variety. And with that, at least they'll be convinced that some part of it, even when they come for the follow-up also, they know that little, so much percentage of improvement is there, so which is the epidermal part, what we see.
Yes, ma'am. Because more often than not, even though we do start our patients on a good set of medications and counsel them regarding sunscreen use also, we do see a lot of patients come back to us and tell us that, like, okay, I've been using this for this many months or this many weeks and still I'm not finding the difference. So that is when we have to explain to them about the epidermal dermal component of the melasma and tell them that yes, it takes time. Dermal pigmentation with topical creams alone takes longer, so stay on track with the treatment. And what about the role of dermatoscope? Now here we have a patient who's probably used an OTC drug with hydroquinone combination. So do you feel that the dermatoscope has a role to play here? Dr. Shobha?
Yeah, Actually, this patient is coming from a very longer time to my clinic, and she went to many clinics in between. So she has used a lot of hydroquinone, and if you see, it's very difficult to differentiate whether it is, and why she is shifting the clinics because there is no response. So that's why so we have to, dermoscopy plays very important role here. If you see in the dermoscope, we can see to some extent we can exclude exogenous ochronosis component, where in ochronosis there will be lot of dark brown globules with the obliteration of the follicles, where we'll see in melasma proper this pseudoreticular network with there is a sparing of the follicles. And if you see in the last slide, you can see the brown amorphous area. So this is a typical of ochronosis. So we can tell the patient why you are not getting response, maybe because you using hydroquinone for the longer time. Not only the hydroquinone, even the hydroquinone derivatives also, even the resorcinol, even arbutin also, if they use for longer time, it may lead to exogenous ochronosis. That's why we, as a treatment part, plays very, using of dermoscopy plays very important role.
Dr. Rajalakshmi?
Yeah, dermoscopy is very important for us to differentiate between all the pigmented disorders of the face, like Reals melanosis, exogenous ochronosis, and then PIH, and main LPP. All these conditions we can differentiate from dermoscopy, seeing as you have rightly put all the pictures, what you can see in that. In Reals melanosis, it is always like a melasma, only it is a pseudo network, not much of a thing, and uneven distribution will be there. Whereas in melasma, you see even distribution of globules and brown dots are seen in melasma. And ochronosis, though, as Shobha rightly said, these are the features seen in ochronosis. So these things we need to differentiate.
Sorry. One more thing in exogenous ochronosis, if they keep on using even after counseling, we can see some confetti-like depigmented macules in the dermoscopy that we can't see through the naked eye. True. So that one is very difficult to reduce even after, even with the lasers also.
So yes, clinical history again and examination, and if you have your dermatoscope, scope the patient. So it helps you differentiate what other parameters may be there, and we need to concentrate on when we're treating the patient.
And also it gives confidence to the patient at the first place that what we are exactly doing and what we are explaining to them.
Yes. So they feel a little too happy that you're examining them properly, and we can probably even show the progress with the treatment on scoping and different follow-ups. So what about use of hydroquinone in your practice? Do you prefer to use it as a monotherapy or in a triple combination?
I start usually with triple combination only because it has a role in, because if at all I want to convert the patient after a few months for the peels, it has a priming effect. So I usually start with, but strictly I tell them that you should stop it after 12 weeks and come back so that I can give maintenance therapy, so that, and counsel them that it causes striae. I show actually pictures telling them how the striae are formed if you, so don't use. And in my prescription I'll write after 3 months, please stop.
Yes, in my routine practice, whenever I start working with the hydroquinone, first I assess the skin type and see that the skin is well hydrated. So before hydrating, we have to check all these, starting the hydroquinone. And coming to the triple therapy, routinely, depending on the type of the melasma, if it is a mixed type, which is little stubborn and all deeper, so I do definitely start with the triple combination, of course with the thorough counseling, that it should not be used for very prolonged time. And I do call my patient once in a month or 6 weeks and do assess, and we shift over to the plain hydroquinone and other combinations like CUTICON and then kojic acid preparations, niacinamide, arbutin, etc. in combination, once in the day and once in the bedtime. And that's like 6 to 8 weeks and not beyond. And after that, sometimes if the patient is stubborn and all, slowly responding, partially responded, I shift this onto the weekend therapy, triple combination, and put the patient on other non-HQ preparations.
Absolutely.
I don't use triple combination. And even hydroquinones also very, very less in my practice. What I've seen, only few patients, I think. That too with the 2% and 3 to 4 weeks. It is very, very, very rare. But usually I don't use.
Yes, ma'am.
Even that, still the hydroquinone is a gold standard for therapy for the melasma. we can start with 2% hydroquinone. If it's not responding, we can increase to 4%. Only thing is, like the triple combination, we have to write very clearly in our prescription for a limited, whatever the time we are prescribing, they have to use for that period of time only, and they have to come. If they miss the repeated visit also, they have to stop that one. That has to be mentioned even with the hydroquinone also.
So triple combination, particularly the modified Kligman resin.
Yes.
And even the latest US guidelines also, they do suggest to start off with that. They do indicate the usage.
True. Yes. So it's more important to counsel the patient very well to use the triple combination only for limited time duration. And it's also probably safer to take a consent nowadays, because with the word steroid being used by the media left, right and center, we have a lot of patients questioning whether even topical steroids, do they cause any negative effect? In Kligmans, we do have our topical steroids. So probably take a consent at the first consultation and then start the patient. Mention in your prescription the time duration as to which they have to use the hydroquinone or triple combination, and move on to maintenance therapy accordingly. So what about role of tranexamic acid? Yes, please.
I have done study in our Gandhi Medical College on 50 patients. Yeah, I used oral because oral tranexamic acid in those patients, and it worked very well. We have given 250 mg BD for 3 months along with a broad spectrum sunscreen, and then after 3 months we followed it up. So it worked well, but and then after that follow-up period, we have shifted them to topical tranexamic acid. So as you all know, the tranexamic acid is a synthetic derivative of amino acid lysine, and it has a plasminogen, inhibits the plasminogen keratinocyte interaction. So it works very well, and it worked very well in my study.
Yes, ma'am. There's a vascular component to melasma. This has been established now, so it works well because of this case. Anybody? Yes, ma'am.
Tranexamic acid, we can say, is one of the very useful drug in melasma. Why? Because it is targeting almost all etiological factors, all the pathogenic factors in melasma. If you see the vascular component, it will decrease the vascular endothelial growth factors. And one more thing, it's a recent this one, even it is able to decrease the solar elastosis also by decreasing the mast cell population. So tranexamic acid is very useful not only by inhibiting tyrosinase, it also acts in other modes of action like decreasing the mast cell. Even with when you give antihistamines also, the mast cell is not count is not going to decrease. But with the tranexamic acid, mast cell, this study has done in very recently, almost on 500 patients. They almost 89% people are got improvement in melasma.
Absolutely.
Only 1% got some deep vein thrombosis. That too, they have some family history of protein C deficiency.
Yes.
So the 500 patients, 90% improvement. It's a very, we can say it as a very useful drug in melasma.
Absolutely, it's very important to rule out presence of DVT. So take a proper medical history.
Dr. We have to actually, we investigated the patient for CBP, coagulation profile, and also hypothyroidism. And another thing is with injectable, I wanted to do actually comparative study between injectable tranexamic acid and oral. But in one article I studied that it caused necrosis. So I just did only on oral, with the oral tranexamic acid.
Yes, ma'am.
Actually, oral tranexamic acid works well compared to topical thing. It is very good drug. As Shobha told, it takes care of all the pathogenic things. And coming to what exactly we have to do, it is not only the coagulation profile which is important, it is the history which is most important. Like in the family history, if somebody is having stroke or deep vein thrombosis or anything, that we have to definitely ask and even mention on the case paper.
Yes.
And then we have to give the oral tranexamic acid.
Yes, ma'am. To add for this thing, always ask the personal and family history of CVS and heart disease before 40 years. Not after 40 years, before 40 years. This will, some way we can exclude thromboembolic events in the family.
Correct, ma'am.
To conclude, usually when we see the results, minimum 500 mg is working. Less than that, it's not giving much results. And the minimum duration when we are seeing the results is minimum 3 months after the third month. So we have to counsel the patient regarding that. So you have to go ahead and use the medication further. And this being a COVID era, thrombotic tendencies. We are seeing like we have to take the history that whether the patient had any hospitalization history and any medicines, aspirin and all, we have to check the thing. And even Covishield vaccination has vascular.
In our study, we have found only gastrointestinal side effects and oligomenuria in female patients, nothing more than that.
True, this also can be a side effect of tranexamic acid itself, so we need to counsel the patient regarding to look out for these side effects. But it's not that common though. I do have tried the injectable tranexamic acid in a couple of patients, but what I would like to stress upon is that do not use more than probably 2 ml in one session. Time your sessions between 4 to 6 weeks, but try to dilute your tranexamic acid when you're doing an intradermal injection, because being an acidic component, it has a burning effect on the patient. So you apply the topical anesthetic, EMLA cream, and then do your intradermal injections. Even that tends to give a very beautiful result. So glutathione, I think we have covered that as topical face washes, but what about oral glutathione? Has anybody used oral glutathione as a treatment modality apart from tranexamic acid?
I don't use.
No.
Now there is a lot of hype about the glutathione. Patients themselves come and ask us,
exactly.
not only just for oral, sometimes they even ask for IV. In my practice routinely, I do not go ahead with IV, but oral I do give. It has an antioxidant effect also.
Right.
In some patients, they have a lot of satisfaction, because since anyway we are working at multiple agents, never we treat with a single agent, everything works, and glutathione I do use and patients are very happy with that. Definitely an antioxidant effect.
Yeah, as long as nothing happens, we are safe. But the studies, whatever they have done on glutathione, no study has declared that it's absolutely safe. One thing here, there is a conversion of eumelanin to pheomelanin, and this pheomelanin maybe in one study I studied, it may be carcinogenic. So it's not see, nothing happens, everything is fine, but if anything happens, there should be backup. No?
So we need to have more studies to establish the safety of glutathione. So yeah. So what about PRP in patients? Has anybody tried this? Dr. Indra.
Going to PRP regarding tranexamic, topical. So
Yes.
topical, it is not working. We tried topical, but it doesn't give great results.
Maybe some patients do seem to respond, but it almost always returns.
The epidermal absorption is negligible, just like the face washes. Gluto.
Yes.
Epidermal absorption, it won't be much.
So topical tranexamic acid does not seem to help as much, but oral and maybe injectables in some limited patients with proper history does have a role to play. So coming to the next point, PRP. Whether you use regular Vacutainers or use a commercial crit, has anybody have any experience in the growth factor constant, which is all the rage now?
PRP, I have tried in some of the patients. That's as a third line therapy where they have like very prolonged time. The first line did not work. Even the peels did not give great results. So there is like more hydration effect, little lightening. In some patients, there was initially improvement. Again, it was rebound, like it was again coming back. It's not like complete solution, but definitely to some extent, it gave them initial lightening effect. I can't say it's completely clear. So definitely hydration and glow and all, they do add.
Yes. Dr. Shobha, I think?
Actually, theoretically, GFC is supposed to be good in the studies compared to PRP.
Yes.
But in experience, I have not given PRP, neither GFC.
Yes, ma'am.
Not the pigmentary component. PRP may improve the uneven texture or skin texture. In some way, it improves the skin tone and uneven pigmentation. It will help, I think.
Yes.
Not the pigmentary component is not going to be affected by the PRP.
But there are studies where PRP was helping. There are so many studies we have gone through. But PRP was helping, as you said, the texture part of it. And some part of pigmentation, because of the improvement of the texture, even the pigmentation in the superficial layers was little better. So in the studies.
PRP is an autologous thing, so it is always safe to the patient, but it has, the few RBCs, while giving, if they are there, it may break on the skin and they can, hemosiderin deposition may happen. And also one practical thing is, we should not clean the face with the betadine before injecting PRP. And coming to the growth factors, recently these growth factors are coming, the medical reps are coming. So they contain transepidermal growth factors, fibroblast growth factors, and also the platelet-derived growth factors. So they all improve the collagen level. So the shiny, the elastosis part will be taken care of. So if Gandhi doesn't become COVID, we may do a comparative study, if sir agrees, between this.
So yes, PRP does seem to have a role to play, but not as a monotherapy. I mean, maybe as a combination approach. It does give an overall improvement. Maybe not a lot of difference per the pigmentation per se. There is some amount of sparing effect noted. That is, only some few patchy areas respond, but some of them tend to retain. So this patchy effect is seen quite evidently, but it can be probably combined as a pre-function kind of a treatment option to the patient, because the overall effect on the face is good. So maybe that way. So what about chemical peels? I would just like the panelists to quickly name their most preferred chemical peel. We'll move on to the next questions.
I do prefer gel-based combination peels.
Dr.
Glycolic, salicylic, mandelic combination peels. They're very safe. There is like buffered peels with pH and pKa value balanced.
Yes.
And we can very boldly go ahead and use, and for longer time also we can keep.
Okay. Dr. Shobha?
Glycolic peel, I prefer glycolic peel, 35%, because it's a superficial peel. It's safe, and one more thing we have to tell about the patient, to the patient is only the epidermal component is going to improve by the chemical peels. And before going for chemical peels in our Indian skin, always assess the post-inflammatory pigmentation tendency. We should not make more worse rather than improving it. That's why always choose the chemical peel and choose the depth of the chemical peels by Robertson hyperpigmentation tendency scale. And after that, glycolic peel 35% is I prefer, and even the leave-on yellow peel is also good. And very rarely, not in the very dark skin people, TCA peel with phenol is also works well.
Dr. Rajashmi ma'am, what is your preferred peel and how many sessions would you advise for the patient?
I usually go for glycolic or this mandelic peels, but 5 to 6 sessions, but still recurrence is there, everything, but I'm also not very happy, but I explain to them, and then if they really wanted the peels, see, apart from the peels, even I continue my sunscreens, I continue my other demineralizing agents also. So then I explain to them and take the peels. And once there is much improvement after 3 peels or something like that, then I go for one more and then stop it. It's all depending upon the improvement also.
So chemical peel is an add-on.
Not like a fixed like 5 peels, 6 peels or something. It all depends upon the improvement.
Absolutely. Dr. Satya?
I tell.
Yes. Yes.
Just before, 3 days before and 3 days after giving the peel, I ask them to stop all the priming creams. So because priming creams, and for yellow peel, during the winter months, the peeling effect will be more. So we should be cautious.
Sure.
Priming is a very important thing. We have to, and after doing the chemical peels also, maintaining with the topical depigmenting creams is very important.
Absolutely. Do not jump to the procedures at the very beginning of your consultation. Prime your patients, take proper history, take proper consent, and only then plan for chemical peels or laser in the following sessions, depending on how they're responding. What about role of lasers, doctors?
Yeah.
Dr. Shobha? Yeah.
Yeah, lasers, after seeing in the dermoscopy, if you think it is a dermal, pure dermal component, we have the only choice we left is the lasers. And the lasers, as already explained by the previous in the panel discussion, it's a Q-switch Nd:YAG laser.
Absolutely.
It should be the long pulse, and it should be the spot size should be large spot size and multiple passes. This multiple passes plays very important role. Why? Because we are not causing any cell death of melanosomes and keeping the cell membrane very intact. So we are just breaking down the melanosomes and causing the dendrectomy of the melanocytes.
Right.
So in that way, we are not completely removing the melanocytes. So that's why the relapse is very common, and the counseling is very important, and multiple sessions are needed for the Q-switch Nd:YAG lasers.
Absolutely. So Q-switch Nd:YAG is the gold standard here, supposedly. So low fluence, bigger spot size, and higher frequency. This is preferably used. We'll next move on to the next topic, periorbital melanosis. So here, how do you approach a periorbital melanosis patient? Dr. Shobha, I would like to point this question to you. Is it important to determine the cause of POM?
Yeah. see, we know periorbital melanosis has a multiple complex etiological factors. If you see in the first picture, it's not a typical periorbital melanosis. It is a case of exogenous ochronosis because she is keep on using the hydroquinone from the longer time for the lichen planopigmentosis. So I have not done biopsy, but the thing is, when I have seen in the dermoscopy, there is a almost a brown amorphous hem-like pattern of pigmented macules and with a follicular plug, perifollicular accentuation as a previous in the previous. So even the LPP also may extend beyond the malar area. So we have to think beyond the out of the box. And the second thing is she has a allergic contact dermatitis to the hair dyes.
Yes.
She applies very frequently, and if you see, there is a lot of structural changes in her. We can see tear trough deformity very clearly. So the etiology is very, very important, and there is a multiple etiology. We can't tackle only one etiology. It's like
it has to be a multimodal approach.
Multimodal approach. Yes. And the last case, if you see, it's like you can see other areas. We can easily diagnose by seeing the forehead thickening hyperkeratotic area. It's a facial acanthosis nigricans. So the proper history, proper examination using the dermoscopy judicially plays very important role in diagnosing periorbital melanosis.
Dr. Indra?
Yeah, as rightly said by Dr. Shobha, there is a classification of this by Huang where there are 4 types, the physical and then vascular, pigment and mixed varieties, which is definitely based on the cause. So this cause determination helps us in the management.
Yes, so what's the role of stretch test?
Yeah, stress test is a test where we pull the skin below the eyelid and pull it down and check. Here, if it is because of the physical cause, like increased laxity of the skin, or because of the aging, you have tear trough, this disappears. If it is because of increased vascularity, it doesn't disappear, it stays back, and there is like more pigmented appearance.
Pigmentary demarcation lines also.
PDL. So they do not disappear.
Yes. So by doing the simple stretch test in your OPD itself, you can counsel your patient regarding the prognosis of the periorbital melanosis and hence plan the treatment course for them. Okay. So what about the topicals preferred in periorbital melanosis, Dr. Rajlakshmi?
And one more thing is about the causes of periorbital melanosis. I mean, commonly we are coming across all the fungal infections nowadays. It is like tinea incognito or anything after, once the fungal infection is treated also, they come with pigmentation. So that aspect also we need to keep in mind. And then coming to, any topicals for, pigmentation, periorbital, it is a sunscreen. The first thing is the sunscreen what we give.
Absolutely.
And other demelanizing agents, I usually don't give every day. It is a milder demelanizing agents we can give, like alternate day or a weekly therapy. And then I ask them to just apply a little away from your eyelid closure margin, and then continue the thing for 2 to 3 weeks and then follow it up.
Dr. Satya?
I usually examine the patient because atopics may have the dryness which may cause the periorbital melanosis. So I give a lot of moisturizers to them, and then haloxyl peptide, haloxyl containing products, retinol, especially the microformulation ones, the microsponge technology, microbeads technology, they are very helpful because the irritation comes down. And also peptides and retinol.
Yes, so retinols and peptides are quite commonly used, especially with the micro-nano encapsulation technologies.
And also about the contact dermatitis, like see, yesterday, the patient what I have seen, there was nothing in the periorbital melanosis to see. But after seeing her application of nail polish, different nail polish to each nails, so I could at least tell her that it coincided. The day she applied the thing, she developed the lesion and then developed the pigmentation.
Yes.
So these smaller things also we need to keep in mind.
So history is quite important. Determine your cause and then plan your course of treatment. So please.
See, this periorbital melanosis, what we talk about, is a genetic condition which runs in the familial. What you are talking is all PIH secondary to things. So we should have a clear concept about how to treat them.
Yes, sir, definitely.
Absolutely. So Dr.
That's
Satya?
why the family history is very, very important. And one more thing I want to point out is PDL lines.
Absolutely,
See,
yes.
even the PDL lines, we may be confused with the periorbital melanosis. So you have to check the family history. As sir told very correctly, PDL lines cannot be treated with whatever
Yes.
the thing.
In that case, the patient has to be counseled. Like, this is not something you can treat, this is something you have to learn to live with.
Like lack of sleep,
Even in the melasma also, repeated use of hydroquinone also leads to pigmentation just below the lower eyelid. That is also one of the etiological factors.
So we'll try to wrap up in another 5 minutes.
History of drug usage also, like parenteral goal therapy and metals.
Yes, Dr. Rajita, please.
Good afternoon. So PDL has been treated with a Q-switched LX way back in 2005. And if you're going to do around the eye, then obviously a metallic corneal shield is needed. So that is something that I do with pretty good outcomes. But if you don't know how to handle a metallic corneal shield, remember the cornea doesn't forgive.
Absolutely, absolutely. It's quite important to use the corneal shield, especially when you're doing any laser, any type of laser around the eyes.
I want to add one more thing about investigations. Serum vitamin B12 deficiency, anemia and hypothyroidism should be ruled out before starting the
Yes,
treatment.
Dr. Satya, absolutely. So that's what, proper history, proper examination, all of this is necessary to find out the cause of the POM and then accordingly to plan the treatment further. So it's almost done, sir. It's almost done, sir. So anybody for role of PRP, HA fillers, threads, or even cosmetics?
PRP is not separately done. Whenever we are doing for whole face, we do see some betterment.
So with respect to PRP and fillers, basically it's the hydration effect that they give and correction of tear trough deformities, if any. So age of the patient and if any laxity of the skin is present, that is what it gives a correction, and that's why it gives a lighting effect on the periorbital pigmentation. Now in this case, the elderly lady at the bottom, there's a lot of skin laxity. So probably threads and fillers to an extent makes a good difference. Over there you can see the eye bags also. The younger patient on the top, she had underwent a PRP session. You can see the before after within a week's difference. Whereas this patient on the left, of course, there's a whole lot of anti-aging effect also with the HA fillers, but you can see that the periorbital pigmentation also has lightened quite significantly.
Actually, in the infraorbital area, threads you should be more careful because of the pinpoint bleeding spots also will be seen.
Yes.
If at all there is a mid-face, sagging, then the voluma helps to improve that.
Yes.
Yeah, on both sides.
So for the tear trough alone, just a hydration effect is good enough. So that, and probably depending upon how much of laxity is there, then probably you have to determine the type of HA filler that you have to use to give them a better effect. So moving on to lip melanosis. Of course, what are the common causes for lip melanosis? And again, why is it important to determine the causes? We know that our patient can present to us in multiple reasons. ICD-2 cosmetics or any dental hygiene products, presence of cheilitis, smoker's lip itself, lentigens, and sometimes they may have just the opposite way, that is lightening of the pigment skin at the corners of the mouth or just at the center of the lips, and even that can present as darkening of the lips. So with this, again, how commonly do you come across these conditions, and how commonly do you see perioral seborrheic melanosis in your practice?
Actually, in my practice, it is very common, what I see in children, because of the lip smacking and eating the bubble gum and all that. And even people who are eating chips also, because of the powder, what is happening, even in those children also, I have seen a lot of cases. And even seborrheic melanosis also, it is common in my practice.
Quite common. So, Dr. Shobha, what are your choice of topicals depending upon the various etiologies? Do they vary, or do you feel that simple topicals are sufficient to contract all the etiological factors?
See, if you see the pigmentation causes seborrheic melanosis, we have to treat seborrheic dermatitis very promptly.
Absolutely, yes.
Starting the oral itraconazole, then go for the topicals, and maintain the barrier function is very, very important around the perioral area. It's whatever may be the cause, whether it is a cheilitis or pigmented cosmetic dermatitis or seborrheic melanosis, maintaining the barrier is very, very important, and a proper lip balms, and not the colored one or not the perfume, this one.
Yes. Dr. Satya, what ingredients do you look for in case of lip
along
balms?
with the etiologist you told, I want to add LP as one of the cause,
Right.
and also FD is also commonly we see on the lips.
Right, right. Dr. Satya, do you have any preference for ingredients in lip balms? Any particular thing?
No, all the lip balms now they are coming with SPF 30. They have SPF 30 or means the sunscreen. So they have the moisturizing effect. So the chapping of the skin will itself help the patient not to lick the lips and also it helps them to these usually they contain this waxes. What?
Beeswax,
Yeah,
petroleum
beeswax,
jellies,
castor oil, and also sunflower oil, along with the sunscreens like cinnamates and salicylates. So they are helpful.
Yes. Dr. Indra, in case of lip cosmetics, what ingredients to avoid? Is there any specific items that they have to avoid?
any metals which cause irritant dermatitis.
Yes.
And
To-
fragrances, perfumed, better
Absolutely.
avoid.
So probably do a patch test when you're seeing that there's a chronic lip pigmentation and they have a constant use of lip cosmetics. So is there any role of oral medications in seborrheic melanosis?
A definite role is there. Particularly we go ahead with oral itraconazole, even oral fluconazole, pulse
Yes.
therapy we go ahead with.
Anybody prefers using oral isotretinoin? Low dose isotretinoin?
If it is not responding to the oral itraconazole, we can use low dose isotretinoin if you are associated with a seborrheic scalp.
Yes.
Like a very
So
chronic
seborrhea on the face, seborrheic dermatitis on the scalp. In these case of patients, low dose oral isotretinoin for probably 4 to 6 months.
With acne and severe forms of
Yes.
seborrheic melanosis.
It helps quite well. So again, importance of sunscreen. Yes, we have a lot of lip balms available with sunscreens already in them. So what about chemical peels for lips? Dr. Indra?
Again, we can try gel-based buffered glycolic combination peels, even arginine peel, lacti
Yes.
peel.
Yes.
We can try with variable results.
Yes. So here probably the lactic acid and arginine peels, they give a hydration effect and that gives that immediate lighting of the pigmentation. That helps to some extent. But of course the prevention of the causative agents and topical applications are what are the mainstay over here. So in this patient, would you prefer treating her lip pigmentation? Do you feel there's a component? Do you prefer treating? Not.
Here it is more of shadowing effect.
Yes. And what about this patient?
It's like more cheilitis is there. So you have to check even for the vitamin
Right.
deficiencies and
Right.
correct that.
Absolutely. So yet again, the proper history examination, investigations, and then plan treatment. So, sorry, yeah, lasers. Sorry, I missed that. So any lasers preferred? I
Q
think
switch
Q-switch
NDI, glass spot size with very low fluence, particularly less than 0.5 joules. We can.
Absolutely. What about role of HA fillers and PRP?
Definitely HA fillers have a role. Low molecular weight HA fillers we can try for the lip. And PRP we have not tried. Definitely for the melasma it's not giving great result. If you want to try, just check. Hydration effect may be there, which lightens the volume of like pigment. Doesn't remove the pigmentation as such. Because of the volume adding effect and hydration, it lightens the pigmentation appearance.
Absolutely, absolutely. Dr. Shobha, do you feel cosmetics have a role to play in case of periorbital and lip pigmentation? Because these are conditions which don't respond very easily to our therapies that we have right now.
Yeah, we can use
So-
as a cosmetic camouflage.
Exactly,
Like
yeah.
a tinted lip balms, like ferric oxide, but we have to be very careful. It should not cause any cosmetic dermatitis.
Absolutely. So we do have a lot of cosmetic brands which are skin friendly, do not cause any allergic reactions also. So even in case of vitiligo patients or our patients with facial melanosis due to various causes, we can have matching of the color, skin color, and accordingly they can use it for a limited time duration, especially when they have to attend any important meeting or a function.
So nowadays
Yes,
for
Dr.
lip
Indra.
pigmentation, we are getting some of the even lip balms with just like kojic and arbutin niacinamide
Yes.
preparations. When I tried in some patients, they were tolerable. We tell them to thoroughly use lip moisturizer in the daytime 2 to 3 times. Bedtime they can apply these preparations, very little quantity, and most of the patients were tolerable and it takes little longer time. These patients they complain of itching and irritable sensation. So if they do not have that, we can ask them to go ahead and use them. Now we are getting these preparations.
Absolutely. I think with this we come to the end of our discussion. Thank you, my esteemed panelists, for the wonderful discussion. If there's any audience question, one or two, we would like
Before
to take
we wind up, any questions from the audience? Regarding the pigmentation, any questions? Okay. Anybody in the audience? No questions, no doubts at all? If you don't, then I will have to ask Satyasri one question. You said you did a work on tranexamic acid. You said coagulation profile. What are all the components you did in that?
In our study, I have done PT, APTT, INR, CTBT
Yes,
also,
yes.
CTBT also, coagulation profile.
So you did coagulation profile total. And Madam Shobha has also said about something as C protein, she said in the passing statement. So what is that? And then we have to do that.
See, that's why the role of doing CT, BT, APTT, it doesn't have any role before starting the tranexamic acid, rather than taking the proper history. Any history of CVS, even the heart disease is very important, what I prefer. Because the CT, BT, APTT is almost normal for every patient. And it's very difficult to identify familial C protein, all these things, very rare diseases, and we can't do all the investigations.
Yeah, can I ask the panelist and Dr. Rajita also one question which is common sense? Say you are all insisting on using the eye shield when you are using a laser around eyelid. I have my own doubt. What is the thickness of the eyelid, upper eyelid? You have skin, you have orbicularis, you have a tarsal plate, you have a submucosa, so it will be nearing more than 1.5 millimeters. What is the penetration of a CO2 laser when you do a single pass? 35 to 50 microns. Then why are you so afraid to use a laser on the eyelid?
Dr. Rajita? Yeah.
So with CO2, you could probably take a chance, but there have been reports of blindness reported with YAG lasers. Now we were talking about, no, not with the eyelid open. When it was used for treatment of eyebrow hair, long pulsed Nd:YAG has been reported to cause ocular field defects. Now, if that field defect happens to be in the macula, then there is going to be total blindness because the retina is full of pigment. Now, with the CO2, which is not absorbed by melanin, it is a different story. So there I would not want to comment. But I think it is generally not a good idea to use it there because do we understand what happens when a laser goes in? And when you're talking about something that is very thin and it's a fluid-filled structure, the globe is fluid-filled. So in water, how long can these things penetrate? Now the vitreous is a little thicker than water. So do we have studies to show that this is safe? And when it comes to a cosmetic treatment, I think primum non nocere rules. So that would be my message. So if it is a YAG laser, do not take a chance. Absolutely. The problem is No. So if you read up the literature, there have been reports of eyebrow LHR. Now there was a time when we used to do eyebrow LHR. We don't do it any longer because it is not worth the risk, especially below. So what I understand is once it goes into the globe and whether the thing is going to go directly, whether there's going to be a little refraction, scattering, going back. Do we understand laser physics that well? Once there is an evidence, I don't think we should take a chance. Now, so I wanted to make a point.
Suppose we use a shield, corneal shield.
Sir, the panel is there.
When you are talking about blindness,
yes.
I am saying. Huh?
Rajita said there may be accidental exposure to the laser, and especially with the Q-switch laser, even the retina has a rich of melanin content. So if anything accidental exposure, it may lead to blindness. That's why
Even nobody accept the blindness because of the cosmetic lasers. That is very
I wanted
important.
to make a point about the CT, BT, APTT, INR and all that. Now, my basic question, which I've asked in multiple forums is, are we scared of bleeding or are we scared of clotting? When you're giving, no, we are not scared of bleeding, so we are scared of clotting. When we are giving, so, no, not really. So when you're giving tranexamic acid, what are you scared of? You're scared whether this person is going to have an intravascular clot, which your tranexamic acid is going to prevent from getting lysed. So doing all these things is going to tell you if there's a bleeding diathesis. Whether it's going to tell you about a risk of intravascular coagulation, it doesn't. So what I personally do, in addition to what Dr. Shobha said, is a lipid profile and a serum homocysteine, especially after a certain age. And if there are things like smoking, the things like sedentary lifestyle and obesity, then you would want to be wary.
And one more thing I want to point out here is the gynecologists, the dose they are using for menorrhagia is much higher. So the what we are using is very less. They are using almost like 3,000.
But that is short term.
Short time, for 4 days.
As of now, for oral tranexamic acid, we do not have evidence for use for more than 6 months. So mind it. So once you start seeing some clinical response, start tapering the dose. 250 milligram BD is what is approved for now.
So then, panelists, any of these panelists can take this. How do you treat peribuccal pigmentation of Brock?
Peribuccal. I think topical immunosuppressant.
I don't know, but usually in men it is more common, and they use non-steroidal anti-inflammatory drugs that cause pigmentation, pigmented contact.
Shobha, you said TCA pill can be used in melasma. What percentage of TCA, how frequently you do for TCA?
We should not go beyond 20%, 10 to 20%, because I should not mention the brand name, but that has 15% of TCA. Only thing is, we should be very careful when we are doing the dark skin people. There is a lot of PIH.
Chance of PIH is very high, and of course to properly prime the patient prior, and sunscreen use, strict sunscreen protection, even if they are endorsed, frequent sunscreen with TCA.
So I think with this beautiful session, a lot of information you have shared. Thank you for that. And I thank the moderator, Dr. Aradhya, and as well the panelists, Satyashri, Shobha, Indira, and Rajalakshmi Garu. And my colleague Ramesh, we both together, we thank you and the audience for the wonderful questions, and hope the time should have been little more, because this is a never-ending question-answer sessions. Thank you, Aradhya.
Thank you, sir. I would like to thank my esteemed panelists, Dr. Rajalakshmi, Dr. Satya, Dr. Shobha, and Dr. Indira. Thank you so much.
Thank you, sir. I thank the organizers for giving us this opportunity. Thank you, one and all.
Yeah, thanks to the organizing committee for giving.
జ్యోతి ప్రజ్వలన ఇక్కడ పెట్టండి, చైర్స్ ఇక్కడ పెట్టేసి. ఉన్న చైర్స్ అని పెట్టండి, 6, 7. అది ఇక్కడ తెచ్చేసుకోండి స్టాండ్. ఇక్కడ మధ్యలో పెట్టేసారు, అంటే సైడ్ పెడితే అందరూ రారు, ఇట్లా అయితే ఇట్లా వచ్చేస్తారు కదా, తర్వాత తీసుకెళ్ళి మళ్ళీ సైడ్ పెట్టదు.
Now the next session is the inaugural function. Kindly be seated for another 5-10 minutes. Thank you, sir. Thank you. లీవ్ పెట్టి మరీ ఇచ్చేది.
పెట్టండి మేడం.
I now invite our President of TS IADVL Telangana, Dr. DBN Murthy sir, onto the dais to start our inaugural function. And today's chief guest is Dr. Putta Srinivas sir, who is our first and former DME. And our guest of honors, Dr. Raja Rao sir, our Superintendent Gandhi Hospital. Dr. Lingamurthy sir, General Secretary of the Alumni, Gandhi Medical College. Kindly welcome, sir. And Honorable General Secretary, Dr. Bhumesh Kumar sir. Treasurer, Dr. Janardhan sir. And our President-elect, Dr. N. Ramesh sir. Our immediate past President, Dr. Vani Patale madam. Scientific Chairpersons, Dr. Neta sir. And Scientific Co-Chairperson, Dr. Sudharani madam. Vice Presidents, Dr. Geeta Madam, Joint Secretaries, Dr. Rajita Damishetty and Dr. Raj Kirit. Kindly welcome to the dais to start our inaugural function.
ఇట్లా పెట్టేసి ఇటు కార్నర్ చీర ఒక్కటి తీసుకోండి.
Jyoti Prajvalna and prayer song.
विनायक नमो नमः अष्टविनायक नमो नमः मंगलमूर्ति मोरया ओम गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया ओम गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः मंगलमूर्ति मोरया ओम गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः मंगलमूर्ति मोरया ओम गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः मंगलमूर्ति मोरया
Now I request our President Sir, Dr. DBN Murthy Sir, to kindly give his welcome address.
Good afternoon, our chief guest, Dr. Putta Srinivas Garu, my friend and classmate, Dr. G.R. Lingamurthy, who is a General Secretary of Gandhi Medical College Alumni Association, President-elect Dr. N. Ramesh, Scientific Co-Chairperson Dr. Narasimha Rao, Co-Chairperson Dr. Sudharani Madam, Vice President and Joint Secretary, Treasurer Dr. Bhumesh, everyone on the dais, I welcome them to this inaugural function of pre-conference workshop. I thank you all for participating in large numbers. I am thankful to the entire scientific committee, the staff of Gandhi Medical College, for giving us all this scientific support in conducting this conference. And I thank the alumni, Gandhi Medical College Alumni Association person, Dr. Lingamurthy also, for giving us this venue free of cost for conducting this workshop. And I wish in the morning session the program was a grand success. I hope the entire 3 days sessions will be highly successful and academic and informative, and it is a good platform to share your experiences physically. After a very long time of going through webinars, we are having the first time a physical conference. And I thank the entire executive body who was with me in supporting me and the entire organization of IADVL for conducting all the programs throughout this year. Now, I give back the mic to the organizers. Thank you very much for giving me this opportunity.
I now request our Honorable General Secretary, Dr. Bhumesh Kumar Katkam, to address the audience.
Respected dignitaries on the dais, our chief guest, our friend of the Dharma family, the senior most dermatologist from all over India. So we are so fortunate having him as a chief guest because he was the first, the DME of Telangana. So thank you very much, sir, for accepting as a chief guest. And our guest of honors, Dr. Lingamurthy, sir. Always, whenever you say, sir, we are going to have one CME, and Bhumesh, go ahead. Without any hesitation, thank you so much, sir. Even leprosy day, all leprosy CMEs, all we are going to conduct here only with the free of cost. Thank you so much, Lingamurthy, sir. And we request in future also the same, it should be continued because these academic activities for the updating of our knowledge, especially our younger generations. Because Lingaya sir also, because of some personal problems, he could not come, and Superintendent Dr. Rajarao also, because of his some personal problems, he could not come. And our the President-elect, Dr. N. Ramesh sir, and my friend Treasurer, Dr. Janardhan, and Scientific Chair and Co-Chair, Dr. Neta sir and Dr. Sudharani ma'am, and Vice Presidents, Dr. Geeta, and Joint Secretaries, Dr. Rajita and Raj Kirit. Thank you very much for having here. And a big thanks to all the delegates. So, because after 2 years, the COVID had made us almost, it's the collapse. So, whether to conduct the CME in a physical, it was a big challenge, but because of your support, almost it has crossed more than 400 registrations. It's a big time to us, and thank you very much on behalf of Team CUTICON 2021 for your active participation. We request you to the same, it should be continued for tomorrow and day after tomorrow, because the CUTICON 2021, it's a blend of academic activities, awareness activities. Even we request all the delegates, please, we have 2 standees. One is awareness on the theme IADVL. Please take a photo and send it to us. So we will circulate in the social media to create awareness. And even we are COVID awareness stand is also there. Please take that photo. And academic activities, the 3 days feast is will continue. So we request everybody to be here and support the academic content. Till January, on behalf of our team, we have done almost 230 activities, whether it's in the form of awareness, COVID activity, Chalo Gaoki, and Chalo Patashala, all the activities because of your support. I should say very big thanks to my President, Dr. D.V.N. Murthy sir. Whenever we say, sir, can you go ahead? So because of his support, we could do some activities. Almost it is in the history of IADVL which has crossed. And in 2019, 48 activities was the highest when Dr. Neta was a president. And now we have crossed 230 activities. All because of your support and activities, and especially all HODs, those who are there and sending their PGs, and for the paper abstract submission, almost we received 159 abstract submissions for the paper presentation. Almost it is also one of the highest number. With all your HOD and with all your supports. And with this, I should say very big thanks to all of you, and please stay tomorrow and day after tomorrow for this scientific bonanza of CUTICON 2021. So thank you very much. Over to Dr. Kavita.
I now request our guest of honor, Dr. Lingamurthy sir, General Secretary of the Alumni, to please address.
Presiding Officer, the President, Dr. D.B. Narayan Murthy, Chief Guest of this conference, former Director of Medical Education, Telangana State, Dr. Putta Srinivas Garu, my friend Dr. Bhumesh Kumar Garu, and other dignitaries on the dais, my dear friends. I am extremely happy to be amongst you on this happy occasion of inaugural session of 7th CUTICON conference. For the last couple of years, just now as Umesh Kumar told, because of the COVID pandemic, we couldn't have physical conferences. After a long time, slowly we are coming to the physical meetings and physical conferences. But at the same time, we should be very, very cautious and careful because of the Omicron. That also we have to keep it in mind, and we should take all the precautions to prevent the spread of this infection. And we are extremely happy for this dermatologist, your conference. You are utilizing our alumni auditorium. For the last couple of years, it was vacant because of the COVID pandemic. And whatever the scientific sessions in any field, it really helps the young dermatologists to improve their knowledge, and they can listen to the senior colleagues of that profession. And for the 3 days conference, today is the inaugural session. And I welcome you all for this conference on behalf of Gandhi Medical College Alumni Association members, and wish you all the success. Thank you. Thank you, Ronald.
Thank you, sir. I now welcome our chief guest, Dr. Putta Srinivas, sir, our first and the former DME of Telangana, to address.
Good morning to all of you. At the outset, I apologize for coming late by 10 minutes. The reason being that we are all have a lot of social obligations, Attending the marriage of Dr. Srinivas Rao, the Director of Public, his daughter's marriage at Kompally. Good morning to all of you, respected President of TSADVL 2021, Dr. DBN Murthy, and Alumni Secretary, Dr. Lingamurthy Garu, and Secretary, Dr. Bhumesh, Secretary, Dr. Janardhan, and Scientific Chairperson, Dr. Neta, and Dr. Rajita, and Dr. Geeta, and all the incoming President, Dr. Ramesh, and all the guests, and my dear colleagues, Dr. Manmohan, Dr. Lahari, Dr. Dayal Singh, Dr. Subhash, Dr. Banjarani, Dr. Madhubabu, and Dr. Rajalakshmi, Sudha, and all of you, Dr. Annapurna, Dr. Padmaja Madam, all of you, good afternoon, but it's like homecoming. After the COVID, we are meeting physically after a long gap of 2 years rather. But still we have some lurking fear in our minds regarding the third wave or Omicron and all these things. And thanks to the COVID virus, now we are learning the Greek language, alpha, beta, delta, gamma, now Omicron. So first I would like to appreciate the efforts of GMC Alumni Association, Lingamurthy Garu and Lingaya Garu, for having such a nice alumni building here and maintaining for almost more than 20 years, I remember. Because nobody has time for social cause these days. Everybody look after themselves. But all the office bearers of Alumni Association and the Devu guidance of Lingamurthy Garu and Lingaya Garu, they are doing very nice job maintaining it and keeping it going and giving priority for academic activities of various organizations and sparing a lot of personal time and family time also. It's not that easy to forego all these family comforts. Let us give a big round of applause to GMC Alumni Association. And at this juncture, I would like to place on record the service of Dr. DBN Murthy, very silent person, but very effective and dynamic. He has been contributing to association for almost more than 3 decades. And he has come to the top. He has gone to Delhi and he has come back. He was national treasurer. Now he is the president. He was president by little late rather. He would have been president long ago. But he never desired a position. He wanted to be unassuming and very simple as much as possible. But still, big congratulations, Dr. D.V. Murthy garu. And the Secretary Bhumesh, with nothing to much add now. For the reason that you go to any part in the country, if you say Hyderabad, they'll say, how is Bhumesh? That's how popular he is. TS IADVL, and if you go to any part of IADVL activities, if you're from Hyderabad, they'll say, how is Bhumesh and how is Bhumesh activities. He has become so popular and with dynamic activities and public enthusiasm all the time. Big congratulations to Dr. Bhumesh. And Dr. Janardhan, another one of our students from KMC Warangal. Very unassuming, silent, but very dynamic leader as a organization. I know him. He contributes a lot. Big congrats to Dr. Janardhan also. And welcoming to Rajita, her competitive Itatsa activities and how he fights out for a common cause. A menace of steroids, both systemic and topical. Systemic is not much, the different page altogether, but as topical steroids are concerned, the big fight involving such a machinery in the government and private and judiciary. It needs a lot of tenacity, persuasion, determination, sometimes to ignore. People hurl stones without knowing basics of how these things get resolved. They don't have patience. But still, let us give a big round of applause to our own Rajita for carrying the fight. Carrying the fight with in the Supreme Court, in Delhi High Court, then Supreme Court. We have very eminent lawyer Gonzalez, a prominent lawyer in public causes and PI litigations. Let us hope it materializes soon. Then that Neta is becoming young day by day. As the president, now he is a scientific committee chairperson. And he is doing not only the job of HOD of Department of DV in Gandhi Hospital and Medical College, as well as he is the deputy superintendent of the Gandhi Hospital in difficult times of this COVID pandemic. So big congratulations, Dr. Neta. And all of you, this pre-conference workshop, I have been told, get maximum more than 250 members attending physically and more than that attending virtually also. So I wish this pre-conference workshop all the success and it will be timely maintained. And also the next 2 days of the academic feast of conference of on 25th and 26th and big academic activities and other activities of social activities also. They have planned very well. I wish the conference all the success and wish this pre-conference workshop also all the success. And last but not the least, it's my duty to place on record. Thanks for giving me the opportunity to be the chief guest today's inauguration of this particular pre-conference workshop. It's always coming an occasion of happiness to share and spend time with all of you as a guest, as a faculty, as a delegate, as a friend also. Thank you very much for your patient listening. Thank you.
The next session is honoring our guests. I request our DBN sir, the president, to honor our chief guest, Dr. Putta Srinivas sir. Followed by our guest of honor, Dr. Lingamurthy sir. ప్రెసిడెంట్ ఇప్పుడు ఇచ్చారు కదా ప్రెసిడెంట్ నెక్స్ట్ ఆయన ప్రెసిడెంట్ Next, our President, Dr. D.B.N. Murthy, sir. Followed by our President-elect, Dr. N. Ramesh, sir. And immediate past President, Dr. Vani Patale, madam. Followed by our General Secretary, Dr. Bhumesh Kumar, sir. And our Treasurer, Dr. Janardhan, sir. Our Vice President, Dr. Geeta. Next, our Joint Secretary, Dr. Rajita Damishetty. Followed by our Scientific Chairperson, Dr. Neta, sir.
కవిత గారు
ఇప్పుడు గుర్తుపడదు తెలుసు
Next, finally, vote of thanks by our General Secretary, Dr. Bhumesh Kumar sir.
So thank you very much for all the dignitaries and the chief guests for accepting our invitation and all the delegates for your participation. So I request all the members please join for lunch. Again, we will restart the post-lunch session sharp at 2 o'clock.
and at least two of the panelists decided to either fall ill or go out of town at the very last moment. And one of them apparently had excused herself well in advance, but we did not get that information. So sincere thanks to John Avitas, because of which I put his name in a highlighted thing, because he agreed to do it at absolutely the nth hour at 12:30, I guess. So thank you so much. Now, I don't have his CV, but he is of international repute, though he comes from a place called Madurai. He is an alumnus of Manipal, and he finished his dermatology degree in 2003. He forayed into light-based hair reduction, and he is the IPL man of India. So he started off with IPLs in 2005, and since 2007, he's used laser hair reduction devices extensively, and I'm looking forward to hearing his inputs about the various questions that I have lined up. And Dr. Srujana is a alumnus of Osmania Medical College. She completed her MD in 2006, and Dr. Swarupa, and she's been practicing in Hyderabad, and she's had more than a decade-long experience with laser hair reduction. And our young colleague, Dr. Srujana, very enthusiastic and very eager to learn. I had the pleasure of working with her during her stint in Oliva, and now she is on her own, and she's used both diode and LX devices. So firstly, I want to make this disclaimer that we will be referring to proprietary names of drugs. We will be naming specific devices because a device-based discussion cannot happen without naming them. And none of us, unfortunately, are being sponsored for today's talk in any way. Of course, we have our loyalty towards various devices. Now, I thought that we would discuss over the next, they said 40 minutes, but since we are starting early, with the permission of the chair, maybe we can get that extra time, ma'am? Yeah, excellent. So, I thought we'll have 3 hirsutism devices. In fact, I have 4, if I have time. And we'll talk a little bit about body hair reduction in both men and women. I have a photograph of pilonidal sinus. I'll talk about treating the male beard with laser hair reduction. And I'm going to ask our esteemed panelists how they manage laser hair reduction burns, what they do to prevent it, and if an unfortunate incident happens, then how they deal with it. I thought I'd also talk a little bit about paradoxical hair stimulation and white hair removal. And mainly in these scenarios, we'll be focusing on the evaluation, the pharmacologic and non-pharmacologic management, device choices, and because this is actually a workshop and not the conference per se, we will be talking about a lot of practical aspects, the parameters, the protocols, the intervals between sessions, the technique itself. So I request my panelists to keep the answers very straightforward, very practical, scientific, of course, and unambiguous. So before I jump right in, I know that there are not that many people in the audience, but could I have a show of hands? How many of you have are working with a LHR device? You might own it, you might work in a place where there is one available. Would you indulge me by a show of hands, please? How many of you use a LHR device on a regular basis? I see only 2 hands. Thank you so much, and thank you, Muti sir. Of course, we know that you're a pioneer in this. So should I assume that the others are settling in, or they don't use LHR devices? So if you're hesitating to use a LHR device, I hope this is going to change your mind. So I'm going to begin with the first scenario, and I'm going to do the honors with Dr. John here, our special guest. So what do we call you? He's got 4 names. John. Okay. So Dr. John, this is a 21-year-old engineering student. She weighed 99 kgs. She was 5'1" in height. And she had noticed the beginning of terminal hair, excess terminal hair on the face around 5-6 years prior, when she was around 14, 15, 16. She wasn't quite sure about it. And she has quite irregular menstrual cycles. So when she comes to your OPD, and I'm sure a lot of such people do come to your OPD, how do you take this forward?
Ideally, we have to counsel with the parent along with her and tell her that, you know, she has got symptoms of insulin resistance, PCOD is possibility, and we need to rule them out first, madam. It's better to get an endocrinologist opinion before we start the LHR. If a patient is on active PCOD, then preferably avoid LHR for at least 3 to 4 months.
Okay.
Because better that they start on treatment before we actually start the LHR. That's what I do, but opinion varies. And anything else?
Okay. So thank you so much. So basically, you would prefer to refer rather than investigate yourself. Is that what I assume?
Yes, ma'am.
All right. Thank you so much. And I think that's a very sensible thing to do. I have many dear friends who are key opinion leaders across the country, and many of them do the same thing. They don't want to get into hormonal investigations, but they want to refer. Now, I am a bit of a control freak and I do something else, and I'll talk about that. But Dr. Swarupa, how would you investigate this girl, or would you just refer?
Yeah, I would like to investigate this case. The basic investigations regarding, because there are signs of insulin resistance, I would go with the fasting insulin and blood glucose, TSH levels, serum testosterone levels.
Close.
And I would like to, once I get the reports, I would understand. Then if it is manageable by me, I would do that. Otherwise, I would refer to an endocrinologist.
Okay, so what do you mean by managed by you? When would you say it can't be managed by you?
Usually, in this case, I might put her on a oral contraceptive before I start any treatment. It would be, I'm used to the combination of ethinyl estradiol and cyproterone acetate. That would be for 3 to 6 months I would wait. And if I don't find any improvement, then probably I may refer.
Okay, so improvement in terms of?
Improvement in terms of the regularity of the cycles and the signs of hyperandrogenism. If they improve, then I would continue. Along with that, I would start a laser after 1 or 2 months.
1 or 2 months, excellent. So the point I was trying to get out of you is, would you expect a reduction of this kind of terminal hair with the medical treatment?
Probably some reduction might be there, but definitely she would have to go for a laser.
Yes, so this is what I like to tell them, because this is probably a little too far gone for pharmacologic treatment to make a difference. Dr. Srujana, now would you want to add anything to the investigation?
Ma'am, definitely I would advise serum total testosterone, serum prolactin, and rule out causes for acanthosis nigricans. I mean, I will check for insulin resistance, ma'am, which includes fasting blood sugar and serum insulin. Apart from this, I would also...
no, ma'am has already, Dr. Swarupa has already mentioned some. So over and above that, would you want to do anything else?
I would also advise for a scan, ma'am, ultrasound scan per abdominal.
All right.
To rule out PCOS.
Okay, so this is one joke that I keep cracking, that you're suspecting something and you want to rule it out, then what is going to be left? So you want to rule in certain things rather than keep ruling out, but this is something that PGs do. I'm suspecting pemphigus vulgaris, I'll do a biopsy and I'll rule it out. So I think as consultants, we have to change those lines, but no offense at all. So would you continue with this? What kind of values would you typically expect in this girl? Now, what would be the most common cause of hirsutism in the world or in our practice?
PCOS.
It would be PCOS. So Dr. Swarupa mentioned TSH very rightly, total testosterone. She mentioned, I'm assuming you're talking about a HOMA-IR, a serum insulin and a fasting blood sugar. So what kind of values would you expect in these people?
Ma'am, HOMA-IR, if it is more than 2.5, ma'am, I would start on metformin.
Okay.
And total testosterone values, like it is differing from each lab, ma'am. I would take a cutoff value of more than 30 nanograms per deciliter.
Okay, but generally in PCOS, would you expect the testosterone to be increased? Again, this is not a viva. I'm trying to make one very strong point to all the youngsters here, that usually total testosterone and testosterone values in PCOS are normal. If at all they are high, they will be slightly high. And if at all they are grossly high, then it is not PCOS. So that is one very strong point that I want to send home. Would you agree?
Yes, ma'am.
Okay. So now I'll come back to Dr. John. So would you be monitoring the medical treatment for this patient, or would you be happy letting your endocrinologist friend do whatever is he or she thinks is needed?
Madam, my endocrinologist.
Yes, that is. Okay, so I will come back to you for the laser and the device related questions. And Dr. Swarupa already mentioned that she likes to give a cyproteron and ethinyl estradiol combination. But is there anything else that you would want to add?
Usually I manage with this.
With just a COC, a combined oral contraceptive pill. Okay, any particular precautions here? Now, in the audience, if I may have a show of hands, and in case somebody is feeling sleepy, I don't mind if you do a few stand-sit kind of an exercise as well. But we'll do our best not to make you feel sleepy. So, how many of you are comfortable using a COC, prescribing it yourself, rather than waiting for your gynecologist or your endocrinologist colleague to do it? COC prescriptions? I see one, and I think it is Rekha. And I see two more, all of who have. Okay. So very few people actually prescribe COCs in this audience. And I'm hoping that today's session is going to change that. So I am ambitious, and I've come with some very clear agenda for today. So in this case, where you have rather severe hirsutism, would you all agree that this is severe hirsutism? Yes. So would you want to add anything else, Dr. Sujana? To the medical
along
treatment?
Along with oral contraceptive pills, spironolactone I would add, ma'am.
So spironolactone is something that is recommended in all patients with moderate and severe hirsutism. For mild hirsutism, it's a bit of an overkill. Sometimes we do use it, but not always. And what about non-pharmacologic management? I'll come back to Dr. Swarupa. What all? See, you are aware that this girl weighed 99 kgs. I mean, this lady girl, 99 kgs, 5'1". So her BMI was 36, 38 plus. What would you say regarding her lifestyle management?
Yeah, to improve, like, she should have good physical exercise, and if she has any other issues like smoking, maybe female patient might not, and I have to view for, actually forgot to tell, risk for any thromboembolism like diabetes, hypertension, heart diseases. This should be actually taken care before we start the OCPs.
Right.
And maybe I will add metformin in my treatment.
Okay, so when would you add metformin in when you're managing
when
hirsutism?
I find that there is insulin resistance.
Okay,
in my
and insulin resistance by home IR.
Yeah.
But suppose there is acanthosis nigricans and the home IR is normal, then what do we do?
Then even then I go.
Excellent answer. Thank you so much, because I tell my patients that the labs may make errors, but the skin doesn't. So acanthosis nigricans means insulin resistance unless proven otherwise. So it could be a malignant acanthosis nigricans, that is a different story, and we all know as good dermatologists how to suspect and diagnose that. But insulin resistance is a clinical thing that endocrinologists diagnose. So for them, ruling out diabetes is enough. For us, ruling in insulin resistance is important, because we can get sued. And yes, we have been sued once. So one of my young enthusiastic colleagues put a 45-year-old gentleman with acanthosis nigricans and male pattern, particularly vertex hair loss. He was getting PRP, and she put him on metformin, and he developed some gastroenteritis. She had to be admitted. And then the general physician said that, you know, these people put you on a sugar ka dawa. It's a very wrong thing to do. So, of course, we got away very cleanly with it. So I'm sharing this story because you need to, as dermatologists, you have to save your skin, but you also have to do your best to save your patient's skin. Now, Madam Chair, will you please remind me when I have 20 minutes and 10 minutes? Depending on that, I will pace the thing. So now, Dr. John, how would you align this girl? You spoke about counseling the parents as well. And in India, I think till the time you're married, your parents have to be counseled. And after that, I think in some cases, husband also has to be counseled.
Yes, ma'am.
Yeah. So how would you align them? How many sessions, duration of treatment? Things like that.
At present, it depends on what kind of device you're using. But normally, we say 8 to 15 sessions is normal. But always remember, 10 to 15% of the patients will not respond in the given time. That also to be told. Because he already has a reason for this. It is not familial. It is caused by a condition which he is having. So, and if I'm using a triple wave, then it is 6 to 8 sessions. Because triple wave can knock it off easier.
Even in this case?
Yes, even in this case, madam. But provided the patient is treated properly for her PCOS and acanthosis, or her insulin resistance, madam.
All right. Would you talk about maintenance sessions?
Maintenance sessions, yes, but most probably it will have more of vellus hairs, madam, rather than terminal hairs popping up.
So vellus hairs, somebody like this would be happy to
Yeah,
keep
there will be a lot of lanuga kind of hairs will be there. Some, they agree that, it's okay, it's not dark enough, but if it is something that they have to knock it off, then again it's a triple wave, madam, or IPL if you have.
Okay, because finer hair is difficult to treat.
Yes.
So right now, what is your device of choice?
At present, madam, I will use my triple wave now, madam.
Okay, and we don't mind if you name the company.
At present, I have Cymedics, madam.
Which one?
Cymedics, madam. But
Cymedics.
That's an FDA approved machine, but the company is out.
Okay.
So it's difficult to even, you can't trust an FDA approved machine also. But yes, luckily the machine is still not faulted, so it's still running, madam.
Okay. So when you are buying a device, please make sure that the backing is good, because you buy an expensive device and then you don't have spare parts, you're going to be stuck. That's an important lesson, I think, from this workshop. Now, Dr. Swarupa, would you tell us, what is your current device? You use a long pulse JAG, you said?
I use diode now.
You use a diode now, okay.
And
So,
I'm using a luminous.
luminous,
laser light.
wow.
Yeah.
Okay, so that's our dream machine now. It's far too expensive for most of us to buy at this point. So regarding the parameters, I will say this to the audience, that the parameters will depend on your device. But is there some easy way, Dr. John, for you to guide a beginner? I know you do a lot of trainings, and those beginners might not buy the machine that you have. So how do you teach them how to decide the parameters?
Madam, it's easier, madam. If you are using a diode system, your parameters should vary between 15 to 25 joules. If it's a diode, if it's a long pulse system which you are going to buy, then you can vary between 30 to even up to 50 joules you can go. The ideal pulse duration you should keep for any case is 30 to 50. Don't try to push the pulse duration longer trying to save the patient's skin. It will not help. So 30 to 50 milliseconds should be the pulse duration. But the only problem arises when you have a triple wave, because triple wave you have to do it only in motion. Stacking will not help in triple wave in these kind of patients, madam.
Okay.
And to one more question, madam, if you ask me, a long pulse NDIAG with at least a bigger spot size, going up to 15 mm, also can be used in these kind of terminal hair, madam. They help a lot, madam.
If you have access, then use the biggest spot size you can. The problem is most of these devices come with a fixed spot size, so you don't have much of a choice. And would you use topical anesthesia? Now, because this is a workshop, I'm going to spend some time on the practical aspects, and I'm going to ask the same question to both of you again. Because with your device, with your experience, I'd want to know.
There is one problem with topical anesthesia.
Yes,
madam.
please.
The problem is when you apply it, the epidermis slightly thickens because of
There's
hydration.
edema.
So once it thickens, the travel distance for the photon is increased. So you are not able to reach the bulb area. So you might reach the bulge area confidently, but the bulge area you might. It's better not to use a topical anesthesia, because it invariably it doesn't help the patient. And the best thing is cooling, madam. The initial first few sessions you can cool and do. And please remember, if you're dealing with vellus hairs, your cooling should be counted 1, 2. That is, you cool, 1, 2, and keep firing. If you count till 4, it is for terminal hair. If you do 4 seconds for a vellus hair and try to do it, you will not be able to hit the target, madam. So cooling also has a problem. You should not cool much for vellus hair, but you should cool more for terminal hair.
So my personal policy is I do not treat vellus hair at all, but finer hair, yes, you can get away with lesser cooling. With nowadays, the problem is that with InMotion and all, finer hair is not that much of an issue. But do you find the need for a touch-up session, Dr. John? I'm going to finish everything from him and then I'll ask. So touch-up session is something that you do after a, like what would you call a touch-up session? How would you define it?
I always tell the patient that the chin area is the most difficult to remove every hair because they are of different depths in the, it's more vertical, madam. If you do a few in that area, we'll understand it, madam. It's more vertical there, so that's why we are not able to reach it. But if you have an adjustable long pulse NDX system, you can reach, but you have to go above 15 mm spot size to reach that depth.
So with our with the triple wavelength that you have,
it is not possible.
It's not possible. Again, that is a strong message we want to give you. Now, may I request dear friend Dr. Sujala Aradhya, so to join us on stage. Thank you so much for accepting. You are also our knight in shining armor. Even more precious because you accepted at an even later time. So you've been following the discussion, so you can pitch right in from where Dr. John left off. Sujala, which device would you use, and would you tell us what kind of parameters you would use, specifics?
So, ma'am, I have a very limited experience. Frankly, I've just recently bought a diode and a quadruple wavelength at that.
Wow. Okay. Milesman, is it?
Ma'am, sorry?
Milesman?
No, Derma India.
Okay.
Derma India. So, with this, yes, ma'am, definitely. The thicker hair, definitely they do start to respond well with LHR. But of course, such patients, we have to always evaluate, look into the hormonal history.
Yes, yes. That
rule out PCOD, all of that.
Rule in PCOS.
Yes.
95% of the time, 90% of the time it is PCOS. So
Yes.
don't rule it out, rule it in. So
Yes.
that is one more strong message I'm hoping to give. So interval between sessions, Dr. Sujala, then we go back to
Initially, I would start with once a month for 2 to 3 sessions, and
Okay.
then depending upon the speed of hair growth.
Okay. Dr. Sarupa? Your interval between sessions?
1 month.
1 month?
Yeah, initially, later on probably 2 months.
Okay. So at 1 month, are you happy with the amount of hair growth that comes up? Do you feel like it's a little wasted?
Usually,
Initially?
yeah, in the first session itself, I see that there is a good improvement because I can see only a few strands of hair, they grow even after first session. Later on, from second, third sessions,
You will space it out.
Yeah.
Yes, Dr. Srujana?
Ma'am, I'll ask them to come back only when they see maximum hair growth, ma'am.
So for such a person, the second session would be roughly, would you, so you ask them to call?
Maybe after a month, ma'am.
Okay, so in Oliva we have this policy that we generally don't call before 1 month for sure, and we do call such people for a touch-up because we no longer use our long pulse diag. We have one device which is living, 2 of them are dead, and we spent a lot of money trying to revive them, much more money than they gave us. So with our devices, we do a touch-up session at 2 weeks, so we can easily get away for up to 6 weeks. And what would you tell them to do between sessions? Do you have resistance from them regarding shaving? Because Indian women don't like to shave.
Shaving they can do, ma'am, because it will just remove the topmost layer of the follicle. It will not pull out the hair follicle completely. But definitely in such a case, I would advise not to shave if possible, unless and until they have a social event.
So somebody like this girl walking around with this hair is obviously very, very awkward. So what now Dr. Sujala, what would you tell this lady between sessions? Obviously she cannot do waxing or threading.
Yes, ma'am. Ma'am, I would advise on shaving, but to use proper precautions. Preferably use a disposable razor, not to go with a very sharp razor, and to shave it in the direction of the hair growth. That's from above to below. Stretch the skin properly while shaving. The reason I would do this is, of course, having such a thick growth. Even on a day-to-day basis, it will be quite embarrassing for them to maintain this around.
Obviously.
So even an epilator use is also quite fine, because as long as we have the hair root left behind, we can continue with the sessions.
Yeah, and even if they shave like somebody like this, even if they shave like 3 days prior, we should be able to make out and...
yes, ma'am.
And yes, please. Yes, Dr. John. Any questions from the audience? You're more than welcome. Please come to the exhale, and then we'll give you a mic.
The interval between session, just remember, it is different for the face, body and the arms and legs. Face, it is 4 to 6 weeks. For the trunk, it is 2 to 3 months. And for hands and legs, you have to do once in 3 months, because it's the longest telogen phase of the hair is in the arms and the legs. You can't hit it in telogen, you have to hit it in anagen. So once every 3 months, if you space it out correctly, I'll tell you the best hair removal is in the body. You actually get results in even 3 to 4 sessions. The face is very notorious. And one thing is, I follow one protocol is, every 4 to 6 weeks we do the hair removal. Yes, provided if the hair is not there, I'll tell them to come a little bit later. But 4 to 6 weeks, the first 3 sessions the patient has to come properly. If they come for the first 3 sessions correctly, then they can space out the remaining 3 months also they can come. But the first 3 have to be hit correctly within a period of 4 to 6 weeks. This is what I follow, madam.
Excellent message. So remember that your success is going to be during anagen. And one important thing about anagen is that anagen is the long phase. So once hair comes into anagen, it's not going to run away very quickly. But once it is in telogen, then it's not going to stay there for too long. So don't worry about, and one of the mistakes a lot of people do, earlier days they used to, nowadays I don't think anybody does, is calling it monthly and then just doing off whether or not there is hair. Nowadays I don't think anybody does that. So now I'm going to go back to Dr. Swarupa. Since you mentioned that you're quite comfortable prescribing a COC, how do you overcome resistance to treatment? Isn't hormonal treatment like a huge bad word that people start getting worried about?
Yeah. So
How do you handle it?
I just put them on OCPs only for 3 to 6 months, because that is the time you need to wait to see the improvement. And because my laser also should work, because without the medication, my laser also doesn't work. The results might not be there. And later on, I'll refer them to the gynecologist or an endocrinologist.
Okay, but do you think 3 to 6 months is enough?
No, it should be like lifelong if they want to.
Lifelong OCP is like too much for us also.
It's
but
not, but whatever, like the time duration they require, they need to be maintained on that.
Okay, Dr. Srijana, how do you handle this?
I'll advise, as long as they're taking LHR sessions, it's better to take oral contraceptive pills.
Sure, but how do you overcome the resistance to treatment in a real life scenario? Though till the time you have a diagnosis of PCOS, the focus is on the hair. Once you have the diagnosis, then the focus is on the side effects of the treatment. Would you all agree?
Yeah.
So suddenly the focus is shifted.
So we need to treat the cause actually.
So do you have any tips? Now Dr. Srijana is married to a psychiatrist, so she probably has some extra skills in counseling. So how would you explain to your patients? Do you have any mantras?
I'll just rule out the other causes of hirsutism.
No, all that is done. You have a diagnosis. Now here you have a set of parents, 2 parents, and one 21-year-old girl who has to eventually get married and have children, because that is the norm for us. And you want her to take a birth control pill, and the parents are worried. And this is internet generation, very common issue, right? Dr. Sujala, what would you tell them? Would you prescribe a hormonal intervention yourself, or would you refer? Sujala? Yeah, the mic.
Ma'am, so the most important part here is counseling to the patient. So we need to make them understand why we're giving the OCPs and what we're trying to target, what result we're trying to achieve with the OCP. So with that being done and taking proper consent from the patient and the patient's parents preferably, I think we should still go ahead.
Right, of course we have to go ahead. The question is, how do we go ahead? So over years, we all want to go ahead. We all want to give this COC, and now the COC is going to act only after 2-3 months. So if they're going to stop after 2-3 months, then there is not much point. And if we go by whatever we all agreed, first 3 sessions at maybe 6-week intervals, 4.5 months, and before that we want a medical treatment. So I would love to do what Dr. John suggested, because he is trying to achieve androgen suppression before the laser comes out. Is that right, Dr. John? So that would be great. That means 3 months before, and then during the entire course, you want your androgen suppression. So I'm going to share just 2 things that I've learned that I use. So I tell my patients that as long as we are doing the laser hair reduction, some hairs are going to die.
And those, hormone or no hormone, it will not wake up. But some of them are going to become thinner. Some of them are going to go into a sleep-like hibernating state. So if the androgen is not suppressed, then the sleeping ones will wake up and the thinner ones will thicken, which means you're taking 2 steps forward, 1.5 steps backward, so you're not really making clear progress. So this is one thing that seems to help. I draw this and, I draw the bulge and the bulb and the, all this stuff. I'm not good at drawing, but I've practiced. And one thing that I learned from a dear gynecologist friend is, she tells her patients that if home-cooked food is great, it's healthy, but if you're not capable of cooking good food, like I am not capable, then maybe ordering healthy food from Swiggy is better. So that is what we tell. And also, once you tell them that we are suppressing the male hormone, testosterone, then that also, I think, does help. Now, and these are the results. More. Yes, ma'am. Yes, 20
minutes.
20 minutes more? Oh, thank you, ma'am. Okay, so I'm still in case scenario 1. But I thought most of the discussion we will do in case scenario and the rest we will just rush through maybe. So these are the results after 3 sessions. Now this girl had to go out of town to Delhi because she finished her engineering, she got a job, and this picture on 22nd of August 19 was around 3 months after her 3rd session. So she'd come for the 4th session. So you can see that she had pretty decent response. So this is how it was. During this period, from 99 kgs, she became around 81 or 82 kgs. And the device that I had used was a diode of Alma. So I didn't use the InMotion. I used the stacking mode, though it is best used in InMotion with topical anesthesia because it's, the pain is miserable. But now I personally don't do laser hair reduction, but for these sessions, the first 2, I was standing there, excellent contact, some pressure so that you can overcome the distance, reduce the distance. All these are practical things, and excellent cooling, of course. So we got away without that. Now I thought I'll very quickly take you all through Rotterdam criteria. At least 2 out of these 3, that is irregular cycles, which this girl had, and hirsutism also she had. So if we have to do just basic investigations, what all would you do, Dr. Sujala?
Ma'am, so the hormonal profile is what I would first ask for the patient. FSH and LH preferably on the day 1 to 3 of the period cycle. Then serum testosterone, free testosterone, serum prolactin. OGCT is another I would look for.
Oral glucose challenge test, you mean?
Yes, ma'am. Okay. Yes, ma'am. And so along with that, TSH, CBC. Yes.
Okay. So the most important line here is actually exclusion of other etiologies. So because the first 2 are already there. So in this girl, the total testosterone doesn't matter. She already has hyperandrogenism. So hyperandrogenemia is not going to add to your diagnosis. And transvaginal ultrasound in India for an unmarried girl, of course, is a no-no. And transabdominal ultrasound in this girl who is 99 kgs and 5'1" might or might not show you much. So in the absence of ultrasound evidence also, you could diagnose PCOS provided you have a normal TSH and prolactin. I'm going to skip this. And investigations are advised for everybody with moderate and severe hirsutism. And for mild hirsutism, if you're going to consider a pharmacologic treatment. So this is again one more important thing, and I say this because all of us are going to see hirsutism patients. So I think whether or not you're going to use a LHR device, you should be able to do this. So total testosterone is something that we do not to rule in PCOS, but to rule out a tumor or a hyperthecosis of the ovary and to establish a baseline. But if in a pinch, if the money is like a real problem, I would actually skip it. Prolactin and TSH, but also clinical evidence of Cushingoid habitus, of growth hormone abnormalities. Like you look at, we dermatologists are excellent at identifying Cushingoid habitus because not just with systemic steroids, with topical steroids also we keep seeing Cushingoid features. So we know how to do that. Acromegaly is something that we are not very hard pressed to find. So prolactin and TSH, yes. Now, in a perfect world, I would do what Dr. Sujila suggested. But in our world, we don't have access to either a HPLC mass spectroscopy or equilibrium dialysis assay. So in our world, because we have, the best we have in Hyderabad is a chemiluminescence, and in some better places you have RIA and ELISA. Now I know that this is a bit much for dermatologists to understand, but we have to, if we have to be good at this. Now 17-hydroxyprogesterone, would I do it for this girl? No, not for this girl, but in some circumstances I would do it, especially if it's peripubertal onset, especially if it's a lean person, I would certainly want you all to do it. So the second line would be FII and anti-Mullerian hormone. Now, and DHEAS only if I'm thinking of a tumor and the total testosterone is within limits. Otherwise, please don't waste the patient's money doing that. And LH-FSH ratio is no longer recommended because it is a very specific marker of PCOS, but it is not sensitive. So irrespective of the LH-FSH ratio, you are going to rule in PCOS based on her TSH and her prolactin. So if there's just one thing that I want you all to take away, I think that should be enough. So day 2 to 5 of menstrual cycle, but if the cycles are irregular beyond 35 days, it doesn't matter which day as long as it's a fasting sample. Now ma'am, how much time? 10 minutes? Okay. So I'm quite fond of doing 3D ultrasound, but I'm going to move on. So first line treatment for hirsutism in PCOS would be COC, and then of course for moderate and severe cases, spironolactone. Bicalutamide is a third line drug that I would use if I'm not able to get the result in spite of a good dose of spironolactone, or somebody is not able to tolerate spironolactone, cramps or fatigue, metformin or other insulin sensitizers. Now, WHO contraindications, if there's anyone interested, please click a picture of this. Make sure, even if the person is young, take a BP, check a lipid profile, and do look at the sugars before you prescribe this. And do ask for family history and history of migraine, history of passive smoking as well, and active smoking also in women, sadly. So these are the absolute contraindications, in which case you would not prescribe a COC. But once you prescribe it, I tell my patients we are looking at a minimum of 9 to 12 months, and ideally I would want to cover at least the first 6 sessions, by which time 90% of the work would be done, Dr. John? More than 90% in the first 6 sessions or so? Yes. So please look at this. Now, breast cancer has been linked, but we know from this huge study that was published in NEGM in 2017 that you don't have to really worry, that the causal link is not really much, so you have to tell them. Now spironolactone, again, I'm not going to spend too much time here. Do learn how to use spironolactone. Flutamide, none of us should be using. Somehow Maharashtra people love to use it, but it is not just unethical, it is even illegal to use, because flutamide can cause even deaths. And if somebody has, especially in women, the risk of idiosyncratic hepatotoxicity and irreversible fibrosis requiring a liver transplant and all have been there. Metformin is a drug that all of us should master, because people think AN is pigmentation and they come to us, and I think it is our chance at changing the world. We come, now Hyderabad is India's capital of diabetes, so obviously India's capital for insulin resistance probably. So I think every Hyderabadi here should be talking about it and using it without. So to sum up, moderate hirsutism, COC with spironolactone, don't give very tiny doses like 25 mg and all, and bicalutamide for poor responders, metformin for insulin resistance only. So this girl had a total testosterone which was slightly on the higher side as per the lab. Many labs would consider this normal. Her TSH was okay. Her prolactin was slightly increased. Now this is a very common finding. So Dr. Swarupa, what do you do when this happens? If you had to treat this?
Prolactin.
Yeah. What is the significance of this?
It shows the cycles are irregular, and the reason for irregularity of the cycles might be the raised serum prolactin levels, and probably I might start her on cabergoline or to reduce the prolactin levels.
Okay, so it's, in fact, the most common hormonal abnormality that we find in PCOS women is increased prolactin. But increased prolactin of a mild degree. Now, most labs give a cutoff of around 25 to 29. So anything less than 50 is usually because of PCOS itself or because of a drug. Most common being your prokinetic agents, your domperidone, your etopride, all these things. So this one is not going to need cabergoline. This is going to need a COC and a spironolactone. But if it is beyond 70 or 80, that is when you want to think in terms of a true hyperprolactinemia. And if that is the case, I'm going to refer to my friendly neighborhood endocrinologist, whom I then very carefully monitor. So either I'm monitoring the patient directly or I'm monitoring the endocrinologist, because I am responsible for giving good outcomes of laser hair reduction. Would you agree, Dr. Sujala? So transabdominal ultrasound, even in this obese girl, did show PCOM. So don't just discount it. It is not that transabdominal ultrasound is useless, but when somebody is married, do ask for a transvaginal one. So she was started on Cresanta and spironolactone. Initially, she was just insulin resistant, but later on, she went on to develop frank diabetes at age 21. So for a period of time, she was put on sitagliptin metformin combination by the endocrinologist. And then after she lost weight, she went back from diabetes to insulin resistance. So I tell my patients that this is like a spectrum, a continuum, and you could probably keep moving. And of course, diet, exercise, sleep, and stress management, I give them the specifics. So number of sessions, lifelong maintenance is something that I tell them that, you know, if the hormones are awake again, whatever is hibernating might wake up, but typically after around 8 to 10 sessions done with a good device, very few people come back for a maintenance. Would you agree, Dr. John? Especially if hormonal medication is given. So just to reiterate, this is from Dr. Zubolis' paper, where this person with severe hirsutism had no hyperandrogenemia. The total testosterone was normal. So basically underlying what I had said. Another lady, this lady came to me when she was 120 kg. I suggested that she didn't have diabetes, she had only insulin resistance. So we did put her on spironolactone and drospirenone containing one, because the metabolic effects of drospirenone are a little more favorable than that of the cyproterone, but then that's a choice. Cyproterone ones are actually more effective because they have 35 micrograms of ethinyl estradiol. And I suggested a bariatric surgery. Then she said, I already lost 20 kgs, doctor. She was 140. She came to me at 120. Her best weight was around 84, 85. Now she's back at 99 and she's finally agreed to go for a bariatric surgery, because most of her life she's been managing her weight. And she said, you know, maybe it's time I start living a life instead of just managing weight. So do not hesitate at going beyond what is there in our books. Okay, so ma'am, 5 minutes? Okay, so this is another girl, long story, but I'm going to cut it short. A lean girl, and this is what her ultrasound showed. So we put her on treatment, she's doing okay. Now, this is a thin-built girl, 20-year-old, irregular cycles, and normal total testosterone, TSH, prolactin, transabdominal ultrasound, all these were normal. Her 17-hydroxyprogesterone was 5.71. So we had done, like the endocrinologist, a colleague of mine, did a ACTH stimulated 17-hydroxyprogesterone, which then went beyond the cutoff of 10, of 8 actually, and then this was labeled as a late onset congenital adrenal hyperplasia. So in addition to dealing with the secondary PCOS kind of a situation with a COC and spironolactone, she was put on high zone 5 milligrams at night, and she did quite well later on. But what if this were idiopathic hirsutism? I'm going to go back to Dr. Sujala. So suppose it were truly idiopathic hirsutism, Dr. Sujala, would you give any medication at all?
Ma'am, if all the hormonal parameters were within normal and it was exactly an idiopathic hirsutism after ruling out everything, then I would defer from giving any oral.
You would not want to. Now, same thing, Dr. John? Dr. Swarupa, would you want to give any medication? For idiopathic hirsutism, would you give any medication? Idiopathic hirsutism comprises only 5% or so of all our hirsutism patients. No?
Probably I would add, ma'am.
Sorry?
I would add, ma'am.
You would add?
Because it could be because of androgen sensitivity also. It could be because of increased sensitivity to androgen receptors of the hair follicle.
So you would add what?
Oral contraceptives.
Oral contraceptives. So here, so basically what is the defect in idiopathic hirsutism? Everything is normal, but the androgen receptor is binding very avidly to whatever little androgen is there. So you want to do a androgen receptor blockade, which means you want to give spironolactone. And if you want to give spironolactone to a lady who could conceive, who is menstruating, then you want to give a COC. So I have this, again, kind of a joke that for PCOS treatment is COC plus spironolactone. For idiopathic, it is spironolactone plus COC. I mean, eventually it's the same thing. This is what this update says. Combination treatment of idiopathic hirsutism, I'm going to read out, includes androgen suppression, peripheral androgen blockade, and cosmetic methods. Again, very strong message. Even if the diagnosis is idiopathic hirsutism, if you want to get your best outcome, same problem there. When the bulge area is being targeted and some of the hairs are hibernating and some of them are partially destroyed, same story goes even for idiopathic hirsutism. So the second story here. Now, what about white hair? Postmenopausal, I love to give monotherapy with spironolactone, but your tips for white hair, Dr. John?
Everyone can do an electrolysis, but my choice
I can't do electrolysis.
My choice would be doing FUE with a 0.7 mm punch, madam.
Excellent. That's exactly what
that
I do. Yes. Because I'm ashamed to say this, I don't know how to do electrolysis. And I am not very convinced that electrolysis is the best way. So any tips about how you do that? FUE is something all of us can do. We all do punch biopsies.
Electrolysis, you actually use a 3.5 magnification. You just stretch the skin with your hand, go behind the direction of the hair. You should not go in the
You're
front
talking
side.
about electrolysis or FUE?
Electrolysis.
Okay.
FUE, they will, everyone will do, madam.
No, in that see, because these hairs are not straight.
No. You are talking about FUE.
FUE.
FUE, it's not very difficult, madam. Only here you have to see the direction of the hair. Because in the chin, it will be vertical. In the neck, it is almost parallel. So your direction of entry is the one which creates the problem.
So go parallel to the hair is the mantra, and that is something
in the chin we have to go vertical, madam.
Yes.
That's the only difference.
Perpendicular to the chin.
Yes. Yes, ma'am.
Thank you. And they heal beautifully. They do not scar. 0.7 is, I started off with 1, but 0.7 is better. Only thing is sometimes I end up missing it and then it comes back and then I have to repeat. So, Dr. Sujila, do you have any experience doing this? I'm sure you do.
So electrolysis or epilation, yes.
Both you can tell.
Yes, ma'am. So, so epilation, it's a very time-consuming procedure. This is what I find. And though we give topical anesthesia to the patient, it can be a little painful too. And the chance of PIH, that is one significant side effect that we face. But definitely FUE is a much more convenient procedure for us and for the patient.
I think so. Thank you. So you could take, if you're keen, then just take a picture of this. We'll move on. So PCOS is the most common. Now we move on to body hair. So body hair challenges, again, I will begin with Dr. John, the master. Body hair, how many sessions would you advise? Would you advise maintenance at all for these people?
No, madam. They actually respond in 3 to 4 sessions, madam. It takes 1 year to complete, but it takes 1 year to complete. You have to do it once in 3 months. Preferably, don't do long pulse in this. It's either a triple wave, IPL, or diode. Because if you use a long pulse, the results won't be good.
Why not?
Or you have to use a very smaller spot size, madam.
For which one are you talking about? The
body,
first one is chest.
Body hair, madam. Just if it is very thick, you can use, madam, long pulse NDR. That one, I think long pulse will be a little bit tricky because you will send the photons way beyond the bulge area and the bulb area itself.
But on the way they will get
Triple
absorbed.
wave is very good, madam. Please
Of
try
course.
triple wave.
No, I am a fan of double wave. Now
Yes.
here we have 3 people. I am using a double wave. I love it. Dr. John is using a triple wave. He loves it. And Dr. Sujala uses a quadruple wave. He loves it. And Dr. Swarupa has the best of the lot with his light shear, and she loves it. So the truth here is, whichever device it is, you need to master it. It is not about the device, it is about the science that is behind it. And I think all of us dermatologists are capable of getting excellent results even with a decent device. So don't get too worked up on about that. Is that a decent message to give, do you think? Master the science, master the physics, and you can get results with anything. So no maintenance for body hair, there is no androgen business there. But 3 to 4 sessions, I wouldn't dare except for upper face. I would, how many sessions would you align for Dr. Swarupa?
For which underarms?
For body hair, yeah, for underarms, let's say.
For underarms, I think it will take more sessions.
Yeah, how many sessions would you, in your practice, advise?
In my practice,
Mike, I don't know if they can hear.
Usually it is 6 to 8.
Some people are sleeping.
For underarms, and I need some maintenance sessions also.
And maintenance, is it?
Yeah.
Like? How frequent?
Once in initially 3 months, later on once in 6 months.
Okay, but do you need maintenance sessions at all?
For underarms. Yeah.
For the body?
Yeah, for a female I have done, not for male.
Okay, so because generally body hair, you know, once gone, gone. So, okay, it seems time is up. Hidradenitis suppurativa, beard shaping, I thought we'll talk a little bit. Pilonidal sinus as dermatologists. Sorry? Long pulse NDIAG is great, but if we don't have one, then diode is decent as well. Absolutely, the technique. So those kind of things we do ourselves. And for beard shaping, do not treat the entire male beard because it will come back like moth-eaten alopecia, because androgen in a male you cannot and should not suppress. Transgender is a different story. It's a story for another day. Maybe we'll talk about it. So the final, the LHR burns, unfortunately, we don't have time to discuss, but the best way of managing them is to prevent them. And Dr. John, I know what you're going to say. I want you to see it.
2 things, madam. To prevent it is, most of the time patient have this habit of plucking the hair or shaving. It ends up with hyperkeratosis and hyperpigmentation. Use a depigmenting agent at least 7 to 10 days prior to the hair removal. You will not end up burning the patient. If at all you burn the patient on table, use the epidermal growth factor, region D. 3 days. Any complication of burns is gone, the patient is out of your hair. If you don't use, the patient will be behind you for 3 months.
The last thing you want to do is to use a topical steroid. Because already for a dermal burn, would you use a topical steroid? You won't. So this is also a dermal burn, so please don't use that. And I sometimes use tranexamic acid orally to prevent a PIH, because sometimes you have these people who tend to pigment a lot. Hold their hand, be apologetic. If they have PIH, do free laser toning, but don't avoid their calls.
Thank you.
Thank you so much. Special thanks to our guests, Dr. Sujala and Dr. John, and for being such good sports, Dr. Srujana and Dr. Swarupa. Thank you so much. The chair as well. It's been a pleasure. And all of you, yes, Itatsa is ours. Join the crusade.
So next session will be Challenges in Hair Transplantation by Dr. Raj Kireti. Sir, please come.
A photograph there. Okay, we'll take that.
అది మళ్ళీ తీసుకుంటాం కదా. Dr. Rajkirti sir, start the session.
At the outset, I would like to thank TS Organizing Committee, the CUTICON Organizing Committee, to give me this opportunity to present on hair transplantation in cicatricial alopecia. So, scarring alopecia, it refers to the irreversible follicular damage to the stem cells. To the stem cells in region of the bulge, and we know that it is primary and secondary, and scarring alopecias can be differentiated in mouse control. Mouse control. So on lymphocytic, neutrophilic and mixed lymphocytic or the other pathological classification, the therapeutic options are steroids, minoxidil, antibiotics, surgical options. Hair transplantation is now becoming a more common treatment options. In surgical options, we have hair transplantation, scar excision, flap surgeries, and scar reduction with tissue expansion. The challenges are that the degenerative changes and inadequate dermal and subcutaneous tissues, and there is reduced vascularity of scar tissues. And there is less tensile strength, and tissue either tears easily or is thick and hypertrophic. And inflammatory conditions, disease process must be stable before transplantation. The reduced number of available grafts when scarring affects the donor area, that depletes the donor, and then there is a lesser chance of graft survival. The case selection and workup in a scarring alopecia's hair transplant is important. We should confirm the diagnosis with biopsy, make sure that there is not much inflammatory infiltrate around the hair follicle, and that determines the stability, and it should be quiescent at least for 1 year. The patches should not spread, or neither the new patches should happen. The probability of relapse or Cobnus phenomenon by history of wounds or newer patches should be asked, and we should assess the availability of the donor hair. And the health of the underlying dermis and subcutis is important. So this is a dermoscopic image where we see this scarring. We can see the peripilar cast and then the atrophied follicle along with the pigmentation. And then you can see the streamers and the burnt out follicles over here. That's a close-up view of the burnt out follicles. So this is how we decide that the disease process is stable, that there is not much inflammatory infiltrate around the follicles. If there is an inflammatory infiltrate, even though after burnt out appearance of the follicle, it means that there could be graft rejection. So this is not the inflammatory infiltrate which we see on the close follow-up, it is a burnt out follicle only. So the tips for better graft uptake is that the FUE method over FUT, it should, because it has less damage and chance of coponerization is less. Performing test graft of 50 to 200 grafts in different areas and checked after 9 months of growth. And the extraction of skinny grafts for better survival. And then we have to reduce the graft implantation density. Usually it is around 55 to 65, but we reduce it to 15 to 20 units per square centimeter to ensure adequate blood supply. And second transplant with a greater density can be planned at a later stage. The placement of grafts is a difficult thing when there is an actively oozing slits. The areas of thin scar tissue, use of less demiscence and more acutely angled slits for better graft hold can be there. And avoiding usage of epinephrine to avoid vasoconstriction in those areas. And combining the procedure with the PRP in same session is an advantage. Post-operative minoxidil is used immediately. And treatment with fractional laser prior to surgery for collagen remodeling is one of the advocated ideas. So this is one of the scarring alopecia transplants where we have done. This was close to around 600 follicles. We have implanted in those particular scarred areas after the biopsy and confirmation. And this is how he had grown. You can see that there is a lesser density because it's a scar area. But there is a good uptake of the grafts. The thickness of the hairs are uniform and it is camouflaging the scars easily. This is one of the patients where we have done FUE on the frontal areas, and you can see that after growing the hairs, she was able to cover her entire scalp. So many females have a lot of social obligations. So this is one of the lichen planopilaris condition in this patient. So we did this and she could do very well in our quality of life. You can see that this is a congenital temporal triangular alopecia where we did a biopsy, confirmed with a dermoscopy, and then did a hair transplant. And then you can see that this is a good hair growth, and this is the lower one is a little bit later than 3 months. And you can see that this is the before on your left, this is the close-up view, and that's the longer view. So you can see that the grafts are growing up very well. So this is like, it's not a scar, but it's like, a trachea, something like congenital atrachea. There are certain spots, bald spots, where they are not growing hairs right from puberty itself. So they wanted a mustache reconstruction, so we did that. So you can see that the hairs have grown very well. And this is a burnt scar patient where he was, his quality of life was immensely disturbed. A lot of scarring alopecia patients, their quality of life is immensely disturbed. He was not going to college. He's a very qualified person from a very good family. But since he had a burn in his childhood, so he could not go because he was not growing his beard. His scar was really bad, especially in the frontal view. His scar was very much high. So we did a hair transplant. First, what we did was the patient wanted to gain some confidence. So we did some small number of grafts. We did around 200 on the scalp and then 100 on the beard area. You can see that the 100 and 150 grafts, what we did was we spread it sparsely because we didn't want it closer density. And you can see that the spot has actually grown up hairs. So this again we did some more transplant of more than around 1800 grafts, and you can see that we placed around 900 grafts in the front to create the temporal hairline. And you can see yesterday he had sent us this photograph, and you can see that the amount of hair growth what he had in the frontal area, and this is the beard area what he had growth. You can see that there is some sparseness in the beard hairline, but he's definitely happy, and we're going to do a later second transplant following this up. So you can see these photographs. Now he's happily going to the college. Yes, of course, the scarring tissue is still a problem. This is another patient of mine where we have done hair transplant in the scarring alopecia. You can see that this patient is suffering from burnt out alopecia, pseudopelade. And then you can see that these follicles have been implanted. This is the patch test. And after 6-7 months, she had got this hair growth. So what we did was we did a biopsy and we could see the inflammatory infiltrate. So that is the reason I asked her to postpone the transplantation, but she waited for 6 months, and then she wanted to go for a patch test transplant. Then I did a patch, and then the hair's grown very well. And then in this particular patient, you can see that the donor area was very, very limited. In such a condition, what we did was we did an FUT excision, and then of course suturing, and then we did the FUE grafts also, and we could see that the hairs were growing very well, and the scar has taken up very nicely. So this is how we place the grafts. We could get somewhere around 1,000 grafts only from such a donor area because it was the scarring alopecia has eaten away every hair follicle over there, and we had difficulty in transactions also. So we have done this 1,000 grafts, and then we are awaiting for the result. This is after 3 months, and we are still waiting for the results. Probably after 9 months or 1 year, we'll be able to get some good results and show it to you. So this is what we can do in scarring alopecias. The FUT bad scars, also we did a lot of transplants. So FUT bad scars, sometimes it can be a lot of troublesome for the patients, especially when they want to grow their hairs shorter. And in case if they want to shave their hairs regularly, then I think this is also a good option, and scalp micropigmentation is also a very good option. I often tend to do the scalp micropigmentation in these particular areas in case if they want to shave their scalp regularly. So these are the routine transplant patients what we had results with the androgenetic alopecia, and this is also another patient where we did for the androgenetic alopecia. These are the routine transplants what we get in success for. So I thank everyone for the patient hearing. Can we do this? Yeah, ma'am. So now I invite Dr. Larry sir also for the panel discussion, since we had an opportunity to discuss something about hair transplant and PRP. Anybody else wants to join for the discussion, you can. It's okay. So this one video I missed out of my mind. So this is the punch graft, what we do with the FUE. So you can see that there is some amount of oozing, so we have not used adrenaline over there. And you can see that even though we were pulling out those grafts, there was many transactions because the scarring will pull out the hair in different angles. So that is the reason that you might have more transactions over there. Or a video hai kya? No, I think that's good enough. So I'll stop the video over here. Dr. Rajita, you want to join us for the PRP discussion? Okay. Sir, we don't have any presentation, so we can just sit over here and randomly discuss about it. So if the audience wants to give us, want to ask us any questions, I think you can feel free to ask because we don't have many questions to discuss with. So, John sir,
yes.
In a patient with grade 3 to grade 4 patient for the androgenetic alopecia male pattern baldness, if he comes to you and says for the hair loss, what is the medical management or the procedural and the therapeutic, the surgical management that you would advise for?
Sir, any case of patients with hair loss, start the medical management, which we all do. Yes, we have to give you multivitamins, you have to give you finasteride if required, you have to give you a topical minoxidil. Yes, you can use your biomimetic peptides. Now, if the patient asks, I have to do hair transplant immediately, please don't do. Why? Because a patient who has got severe hair loss is going to continue to lose his existing hair. The moment you do hair transplant, in 8 months, he will come back with again the same problem because the hair which is implanted will grow, but the hair which was already there would have shed off. So if you have a hair like, like this and you try to implant something on top, you have density. If the existing hair falls off, again the density is lost. So always medical management is important. You want to be specific about the medical management?
You can add whatever you want, no problem.
See, basically a lot of people have a thing like, you don't need the nutritional support. Please remember that whenever, if you test a patient for any nutritional deficiency, it's not going to be there. The reason being, hair is the storehouse of most of the nutrients. When a body is in deficit, it will use lysosomal induction and bring back the nutrients from the hair storage back into the system. So every time you test, it's going to be normal. Doesn't mean that you should not load it back. So if you load it back, then it goes inside. When the hair goes into anagen, it wants these nutrients. If the nutrients is not there, again the anagen will be cut short and it will go back into telogen. That is why the hair is not growing. So you have to explain that to the patient. You have to give treatment. If you are planning for a hair transplant, please give treatment for 6 to 8 months before you plan a patient for hair transplant. You might lose the patient, but patient might go and do it from another doctor. It's okay, but it is a long-term relationship which you will have with the hair transplant patient. It is not one-time procedure. It is not like what they're doing here out. Everyone is just putting a hair transplant center, non-dermatologists, even non-doctors are doing it. It is not like that because this patient, see, before I left, I saw a patient who had done hair transplant for me 4 years back. I always tell my hair transplantation every 6 to 8 months, you have to just review with me, either through WhatsApp. This patient came back. Why he came back? He has only the implanted hairs, all the other hairs he had lost, almost 50% gone. So I said you have to start your medical management again. So that's how it is. So hair transplant patients don't leave you and go. And if you take the case of Salman Khan, he has done it 5 times. If any of you know that, he has done it 5 times. His back of his head is actually very small because completely FUT was done on his back of his head. So anything else should I add, sir?
Let the other doctors add too. Yeah. Dr. Sujila, you want to add something?
So yes, sir. As dermatologists, we are at a unique advantage that we can give a complete wholesome treatment to these patients because it doesn't end with hair transplant alone. As sir was saying, yes, it's ideal to put the patient on medical therapy first, see how much of response they have. There's an advantage here because if they're already responding fairly well with the medical therapy, then their burden on hair transplant also reduces. So counsel the patient, explain to them why it is more of a continuous process and not just a single surgery. And even of course, after the surgery also, they have to continue with medical therapy for quite some time to retain those transplanted hairs. So the counseling forms a very important aspect.
Sir.
As far as the medical management is concerned, I feel that if you are not using an anti-androgen, the response is very poor. So I, most of the time, if my patient agrees, I put them on, my favorite is dutasteroid, and I don't give full dose, I give 0.5 mg alternate days or twice a week. Because it's a long-acting one, it works. Along with that, the minoxidil you can give, and if the patient is willing, add PRP if the patient is in the younger age group, less than 35. But that definitely helps in the overall growth.
So if the patient is around 25, 26 years of age, so would you suggest him PRP or hair transplant?
Sir,
after 3 months, his hair loss has stopped.
We have
given
to look
him
at
medical
the grade,
treatment.
Sir. If he is looking at the grade, a patient with extreme hair loss, it will take almost a long-term treatment, almost 2 to 3 years to do something for him. But if he is 26, he might get married in a year. So in that case, we have to do the treatment and the hair transplant together. If the patient is 22, 23, postpone. Go with only medical management and PRP. PRP really works. Please give it. You can actually make it cost effective for the patient. It's all in the hands of the dermatologist to bring down the cost. I know people charge a lot, but we can make it nominal. I do a lot of PRPs, a lot of patients from very far come and do, and the only thing they say is, sir, when you give it is working. It is not that. Because my price is less, they have a feeling that they can do it regularly and correctly. The patient, that is very important with PRP.
How many number of sessions do you do, sir?
Sir,
If you're saying that economy is brought down, more number of sessions.
Yes.
So how much is more?
So PRP is like going for tuition, sir. You need to do it regularly.
How regularly?
The first 4
Like
sessions we have to do it within 4 to 6 weeks. After that, once in 2 to 3 months is sufficient, sir.
Once in 2 months?
2 to 3 months is
Once
sufficient.
in 2 to 3 months. How long do you want to continue like that?
Till the patient plans for hair transplant or going for marriage.
Is perfect.
After marriage, I tell you, just leave it. Tell because of marriage, I had hair loss.
That's a common thing I tell my patients too. So in case if given an option of choosing between dutasteride and PRP, which one would you vouch for?
Both are different, sir. Dutasteride is a different class. It is a targeted drug. PRP is not targeted. PRP we are giving it as a it works 20% to 80%. We don't have a perfect score for it.
Yeah.
But dutasteride will work. There is till now we have not had any problems with dutasteride, even for finasteride.
Yes.
People who are not responding finasteride, yes, they are adding dutasteride now.
Yes.
But you cannot compare both, sir.
Okay.
But dutasteride, I don't know, sir.
Other panelists can your
Dutasteride
take
in
on
younger
that.
age groups.
Given dutasteride and PRP, different age groups.
Like he said, it is not. There is no comparison between the two. Two works differently.
Age group, sir. According to the age group.
Do you have any preference with age groups? If not, it's okay.
See, age group is, I would like to start even for a person who's 25 years old or this thing, but he should accept. Most of the time they read on net and they don't want to accept it. So 25 or around marriageable age, they somehow want to avoid that. So nowadays the new lotion form has come. I don't know how much it works, so we give a trial of that to these cases.
Okay. So coming to the topical anti-androgen, the finasteride and this one.
Yes.
So did you ever combine a topical anti-androgen and an oral androgen in your experience?
No.
There
sir.
is no purpose over there. There is no scientific rationale over there. But did you ever try doing it?
Sir, I have used topical finasteride, and recently I am trying out a gel form of finasteride, topical finasteride. Now the thing is like this. If you start a patient on finasteride, want to stop him, then you already start him on the finasteride gel and you can slowly take off the finasteride tablet. But a patient whom, you start on finasteride and suddenly stop and then you give a topical finasteride gel, there is going to be a huge hair loss. So patients won't like it. Either if you want, you start from topical finasteride and keep going with topical finasteride, definitely the results are there. It is the same holds truth for all the biomimetic peptides. Please don't try to stop the main thing, and then only the patient on biomimetic peptide doesn't work. But if you start female patients only on biomimetic peptide, yes, the results are continuously better, sir. That's what I have felt.
Yeah, thank you. Dr. Sujala, in finasteride or dutasteride, would you take a consent or anything of that sort when you're telling to the patient? Would you explain to them, take some time, dwell over it, saying that it's a myth, but this is something that you're supposed to know? Do you mention
Yes,
like
sir.
that to each and every patient of yours?
So yes, sir. If I'm considering to start the patient on finasteride or dutasteride, I do take like 5 minutes extra, explain to them about the drug, how advantageous it is to add on as a therapy, and if they open up their mobile and Google what are the common side effects they come across, because that is the main scare that they have.
Yes.
But though in our practice when we do give these drugs, we do not come across these side effects as often.
Yes.
So it is always good to talk to the patient about this, take their consent and then start them on.
Okay. You want to add something?
See, every time when you give finasteride, there's few things which I have learned over the years. Giving finasteride in the morning actually works better. That is one point. One more is a patient whom you have put on finasteride, call them on the first month and the second month without fail and ask them one question. Are you feeling drowsy when you work? Are you feeling a little bit of, kind of like if you take an Avil tablet, are you having that mental clouding? If that patient says yes, immediately stop finasteride, because those are the ones whom I have seen that they go into a sexual side effect. And finasteride on an elderly patient, ask, you have diabetes, because they already have diabetes. So rationally they are going to have a problem with their sexual function. So if you give finasteride and they read it on the net, that's enough. They will not admit that they have a problem. They will tell it is because of the finasteride. So these two aspects only where I have felt finasteride is wrong, is the problem with finasteride. But rest all, I have given finasteride comfortably. All the patients till now I have seen only 3 or 4 patients, and in that 1 or 2 were representatives because they read in the net, they set up the complaints, because you know about the nocebo effect. Even if you give a drug saying that this is the complication and you give sugar, it will still form the complication. So it is called nocebo effect. So many patients are actually having that rather than the actual complications.
So in that age group of around 25 and above, we usually see more number of factors which can contribute to erectile dysfunction. Like they are working in MNCs, they could be working in night shifts, they could be having depressive tendencies, they could be having pressure situations. So those kind of things can actually trigger this erectile dysfunctions or the sexual dysfunctions what we are talking about. Now, in patients with PRP, in patients with females, AGA, what PRP changes that you can expect? What changes do you expect with PRP sessions? Do you really see good amount of results in female pattern hair loss as much as you see with male pattern baldness? Is there any difference of pattern of improvement? What do you see with PRP?
So with PRP, when we start, first and foremost, what we get is the stopping of the hair fall.
Yes, sir.
That is very dramatic, and that is the only one the patient always feels happy that my hair fall has stopped.
Yes.
And I start seeing new hair growth, particularly at the margin of the hairline, after 3rd session. So
you mean to say on the temporal and the frontal side, you see good improvement?
Yeah, mostly because probably vertex I may not be able to appreciate much, but small intermediate type of hairs we are seeing at the hairline.
Okay.
So we do see at the 3rd or 4th session.
Okay. How about you, ma'am?
So even I feel that there's a little slower response in women as compared to men, like with the hair growth. Yeah. AGA, yes.
AGA is less, sir. Telogen effluvium, the results are good with PRP, but with AGA, it's 1 out of 5. Maybe 1 out of 5 are good, giving good results. That's my opinion.
So in PRP, supposedly if you're watching for PRP and you're saying the patient that PRP is good for you, so what are the investigations that you would like to do before going for PRP sessions?
I don't know. I just do only the platelet counts. That's all I do. I don't. Other than that, yes, we do all the.
Yes.
The
You mean to
medically,
say
do they have the
routine
like
investigations,
do
vitamin
they have
B12?
thyroid and things
Yes.
like that? Those things we see for hair loss normally. But as such for PRP, I don't think I do any investigation other than doing a platelet counts.
Okay. So after doing a few number of sessions,
Yes, sir.
have you seen any patients who were dropping on ferritin?
I know, sir. I think we should answer that.
Yeah, I have seen few patients around 3 to 5%. That could be negligible, but that is what I just noted it. that after few sessions of PRP, there was a drop of ferritin after 8 sessions or so, and then they started having hair loss. Have you seen this kind of any hair loss in between the 3rd and 4th session if you're doing it once? Like
Probably
in
you're
between?
drawing too much of blood.
10 to 20 ml, I don't think that's a big problem, sir. They donate a lot of other substances otherwise also. Okay. So any investigations prior to getting the PRP done?
Only the platelet count, I do that. And from the history of any bleeding diathesis, that's all.
Okay. Would you like to work up on vitamin B12 and ferritin and viral screening before starting the PRP sessions?
Yeah, most of the time I don't do specific platelet count. I do a CBP or a hemogram which gives you that value, and in that we see the other things also. So if there is anything, we correct that also along with that.
So you wouldn't vouch for viral screening?
Pardon?
Viral screening, sir.
No, I don't do because it's autologous, so I don't do it.
You have to do. I would like to make a remark on this. One patient, I've done multiple number of sessions of PRPs, but one patient turned HBsAg positive. So I would recommend, on a personal note, I don't know about the guidelines. I think the New York guidelines have been published in IADVL recently, so I've not gone through it. But viral screening is always beneficial because one time I had a spill injury which it directly went into my eyes, and that was with fractional CO2 and a PRP session. That was around 8 years back. That's when we didn't have much guidelines for the PRP, and that's when I started doing viral screening. Now, when we are talking about PRP and this spillage and all these things, so in hair transplant, would you like to use PRP? Yes. So, did you see any kind of dramatic improvements with hair transplant and PRP?
So, the uptake is definitely good. The healing of the wound is excellent, sir.
Sir?
Post-surgery, the healing of the wound is much faster.
So, you mean to say that you're going to give PRP in the donor area as well?
No. Donor, I just take the remaining solution, PPP, and just...
Which one?
The PPP.
Plasma.
I just dab it there, and I use Region D, sir, to be frank.
Oh, Region D you advise for the donor area as well.
Area,
That's a very interesting point.
Within 3
Yes.
4 days it is healed, sir. 72 hours it is healed.
So you mean to say that the patient doesn't have to have a dressing after 3 days if he is using Region D or the epidermal growth factor?
Next day only I remove, sir.
Okay.
Next day only they are okay, sir. You have to use Region D to believe it, sir.
So yeah, Region D works wonderful. You are the one who watched, and I learned from you, and then I'm using that. But definitely, but this is an interesting point. After transplant, if you use this one, I think
very
that's
safe,
good.
nice.
Yeah.
Less oozing. Patient is healed very fast.
Okay. Okay. Good.
We can
Good.
just use the surgical cap for the next 3 4 days.
Okay.
Before we advocate first hair wash.
Okay.
First hair wash, preferably we do it in the clinic, sir.
Oh, okay. So you like to show the patients how the shampooing is done,
Yes.
and thereafter they can carry on with that. Dr. Sujila, your take on that, PRP and hair transplant?
I agree, sir. Yes, sir. Definitely.
Yes.
I agree with what Dr.
Is there any
Ram
set
says.
of patients that you would like to prefer to use PRP and hair transplant, or is it like a blanket that, you want to use it for everyone? It's like a blind thing that you want to...
No, sir. Probably in the more advanced AGA grades, 4, 5.
4, 5. So do you think the PRP will be helpful in 4, 5 stage?
Yes, sir.
Yes.
To a fair
Okay.
extent, yes.
Fine. Any other questions from the audience regarding hair transplant or PRP? You can ask. You can just sit down and ask as well.
Sir, that scarring alopecia, sir,
Yeah.
there is a lot of fibrotic tissue, sir. So it's like you trying to plant a sapling into a rocky area.
Yes.
So ideally, instead of slits, if you put a 1 mm punch, create holes. Take you are already taking with 0.8 or 0.9 FUE.
Yes.
I think that is a better way to do it, sir. And the punch has to go slightly deeper where you can actually get the bleeding. Because in fibrotic tissue, sometimes we don't get the bleeding.
Not at all.
If the bleeding doesn't come, we are not sure whether it's going to get that supply or not, sir.
Yes, sir.
And as you said, CO2 fractional is a good option to do in the scarring alopecia. After you are confirmed that the scarring alopecia process is out, you do a CO2 fractional 2-3 times before you start the implant. The skin is in very good shape to actually accept the graft, sir.
Yes.
That's what you were trying to say, sir.
Yes. Definitely. And yes, please.
With this, especially in case of scarring alopecia patients, PRP plus FUE. Again,
That acts very well. That
very-
helps
yeah.
very well. How about fat transplant? I've never done that. But few people, they mention about it. What's your take on that? Fat transplant and then take up of this.
Sir, fat transplant and dermal graft I do only in morphia, sir. First I do the fat graft
So
after
that's a
settling
dermal pathology. So you're getting good results in morphia with fat transplant,
only there I
right?
do, sir. I
Right.
don't do it in-
How about in this? If you want to take a view on
I
this.
have not done that.
No, your view. Probably that can help.
Maybe, but the area is too extensive for me to test, sir.
Okay, okay,
I'm
fine.
a little bit worried about the areas.
Okay,
Too
so
much
you
of
might
bleeding.
not watch for it. That's the
Yes.
point there.
I don't want, because if it ends
Fine.
up in necrosis, headache, sir.
Okay.
The large area we are doing, so I'm a little bit worried about the necrosis part. But I don't know, I've not done, so I can't.
Okay, okay, fine, fine. Any other questions so that I can wrap it up? Yes, Naresh, please. Yes. That's a good question. When is the best time to inject the PRP? You mean on that intraoperative day, right? Is it like in the morning, or is it in the afternoon, or is it in the evening, or is it after the transplant is done, or is it before the after the slits are made, then you want to do the PRP?
Sir, I don't give it before the surgery. I give it after the slits are made, after the oozing has stopped. Then I will give PRP. Then I will just spread the PRP and then use the grafts. Yes, PRP helps, but the stickiness of the PRP helps to secure the graft also. Please remember that.
Sir, one thing I
Yes,
wanted
sir.
to know. Hair transplant and then we do the PRP. I mean, on the day of surgery, when it is going on, when the slits are made, and then we do the PRP. But when the tumescence is given again, then again there is a runaway of the PRP into other tissues also. So how is it going to help with when PRP is being diluted with normal saline? It's all in the tissues. So do you think it's like just a thought which popped up right now? So I'm just asking
You're
if you
correct,
don't
sir.
mind.
But see, basically my amount of tumescence is less, sir. That is why I think maybe because of that, maybe that can be a factor. But I give the local first, make the slits, stop all the oozing, then give PRP, then start the implant. This is the process which we do, sir.
Oh, great, great. That's nice.
That's the
That's
way
nice.
I do
Yes,
it, sir.
yeah. Anyways,
I just found it out by trial and error, sir. That's all.
Yes, yes. John sir has been working on hair transplant and every technology for the past 2 decades, sir. I'm sorry. I don't want to make you that much old. But yes, I have been...
Exactly 11 years, sir.
Yeah.
10 years.
Yeah. He does a lot of innovative work. I've been listening to his lectures from a long time. And
Maybe 15 years, sir.
yeah.
Full-time lasers.
Yeah. So I thank the panelists.
Sorry, just a point.
Yeah,
sir.
please,
So
please.
with respect to the intraoperative oozing, what we found was giving 1 dose of oral tranexamic acid just before the surgery. It reduced the bleeding to a good extent.
Oh, that's a
There's
good.
something
That's a
that
good
tried,
point. So how much dose would you give?
So I would go with the 500 milligram stat.
Only 1 dose.
1 dose.
Which time? Like in the morning?
The day before, the night
the day
before the
before,
surgery.
the night before the surgery. That's an interesting point. That's a very nice thing. How much bleeding would it be reducing it to? Like 30%?
So it's significant. I would say more than 50.
Yeah, that's good. So less bleeding, less oozing, and there's less chances of transactions and other factors. So I would like to thank the panelists for the impromptu panel. Just randomly, we just took them up around 2 minutes back before we had informed them. So thank you for your patience and sorry for the cross-examination. Sorry for that. Thank you anyways.
Thank you.
Thank you.
Sorry.
For the session of dermatosurgery, I would like to call upon chairpersons Dr. D.B.N. Murthy sir, President of 2021 TS IADVL, and T. Naresh Babu. They didn't tell where we are from, sir. Dr. T. Naresh Babu sir, Associate Professor, Kamineni Institute.
Hello. I request Dr. Putta Srinivas, who is working as a director for Government Medical College, Mehboob Nagar, to moderate this session on dermatosurgery. I request Dr. Putta Srinivas to take up the proceedings. Over to Dr.
Yeah, good afternoon to everyone. Without wasting much of time, we are well in advance, I suppose. I call upon the panelist, Dr. A.K. Lahari, please come on to dais. Dr. P. Padmaja, Dr. Rajiv Singh. Rajiv Singh, please. Okay. Then Dr. Rahman. Dr. Nazia Naushin, please come on to dais. One more chair. Yeah, fine. No, that's okay. Your laser pointer. Press it on. I think our chair actually is. You know, adjust the chairs there. అక్కడ పెడితే చాలు ఆ దీవ్యం నువ్వు ఇటువైపు వచ్చేస్తే అటువైపు తనకు కూర్చుంటుంది. Naresh, you come this side. So both madam will come on that side rather. Yeah, that will help them to see the slide. So good afternoon to all of you. Today we have last but one session. One more session is there. Last session. I hope all of you are not sleeping, right? So we'll discuss in dermatosurgery, particularly the case discussion, case-wise, case scenarios, right? The first slide. Yeah, before that, I would like to introduce our panelist here. Okay. Which one? Okay. We have that Padmaja, that A.K. Lahari, the senior dermatologist, and he's senior to me from GMC Secunderabad. He's more dermatologist consultant. And we have that P. Padmaja, professor of dermatology, Usmania General Hospital, now in Gandhi. Yeah, GMC. Differentiate in your surgical OT or minor OT or procedure, whatever it is. How you differentiate between vasovagal attack and anaphylaxis clinically? Any mic there for audience, please? Any mic? Audience. Clinical I want. the theory aspects all of us can discuss for hours and hours. But clinically, how do you differentiate on the spot? Somebody falls down when you give xylocaine or some procedure you are doing intralesional, any material, or maybe steroid, maybe bleomycin or something else you are injecting.
The patient can still speak.
Madam, you are not there, I'm not audience.
Sorry.
Please. I want the faculty to be involved. Audience, please. The PG says all the... because the most important thing is, in dermatology surgery, is to overcome the fear and panic situation and to respond. You must always keep your supporting staff ready to support you in case there's some emergencies there. Your nurse or your office subordinate or office, your receptionist should be trained. When there is some situation comes like this, they must help you how to check blood pressure, how to see the pulse rate, hopefully there is pulse oximeter, and how to assess the vitals of the patient. That will go a long way to make you comfort and manage the situation. Right? It's very important because the treatment totally differs between vasovagal attack and anaphylaxis. And I request that Nazia, clinically, suppose the patient is there, you intravenous steroid. Right? It's supposed to be very safe, you know. You might have given thousands of injections in your PG and now in the practice also. Clinically, in the bedside, how you differentiate between anaphylaxis and vasovagal attack?
I had quite a few experiences with this, both anaphylaxis and vasovagal attacks, sir. So clinically, when we differentiate, we can see the procedure or the method. Vasovagal syncope can follow any procedure, not just the injection or the drug. So in the history itself, we know there is no need of any injection. The patient can fall down just at the vision, of some blood or some before we inject something. So it could be vasovagal. Just with the pain also they can fall. Whereas anaphylaxis, definitely there's history of injection or taking of a medicine, like in this immunizations or in intralesional steroid application and xylocaine. So anaphylaxis has more of drug history. And clinically, when we see the patient, anaphylaxis, we can see some skin changes, like it can be itching all over the body, erythema, urticarial lesions, and swelling on the face. So in anaphylaxis, and vasovagal attack, patient might not have any cutaneous findings. And also, in vasovagal attack, the blood pressure of the patient might not be recordable. Sometimes we will not be able to record the blood pressure. And in anaphylaxis, it's not like that. It is it's more of it follows the immune reaction. So it has, the patient falls down, but sometimes the blood pressure might be recordable. And that's it.
Before I proceed further with other panelists, how many of you are keeping the emergency drugs in your clinic? Raise your hands. Those are having emergency drugs to manage anaphylaxis in your practice. Audience, please. I hope all of your PGs, rather. Anyway, your departments, how many of you are having the emergency drugs to manage anaphylaxis? Good. I'm very happy to quite a good number of hands are raising. That's excellent. The point is the prognosis differs drastically between vasovagal episode and anaphylaxis. Now I request that Padmaja Madam, clinically how you differentiate these two episodes? Clinically, in the bedside.
Actually, bedside vasovagal attack, the patient becomes suddenly pallor and pulse cannot be palpated. That is the main thing, vasovagal attack. Anaphylaxis, there may be some skin rash or itching, burning sensation or something, all the things will be there.
Yeah, Dr. Rahman, can you add anything in relation to what Madam has already between these two conditions? You can use the mic, please.
As already Madam said, in case of vasovagal attack, there will be no skin lesions. Same in the anaphylaxis, there will be most of the skin lesions present. Rash will be present spontaneously, and in case of vasovagal attack, there will be patient may be in the hypotension. So main that reasons.
So I think there is some confusion regarding the pulse here. In case of vasovagal, there is bradycardia, and you feel the pulse very well as compared to anaphylaxis, where there will be a tachycardia and a low volume pulse. So there is a very simple, if you just feel the pulse, you will know the difference. and cold and clammy skin in case of anaphylaxis. So these are the easiest method to do immediately. So once you are able to feel the pulse, you are sure that it is more likely to be vasovagal. Of course, in anaphylaxis in the initial stage you may have that, but to know that you are more likely to be a vasovagal.
I think more or less vasovagal attack is because of increased vagal tone and sudden fall of the postural hypotension. The patient falls down just by simple giddiness. In anaphylaxis, we can take the snap of this particular slide. In anaphylaxis, there is an allergic reaction. Patient feels impending doom. He feels something is going to happen. He panics. He says impending doom, something is happening. Sir, the skin will be cold and clammy in anaphylaxis, whereas in vasovagal attack it will be normal temperature. There will be itching in anaphylaxis. There won't be any itching and urticaria in case of vasovagal episode. And as rightly said by Dr. A.K. Lahiri, there will be tachycardia most of the times in anaphylaxis, in bradycardia because of increased vagal tone in vasovagal episode. And there will be hypotension in anaphylaxis, whereas blood pressure will be normal, non-hypotensive in case of vasovagal episode. And the drug of choice is adrenaline. Always remember, adrenaline is a life-saving drug. Just 1 ml ampule you get most of the times. Expiry is only 1 year, clear fluid, give subcutaneously, or nowadays intramuscular also recommended. Whereas in vasovagal episode, simply make the head low and raise the limbs. You'll recover in few minutes, right? That drugs, in case of drug useful mostly in vasovagal episode, atropine, 0.6 milligrams per kg body weight is the drug recommended for vasovagal episode. In adrenaline, you have life-saving drugs like, which is life-saving steroid? Any from audience, please? Life-saving steroid? Yeah, people generally say Decadron. Never say Decadron. It takes long hours to act. Say hydrocortisone. There are two molecules. Hydrocortisone, hemisuccinate, and one more hydrocortisone. Both act equally. 100 milligrams can be given IV statin. That's all. You can use stat, right? So these two drugs, life-saving drugs, but keep along with you in your clinics. Not only magnifying glass and all the gadgets, but also keep a BP recorder, pulse oximeter, and a stethoscope, and a well-trained supporting staff for you in case of emergencies like this. Just to make you aware that emergencies can never come with prior intimation. They just come suddenly. Any case can give you trouble any time, and one troublesome case is sufficient to give you headache lifelong sometimes. So be prepared to face these emergencies. They're easy to face. Don't panic. Keep all the emergency drugs ready and train the supporting staff. Be bold. Do manage. Meanwhile, if possible, call an ambulance and call your colleague nearby. Always, maybe a physician, anybody who's up nearby your nursing home or clinic, call immediately. So they'll give you a lot of lending hand and support in case of needs like this. Okay? And now next, coming to today's topic. Keloids, we see keloids very often as dermatologists, and we need to manage them most of the time surgically or based on surgical procedures. But today's my interest is particularly this type of keloid and the ear lobules in the back, at the front, sometimes lobule and the helix, sometimes dumbbell shape. Dr. A.K. Lahiri, these type of keloids on the ear lobules, ear helix, how they are special and how to manage them?
The special is that the recurrence rate is much less than the body keloids, one thing. Second thing is the managing an earlobe keloid depends upon the morphological type. There's a Chang and Park's classification to do the auricular keloid classification. So if it is pedunculated, you can do a shave excision and do it because your base is very small. But if it is sessile, I most of the time do a core excision. So you open up, remove the fibrotic core, and at the time of removal, you can give a combination of steroid and xylocaine so that there is no proliferative phase starting immediately, and then you can close it under less tension. So that is, you trim the excessive skin and just close it. You may or may not need an intralesional steroid as a follow-up, because many a times, probably I would say 7 out of 10 will not need a steroid injection as a follow-up. There are few cases who will need.
Yeah, that sums up a lot about this earlobe keloid. I think that Madam Padmaja, can you add some more about earlobe keloids and your way of managing them?
Actually, earlobe keloid, I do exercise the keloid in the debulking and give intralesional steroids to reduce the recurrence rate. And usually, in earlobe steroids, recurrence is very less common. And if at all it comes, it is a small keloids may come sometimes after a long period. But we can manage with the intralesional steroids later on.
Right. I think my purpose of this panel discussion is mostly to encourage from the audience to get questions. I request, please pass on the papers to the audience to ask questions. My point of putting these pictures and questions is to initiate discussion. But I want you to involve yourself. Ask your doubts, send me your papers on a piece of paper, your doubts and questions, not only on these topics, any other topic also. I'll pass on to panelists to answer them so that you go with satisfaction. Please, okay? Now, keloids on the ear lobules differ compared to the keloids in other areas. The reason is, in the ear, particularly on the helix, there is not much of tissue to support. There is skin and at least cartilage. There is no muscle, no fascia, no bulky mass in case there is an over-injection or over-removal like that. Here, the moment you enter the cartilage part of the ear, there is likely to be deformity, likely to be a lot of complication. That's why the very thin margin of error is there on the ear lobule, particularly on the helix. But you know, the Indian culture of having a lot of ornaments on the ears is such a temptation and such a common thing. Lot of cases we do see in the ear lobule keloids. So ear lobule keloids, they differ from the reason that there is not much of supporting tissue beneath. And if you go deeper, there can be a complication in the form of deformity of the helix or the ear lobule itself. So how do you manage is, mainly I agree with Dr. Padmaja and Dr. Lahari, that you are just debulk, remove the core tissue. Remove the core tissue, suture it, and there are 2-3 opinions. While suturing, there is a method of school to inject intravenous steroid with 5-fluorouracil. That's what I do. After removing the core tissue of the keloid, resuturing, the suture line, I inject 5-fluorouracil with 10 milligrams triamcinolone dilutions 1:5 to 1:10. I inject into injection line. But there are certain different opinions to reduce the recurrence of keloid. The reason why 5-fluorouracil is that because it prevents the fibroblast to recur again at the time of healing. That's why 5-FU is very well recommended and gives very good results. But on the other hand, I request Dr. Lahari, in addition to debulking the tissue and injecting the intravenous steroid, do you adopt any other method, including while giving anesthesia also?
First is, before the procedure, when I give anesthesia, I mix Kenacort, I would say the trade name, along with xylocaine and inject in 1:1 dilution, so that we get a preemptive inhibition of the proliferation of the fibroblast and collagen. And intraoperatively, after removing the core, I wash the base of the thing with 5-FU solution. So I wet a gauze with 5-FU, pack the wounded area for 2 minutes, and then wash it, with the hope that the 5-FU will kill the fibroblast, which is the causative agent in producing more collagen. So is used as an adjuvant to decrease the reactive phenomena.
Just before going to that recurrence rate, I want to add that one more thing that after a surgical excision of the keloid, we can do RF radio frequency debulking, sir. And also sometimes we can use laser debulking and then followed by suturing techniques. This is both the intralesional corticosteroid and bleomycin injection. There definitely helps in a recurrence. And
Actually, in my personal experience, if the keloid is more firm in the cartilage area, 2 weeks prior we can give the xylocaine with triamcinolone, then it becomes a little softened and the excision will be more xylocaine with triamcinolone, intralesional, like, 2 weeks prior to the surgery. Then after that, if you go for the surgery, the debulking will be
Easier.
more easy, and the suturing is also becomes more easy.
Yeah.
And after that, if required to reduce the recurrence, I preferably give intralesional steroid only after that.
You want anything to add? You want Nazia? Anything? Same.
I add only intralesional steroid only I give, sir, not of bleomycin.
Okay. Yeah, intralesional steroids, definitely recommended. Triamcinolone acetonide. And you can combine 5-fluorouracil with intralesional steroid. Or you can use soak as that Lahari is using. And bleomycin also recommended. So keloids on the ears, the message from the panelist is that first, the volume is big, the size is bigger, at least 2 to 3 weeks prior or 4 weeks prior, inject intralesional steroid to reduce the mass of the bulk. Then excise completely. Then during the surgical procedure itself, you give intralesional anesthesia, along with that add some amount of steroid also in combination. After surgery, you can soak with bleomycin, 5-fluorouracil soak, or into a suture line, you can inject 5-fluorouracil with local steroid. That's how they follow. I also practice. Of course, there are reports of bleomycin injection into the suture line at 2 to 4 weeks intervals, right? 1.5 units per ml. All other very economical medicines. 5-fluorouracil very cheap, right? So this is the case I have shown you in the beginning. This is before surgery, this is after surgery. And in injecting into the lesion 5-fluorouracil with local steroid, intralesional steroid, right? The same case before and after, this is after 8 weeks. This is the ear lobule keloid. This is afterwards, right? This is before and after for comparison, right? So then other modalities are cryosurgery in keloids. So it is a definite role of keloids being treated with cryosurgery. Generally, the treatment of choice is liquid nitrogen. So, madam, can you share your experience with liquid nitrogen with keloids? What is that?
Actually, nowadays we are using like a liquid nitrogen pen type is coming. That is the small keloids we can try for the liquid nitrogen.
No, sir. Honestly, we were using when I was in medical college, we were doing in naked medical. But night in my clinic, I don't use cryosurgery. I do surgeries or intralesional steroid incision. But the procedure, good cryo, it has.
So you have to.
Very effective agent, but you have to inject through a derma inject that's your try and do it. It's very economical and you can use that. Yeah, I'm sorry. So liquid nitrogen cryo I do use for keloids, particularly in the normal areas like hands, chest, and other common areas location. It gives very good results. The only thing is that you have to balance between the temperature you raise and freeze-thaw cycles, right? So I use a low freeze-thaw cycles of 5 to 10 seconds only, and at 4-week intervals in 2 to 3 sittings, right? Response is quite very good. Recurrence is very low. 85% response is there in all the keloids, right? But to reduce the chance of hypopigmentation, I use low freeze-thaw cycles of 5 to 10 seconds. And the hypopigmentation is of two types. There is temporary suppression of melanocytes physiologically that recurs in the next 3 to 6 months. Sometimes melanocytes may get destroyed permanently because of extreme low temperatures. In that case, the hypopigmentation may not completely recover. These are disadvantages of cryosurgery with liquid nitrogen. So you can see a keloid on the neck in a young girl. This is before subject liquid nitrogen cryo. This is after 2 sittings. So it has reduced size by more than 80%. One area is small, a small area of hypopigmentation laterally, then it subsides in 3 to 6 months' time. These are the keloids on the chest, a normal location for keloids. This is immediately after cryosurgery. You can see the blister formation, mild necrosis also, right? This is after one sitting. You can see that it has reduced by more than 50%. Another keloid on the right wrist. This is after 2 sittings and 6 months post procedural time. Then cystic acne and acne scars. Next topic is that. Madam, that Padmaja madam, this boy is a young BE student. He comes from Warangal area. He was very scared because he was not able to go to the college. And he had similar lesions on both cheeks. Literally, he was so much afraid to go to college. He used to cover both his cheeks with kerchiefs and go to college. He was so ashamed. Sometimes, appearance also matters. He was teased by his own friends. So that is being the situation. Madam, what treatment you suggest for this boy?
Actually, this is the cystic acne. It's, actually, first of all, we under the cover of broad spectrum antibiotics, we have to evacuate the material in the content in the from the cyst. Then, along with the intralesional steroid, we can give. After that, depends upon his lipid profile levels. We can start isotretinoin along with antibiotic.
Okay. That nausea. Let's add anything about this cystic lesions.
Yes, sir. First start with the
not rare, but quite may not be unusual, but you might see quite often these type of cases. Right.
Like ma'am said, I usually try
to Mike,
at the same procedure when we are giving intralesional steroid in that, we inject the contents of the cyst, and at the same time we give intralesional steroid also, and then we followed by isotretinoin medication. Sometimes it needs to puncture the needle and take out, as if they are sebaceous cysts, we have to take out the sebaceous content and if needed suturing also.
That Lahiri?
See, when we do IND and we give steroids, we have seen most of the time in 2 to 3 weeks they come back with a similar size cyst. So what I normally do is after draining out, I curate it and then apply TCA 35% or 25% inside the cystic wall. So that creates an inflammation and makes the cystic wall stick together. So the chance of filling up the serous fluid is less. So in that way, if you do, I think the recurrence rate comes down.
The TCA you apply inside the cyst or outside?
From the point where you are entering your needle to drain, you can use the small curettes which you use for warts. You can just dip it into the TCA. That scoop has enough TCA. You just put it inside and rotate inside. So 1 or 2 times the TCA is enough to coat the whole wall.
I think these are the cases which need a multimodal approach rather. So we need to treat here not only cystic acne but also acne as such. You need to give antibiotics as antibiotic preparation like azithromycin and whatever you tetracyclines. But prior to that, you have to evaluate the patient. These are the ones who are emotionally more disturbed emotionally. So they need a lot of counseling. Then give anti-acne treatment with standard protocols, and do give retinoids, because retinoids are the mainstay these days. And unless you can treat a cystic acne, what he is having right now, but down the line, next 6 months, he may get classical acne also. So that needs to be managed simultaneously. And as Madam and Lahari has said, you need to give systemic antibiotics at least 1 week, 10 days prior to that, to reduce the load of commensals and pathogenic bacteria on the surface of the skin. Then with all the standard surgical cleaning procedures, evacuate the cyst, the dependent area. That's very important. Don't do in the area where it has to go under the gravity. Do in the dependent area and aspirate the contents as much as possible. Then give intravenous steroids in dilutions. Then you can add little xylocaine also. And when the bulk of the cyst contents are evacuated, to reduce the chance of recurrence and allow the wall to collapse, the application of TCA, how much percentage you use that, Lahari?
I use 25.
Yeah, 25% TCA in a swab method. No?
Yeah, with the same stab wound, you just enter into it and rotate your curate,
Yeah.
so it spreads inside.
Yeah, just spread inside the walls of the cyst wall, then apply the TCA, then leave it like that. It collapses gradually. And usually it takes 2 sittings minimum for these type of cystic lesions. The same patient on the left side of the cheek, you can see one on the going very lengthy one. So what we have discussed now, aspirate the contents, inject intravenous steroidally with the triacetamide acetonide. Then Hyalase also can be added to reduce the fibrosis. I do add Hyalase for the steroid, and you have to give 2 to 4 weeks at intervals, and 1 to 2 sittings are sufficient for this. This is a before photograph. These are both before. This is afterwards. So after 2 sittings, you can see it has reduced by more than 90%. Right? Then along with that, I have given retinoids also. So gradually has recovered. This is on the left side. Almost 90% of cyst has completely gone. Then, before I proceed to further questions on this, we got a question from the audience. How to prevent? I think this topic of warts will come later, but this is something concerned with the tinea also they have asked. Okay, I'll ask these questions when the topic of warts come. Okay, is it that okay? Right. Then, madam, 11 minutes more. Fine. Then, the role of succession in acne scars. Madam, how do you find that?
Actually, in any type of acne scars, the substitution is the gold standard. Actually, if you give do the substitution 2 sittings or monthly apart,
okay,
then most of the 50% of the lesions will come down. After that, depend upon the scars, we can plan for the further management like PRP and all the things.
Okay.
Substitution is the first step in the management of scarring of what all the different type of scars. After substitution only we can think about any other procedures. So we can decrease the depth of box scars and all.
Yeah, just I have to go at speed now because we have to vacate the hall by 4:45 p.m. Right? Anyway, see the gold standard any acne scars, particularly the box scars, rolling scars and other type of scars is, the reason is there are fibrous bands between the scar and the underlying tissue. Unless you break these fibrous bands and release them, any amount of treatment, any type of treatment you do, advanced lasers also not going to help. You have to release these fibrous bands as a primary treatment of acne scars. This is mandatory. It may be time consuming, but worth it. So here you see acne scar on the nose, right? This is a mechanism I already informed you. So this is before doing procedure. This is after the subcision, right? This is post treatment. they improved by more than 50%. The scar has elevated by more than 50%. That's what is important for us to realize, that any advanced gadgets will be definitely useful, but without subsession and releasing the bands will not be of much use. Madam, just briefly, ice-pick scars, how do you treat?
Ice-pick scars is TCA cross is the best option, sir.
That Lahari, how about you?
TCA cross and focused high intensity CO2 laser. You just burn the hole through the ice-pick scar. You just have to do a deeper.
Yeah, ice-pick scars are special by themselves. Narrow base is very sharp, this thing is there. So you need to use a TCA cross, which gives very good results and a time-tested one in any situation. Now the chemical peels, for mild acne scars, grade 1 scars, which type of peels you use, that Lahari?
See, actually, it's not necessary that it has to be a mild acne scar. You can do even for superficial box scars. It only depends upon how deep you want to peel.
Yeah.
So if you can get a medium depth peel, which is good for our Indian skin, not the full depth peel like with phenol, which is not possible with us. So that there we do a sequential peel, or we use a combo peel. We use 2 peels. Like we can combine Gessner with TCA, or we can do anything to peel the epidermal layer. Like you can do a microdermabrasion, or you can do a fractional laser, and then put a 35% GLA or 15% TCA on it. So this combination ones will give you a deeper peel and will give you even results in superficial box scars.
Yeah, Rahman, what is your, you want to add on that?
Initially, we can add salicylic acid peels also. So,
Madam, how about you?
Actually, we can start chemical peels in the inflammatory acne itself to prevent the scarring. Otherwise, after scarring means we can go for the peels, glycolic acid peels and all. Before if the acne or active acne are there, salicylic acid peels are the best option.
Yeah, I think with my experience, SA peels are the best in acne, oily acne, seborrheic acne, or seborrhea comes with acne, and mild acne scars. SA peel is most useful, very effective. Whereas glycolic acid peels are useful, but medium depth peels, I am not happy with the amount of improvement we are able to get from that. Right? Then box scars, madam. Other scars like rolling scars.
If the bigger scars are there, we can scar excision and suturing. The smaller scars, scar removal and French graft also we can do.
Yeah, box scars.
Box scars, derma roller with PRP I'll do.
Okay, right.
We are doing also Plaxel to shoulder the box scar, sir. Plaxel laser.
Fractional laser.
No, not Plaxel. It's a Plaxel, small laser.
Okay.
And then microneedling, either it be a small pen type of microneedle or microneedling RF. Of course, we have to start with subcision. First subcision followed by any of the procedures. And TCA peel, according in my practice, I have seen wonders with TCA peel. 25% TCA gives lot of improvement in acne scars.
25%?
Yes.
Okay.
25% TCA person.
So you prepare yourself, or you get from the branded ones?
No, I take it from a particular company, because if I prepare myself, I have this impression that I might get post-inflammatory hyperpigmentation.
The pH is the one difficult to maintain sometimes.
Yeah, few formulations are not giving so much pH, because I have compared a few, but few companies, few TCAs, they are not giving any pH.
Okay. So this multimodal treatment of acne, just some few of my results I just want to show you. Then coming to vitiligo surgery. So that Padmaja madam, she has got vitiligo on the lip, lower lip. How do you treat that? How do you approach?
Lip vitiligo is the best option is a blister graft or ultra thin graft, sir.
How about you, Nazia?
Quite a few number of cases of ultra thin graft, and it both ultra thin and suction blister graft is good. We can do anything.
That's Rahman?
Sir, first one is this is a blister suction graft, then ultra thin graft. Even we can do micro punching graft, sir.
Micro?
Micro punching, sir.
Mini punch graft, right? Okay. That Lahari?
Yeah, same preferences for a blister graft.
Yeah. I think these type of mucosal vitiligo on lower lip or upper lip You first dermabrate completely, do a suction blister grafting or split thin grafting with thin one grafting, gives wonderful results. The best option is, and in these areas, punch grafting do give results, but you get polka dot appearance. Best is split thickness grafts or suction blister grafting, but do dermabrate light to the medium depth at least. Otherwise, take will be not sufficient. You get a stuck on appearance. So to prevent that, do dermabrasion up to medium depth.
Punch graft will be good in the angle of the mouth.
True.
Because it
I agree
stays
with
there.
you. I agree. So this is a picture. She has vitiligo of the lower lip, and the male having vitiligo lower lip. What we discussed just now. Do you use any one of you use autologous cultured melanocytes or cell suspensions? Any experience, Dr. Lahari?
Yeah, I do.
You do it. What are the results?
You are asking on the lip?
On the lip, yeah.
No, I would not prefer to do on the lip because it doesn't give good results.
Okay.
But larger areas where you have, patchy pigmentation, you cannot dermabrate properly. Those are the ideal cases where you can do NCS.
Yeah. I think these cultural melanocytes, all these things need little big setup and all that. For the beginners, yeah, please go, Nadia.
So it doesn't need, cultured is different. Non-cultured, what we are doing usually is doesn't need much setup, sir. But we can see the area, how much we have to repigment. If there's a smaller area, less than 10 centimeters, then any of the procedures, what we are doing, suction blister or ultra thin or fine. When we have to give a pigment of larger areas, like in female chest and all, so non-cultured melanocyte graft can give up to 10 times the pigmentation of the donor area. Okay. I have done quite a few cases and it's good, sir. So we can distribute the pigment uniformly, not like the ultra thin and split where the pigment starts from a patch.
Yeah, as per her statement, and it's true also, for small areas, the grafts, the suction blister grafting and thin split grafts are sufficient. But when you encounter larger areas to be covered, so the cultural melanocytes or cell suspensions will cover larger areas. That's her opinion. That's correct also, right? So this is a patient has shown you. This is before surgery. This is after fitness graft. Male lip, the lip part of the vitiligo, you can see. This is after treatment. I have 10 minutes more, please. I will wake up before 4:40 positively, right? I'll go along with all of you, right? Thank you, because everybody is interested in the practical topic. I'm not discussing theory, please. Huh? Okay, right. This is the after photograph. Then vitiligo of the areola area. What treatment you give? That Padmaja madam.
Areola, I'll preferably do the ultra thin grafts, sir.
Okay.
I had good response.
Nazia?
Yes, both ultra thin as well as suction blister. Like we tend to think that the graft what we are putting sticks on there and will become, it doesn't happen. The graft actually falls off. Only the melanocytes stay there, so there is no stuck on appearance actually even in areola region.
Lahari?
I would prefer to do an MPG in this because it simulates the Montgomery's nodules. So cosmetically it will give you a better acceptance.
Which one?
When you do punch grafting.
Punch grafting.
Because of the pebbling effect, it gives you the appearance of a Montgomery's nodule there. So cosmetically it looks similar.
Placing the graft is a little difficult because it is
contractures
and
no, you put the graft, use a surgical glue to seal it.
Yeah, sometimes we look from as a doctor or dermatologist the patient's problem. But what problem they think, how they perceive and their family relations and how they look socially is completely different. So this patient is a male patient, had this problem, was avoiding marriage for 5 years. His parents were asking for him to get married. He is a very rich person, he has got 1,000 crores of industry and everything. But he was not ready for marriage. He was not revealing the things to his parents. But he came to me with the skin, some other problem, then he told me, sir, he has this problem, how do you treat? Of course, we have treated him. Subsequently, his parents came and thanked, and really, they were not aware that this boy is having this problem. So you can see the vitiligo of the both the areola. This is after surgery with the split in the graft, right? You can see near normal appearance. And this is before on the left side, right side, I'm sorry. This is after the surgery, post-surgical. Then vitiligo of the eyelids, madam, how do you treat that, Rahman? Vitiligo of the eyelids.
One is the main is ultra thin graft and also mini punching, sir.
Lahari, eyelids.
Eyelids you can do anything. You can do a better is suction graft is the best one. Otherwise you can do a non-cultured epidermal cell suspension also, or you can do a mini punch grafting also.
How do you protect the eyeball? When doing surgery, how do you protect the eyeball? The practical things are necessary to be known to the audience.
No, see, when you are doing a suction blister grafting, like I asked the question before, I don't use an eye shield. I use an ultra pulse mode of CO2 to dermabrate the top layer of the eyelid. It is practically safe as long as the eyelid is closed. And then you can put a suction blister graft on it. For punch grafting, you have to be a little bit more careful. I don't advise the beginners to do on the eyelid. But as you gain experience and as you know the feel of the depth, you can do even that on the eyelid. And non-cultured epidermal cell suspension, coat it, put a collagen dressing on it and leave it. No need to dress also. So they give good results with that.
Madam, how about you? Your experience? Eyelids?
The suction blister is the best, sir, but protection of eye is with the eye guard.
No, eye shields has to be used, particularly the beginners and everyone. Don't take the risk, use eye shields, and that's as a safety measure, right? Then molluscum contagiosum in children and the locations on the face are delicate areas. We all know molluscum is simple to treat by extirpation and application of local
Can I ask one question?
Yeah, please.
When you are doing eyelid grafting, how long do you keep your eyelid shut? How long are we keeping it shut?
How long you ask the
did a
patient?
grafting, you have to keep the area stable, so you will close the eyelid. For how long can you keep it closed? For how many days do you keep?
How long means at least 4 to 5 days minimum.
Because the longer you keep, there is a problem of diplopia. So the shorter is 3 to 4 days is maximum, then you need to open it up.
Yeah, that practical point. You guys just close one eye for a week and all that, it leads visual problems, right? So they land up in new problem of diplopia and all that.
5 days.
Okay. Yeah, the next topic is molluscum in difficult areas and difficult age groups. Children and face a different treatment altogether. So this child had molluscum lesions entire face. You can see on the left, right eye, eyelids, and inner cancer of the eye, forehead, and the cheeks and around areas. Actually, they tried some local medicine. You can see a scar, the left cheek. They tried some lime and what is that combination of with lemon juice. They got severe scarring. Then somebody advised them to go to specialists. They came to me. So these type of patients, how do you treat that, Nazia?
Sir, actually, for child at 4 to 5 years and all, under topical anesthetic cream, I prefer to do cautery, but the child don't cooperate much. So ideally, they should be done under anesthesia, short general anesthesia, to be cauterized or extirpation. Yeah, but I haven't done under anesthesia or with the help of anesthetist.
Done much, right?
Yes.
Okay. Rahman?
Sir, as the child is very small, they will not allow us to do. In such cases, it is better to admit the child under short GA with ketamine injection, like that we can do. We just extubate and burn the base, either with the electrodesiccation or with the TCA application. So, but for this type of children's younger age, anxious patients, not cooperative, better to do under the GA. So, multiple lesions, face lesion, children's, better to do under GA.
Madam, how about your opinion?
Preferably, I avoid surgery, sir. Actually, with retinoid, topical retinoid is useful for the children, but it's like daily 2 hours contact period like that. At least within 2 weeks, most of the lesions will go off. Otherwise, 10% KOH also. We have to educate the mother to how to apply and all the thing. If at all they go for, I did one case, let's say extensive MC under the general anesthesia, sir.
Yeah, wait, let the panelist speak. You are not a panelist.
He is pediatric dermatosurgeon.
No, you're not a panelist. Lahari, let Lahari ask. Let Lahari speak.
See, we all know that MC treatment is not a single sitting treatment. So how many times will you give a GA and do the patient? That's the practical point.
Actually, usually I'll preferably I avoid surgery.
Yes.
But one of our PG's relative only is some exuberant lesions are there and eyelids and the bunches of lesions. That case we did in the general anesthesia. And after that, if at all any smaller things are popping up, I advise them to apply short contact period of retinoids.
Yeah, that's what. There are exceptions to everything, but generally we can avoid doing a major complex thing for a smaller thing. You can do like topical retinoid, you can use Emiquat.
Yes.
That also will help in these cases. So we can give a try to that. If then nothing works, then we can probably go to the others.
I think we called Bhumesh as a panelist now, and he can answer. Briefly, please.
I will share my experience as not a panelist. So,
fine, you're enough. Yeah.
Any treating invasive procedures in the pediatric age group, it's very difficult. So, when you see the MC and the child, first thing is we have to rule out whether the atopic child or non-atopic, because in atopic individuals, the managing is different. In non-atopic individuals, managing is different. Most of the time, what we have done, even Gandhi, myself, Neta, and we did the immunotherapy. So, if you choose one big MC, if you give intralesional MMR live vaccine, all lesions will subside. That is one way. And another point, Madam rightly said, just leave it and give assurance, all lesions generally it will subside. In other way, at least 15% KOH or the 15 to 20% TCA, at least 10 to 15 days that will. Because invasive procedures managing in a child, it's very, very difficult.
Yeah, I think the point is well taken that we need to give conservative measures. First thing is assurance, the parents. But the point is, when they're getting new lesions in the same child, particularly in the face, when other children are getting infected with the same lesions again, they will be in panic. When one sibling gets, then other sibling also start getting. It spreads by touch. So then the point reaches where you have to treat it somewhere or the other. You have topical treatment like retinoic acid, 0.025%, 0.05% applications. Then with a toothpick apply 10% calcium hydroxide, and imiquimod, all are quite useful. But when these things fail, what to do? See, nowadays surgical procedures are not that risky. Maybe invasive, but they are necessary in case. Because when you find such a lesions all over the face, the extirpation is impossible without giving anesthesia. And the child moves like this, once it picks like this, gone, finished. So you need to sedate the child. For that, Madam, you want to raise anything? Yeah. Take the mic, no?
Recently, Dr. Vimla Manne has told that the plunger, if you keep on the, with a syringe plunger and pull that, it becomes more obvious and we can remove the MC.
But child must allow you to do so, no?
Only
the whole issue, child won't allow you to do so.
If it is more or less obvious. And yeah, if we pull, the vacuum itself helps.
You can use the probe of a microdermabrasion.
Yeah, these are innovative methods.
Microdermabrasion probe is broader, sir. Plunger of the syringe is very up to 1 mm only. So we can put on the MC and suck it off.
No, microdermabrasion, if you see the probe, the hole is very small.
Yeah, I think, wait, Raman, brief please.
This technique of plunging with the syringe will help only with limited lesions. But multiple lesions, small child, definitely it will be very difficult. If we start with one lesion, then the child will become agitated and he will not allow, he will not be cooperative.
Because they are now techno-savvy, they are keeping that video ROM attached to make them see the videos. Yes, they are doing, sir. Videos, they'll be continuously seeing the physician can do.
Okay.
Like
now, say,
keep that in
I
the
think
clinic.
we need to conclude this discussion on molluscum contagious.
You are doing the VR with the same price or increased price?
Okay, fine. Thank you. So, most important thing is never be afraid of taking reasonable risk as per scientific knowledge. I give under ketamine anesthesia, I ask the patient to pay for it. I do in a theater, in a nursing home, anesthetist will come, I'll pay him, I'll pay OT charges, I'll pay my charges also. I never think the patients are poor. They are only poor before doctors and nursing homes. They are very rich, birthday parties, pizzas, burgers, birthday parties, what not, everything. See their cell phone. The cost of their cell phone will give you the status of how they are. वो बहुत गरीब बोलता है 50,000 का सेल फोन कैरी करता है. Never believe that they are poor. They are only poor before a doctor. You decide your status. You dictate terms of your fees and your terms and conditions. You charge 12,000, give 3,000-4,000 anesthetist, 3,000 to nursing home, pay 6,000 yourself. Patient will be safe, child will be safe, everybody will have, you have technical knowledge of anesthesia there, and that is how you do it. Don't underestimate yourself, please don't do that. Don't undersell yourself. Do it in a way so that they pay for it. I given a ketamine
this is the best take-home message.
So this child I gave under ketamine, and this lady, she has got molluscum, you can see on the eyelids. Eyelids difficult to control the eye movements. And extirpation in this age, at these margins, is difficult to control the eyelid movements. So for these both patients, I did under ketamine anesthesia and extirpation. I asked the parents to mark all the areas, do extirpation. I check all the areas once again. I ask my nurse to check once again. I ask once to check once again, so that you don't miss any lesions to prevent recurrence, right? So this is before doing procedure. This is after procedure. The same child, you can see. This is before, this is after, face, this is after. Another child, this is after procedure. You can see molluscum, the eyelids, eye margins, eyelashes also on the face and the cheek. This is after treatment. The last topic today is, we'll conclude soon, please. 5 minutes more. So, bear with me, please. The Rahman, these are plantar warts. How they differ from the common warts in other locations like verruca vulgaris. How the plantar warts or periungual warts or palmar warts differ from the classical verruca vulgaris.
Plantar warts are hyperkeratotic form lesions, sir. They are highly infectious. And when compared to other warts, it is very difficult to assess the depth of the warts. And it is very commonly seen in the children and teenagers. And
yeah, you tell the procedure part of it, you know. Theory, let us, because time is short.
Yeah.
I request you, please, theory, practical part of how do you treat that?
So first one is just initially we can try for as a first line of treatment, we can start as a salicylic acid application, 17%. In the later stages,
application.
Yes, sir.
Right.
And later on we can go for under local anesthesia. We can go for electrodesiccation followed by curettage and TCA applications.
Nazia, you want to add?
Plantar warts, like the warts on the other areas can grow superficially, but they grow inside. So the cone of the depth of progression is inside. So it will be, they are different from other warts of the body.
Okay, madam.
The depth is we cannot assess. That's why we can, usually I'll preferably do the, under local anesthesia, what are the hardened keratotic lesion, I'll remove with the cartridge. After that, usually I'll go for the cryo or something.
That's fine, madam, but one disadvantage risk is that when you inject locally an anesthetic agent, you inject, when you are withdrawing, the virus particle can come along the injection tract and there can be recurrence. The risk is always there. So generally we give intralesional anesthetic agent, but this risk is always there. Right, that Lahari?
See, what we can do is most of the time, like here you are seeing almost a 1-inch size plaque.
Yeah.
Probably the wart is not that big. It is the hyperkeratotic tissue. So you shave it off. When you shave off and then apply a coat of TCA, 50% also, you will see the grayish white circular points. Those are the actual infective points. You can punch out those things. So instead of making a 1-inch incision and leaving a bad scar, which itself will become painful, you can remove the hyperkeratotic tissue and just punch out the grayish part. the treatment will be as good as doing the whole thing.
Yeah, madam, the local anesthesia is definitely useful. It's only risk I just talked about. Okay.
Actually, after local anesthesia, not only local anesthesia, sir, actually viral things we cannot predict. After the removal also, some people they develop smaller things. Along with
almost 40% recurrence rate is
the recurrence is there. To avoid all these things, I'll preferably give immunomodulators like ivermectin or something. Tacrolimus, all the things, along with the zinc preferably I'll give, sir, at least 1 or 2 months continuously. Then the recurrence rate is very less.
So zinc sulfate tablets?
Zinc sulfate tablets and that vermizole, what is it? Levomizole, weekly pulse therapy I'll give for 12 weeks.
Even larger lesions, if excision is not a possibility, you can do either immunotherapy or bleomycin tattooing.
Mostly the multiple lesions, if I'll give the immunomodulating things.
Okay. I think with the trial of all the immunomodulators and topical applications, still we are not much of response. I just go for ketamine anesthesia and just remove under ketamine anesthesia, short general. That's what I do. And gives good results also, but not much of recurrences. So another child with having the palm or verruca on the right thumb and base of the thumb. This is nene chappattu kodtam mere wait cheyakandi. This is after the procedure, right? And this is the child having the warts I shown in beginning. This is after treatment under ketamine anesthesia, right? Short general. On the left hand, at periungual warts and the thumb also there. This is also same child. This is before treatment. This is after treatment. So all the lesions can safely remove under ketamine anesthesia. So just last few slides. This is seborrheic keratosis. All you know. How do you treat nausea?
Under topical anesthesia, we do electrofulgration.
Right. How about you, ma'am?
Same, sir. Excision.
Raymond? Right. That Lahari?
Cautery and curettage.
Yeah, that's excellent. You see, we just topical EMLA, then curettage, electrodesiccation and curettage gives best cosmetic results. This is before, this is after. Same, the similar lesion. Again, lesion looks big, but it's pedunculated basically. A small base is there. Just do electrodesiccation. Is after treatment. Not even a trace of any scar anywhere. We are very happy before and after. This is a basal cell carcinoma. Last slide that we Deepan Murthy garu, kindly permit me. Right? Padmaja madam, basal cell carcinoma, how do you approach? As a dermatologist, do you refer or do you treat?
Usually I'll refer, sir.
Right. Nazia?
It happened that after I just had a differential diagnosis of BCC and the diagnosis came out later, I already had excised that one. Then it had no occurrence. If I have to manage 2 millimeters wide excision and suturing, will be fine. And most of the
And that, Nagari?
Say 2 millimeter is not correct. It's a low risk BCC should have minimum 4 millimeter of margin. High risk BCC should have an 8 millimeter margin. Low risk, high risk, the difference is high risk is usually face and neck lesions, more than 3 centimeters, aggressive histopathology. Low risk are on the extremities or trunk and the size is smaller. This type of lesion can be, you can easily do a CO2 laser ablation and curettage, the patient will heal better. You need not do excision.
Yeah, I think one point I forgot to mention, when the plantar warts and palmoplantar warts, after you do electrodesiccation, go to 3 mm the surrounding margins. 3 mm surrounding margins also do electrodesiccation. In the base also up to 1 to 2 mm do electrodesiccation. This helps to prevent recurrences by 90%, more than 90%, right? Now coming to basal cell carcinoma, this patient he was 55 years old. Then we did a punch biopsy, it turned out basal cell carcinoma. I did a cryosurgery with liquid nitrogen cryo, longer freeze-thaw cycles. With at 15 second freeze-thaw cycles, 5 sittings. Then after 6 years, no recurrence. After 6 years, no recurrence. He is a teacher in our Kannur district. No recurrence, and We also can take up basal cell carcinoma, non-invasive, local invasive carcinoma, not metastasis. Definitely we also can take up these type of malignancies also. So we have one doubt, query I would like to answer. How to prevent recurrences on plantar cons? Cons are what? I hope it's cons only, right? Madam, how to prevent recurrence of plantar cons?
Cons prevention is very difficult, sir. Cons development is because of maybe the abnormality in the bone arrangement.
Ill-fitting shoes also can be a cause.
Ill-fitting shoes and all the things. Recurrence we cannot prevent actually. We have to advise them to take soft shoes and all. They have to maintain.
See, cons are basically result of derangement of plantar arches, both horizontal and vertical, and no proper alignment. That's why you get cons. For that, you need to use the microcellular rubber shoes, soles, and that's how to prevent it. Remove the cons is surgical only, right? But proper fitting of shoes and other deformities of the foot, sole part is very important. Is it advisable to use moisturizers in tinea? What is the rationale? Yeah. Nazia?
Yes, it is advisable to use moisturizer in tinea because transabdominal water loss also has a role in the more of spreading of the tinea. Sir. The transabdominal water, if a xerotic skin or a dry skin has more chances of the growth of the fungus. So
but
it's always good to moisturize.
There's a catch for that. Moisturizer is supposed to promote the fungal growth.
No, sir. Moisturizer
No,
has
because
to be
audience
applied
says so.
Sir, sorry.
Audience are saying that moisturizer will promote fungal growth.
No, it doesn't.
No, it's not so?
It's a
Right,
sterile.
okay.
It's a sterile thing.
Antifungal
it only help
creams
in
and
Okay.
antifungal creams and antifungal soaps itself will cause dryness. So we can advise because both antifungals in the night times and moisturizer in the morning times we can.
Okay. Lahari?
Unnecessary prolonging the time.
See, the last question before 4:45. Question not mine, please. Audience, please. See, best modality of treatment for periungual warts in adults and children. Multiple warts in adults and children. What is the best treatment for best outcome? Right. The one single sentence, all of you. That Padmaja?
Immunotherapy or immunomodulators, sir, along with the surgical things.
Right. Madam, Nazia?
Immunotherapy with BCG vaccination.
Right. Rahman?
Sir, initially we can, as a first line of treatment, we can give salicylic acid. And later on, and as a definitive procedure, we can go for electrodesiccation, curettage, and TCA, and it should be followed by the immunotherapy, sir, levomazole or zinc oxide.
My preference is intralesional bleomycin or bleomycin tattooing first, and the second choice would be immunomodulators.
Auto inoculation also we can try, sir. But it is multiple.
If the conservative methods fail, you go for a electrodesiccation, the ketamine anesthesia, that's what I recommend. Subsequently also, while doing the electrodesiccation, do 3 mm in the margins and 2 mm in the base, and after that also give no moderator to prevent recurrence. That's a message from the panel discussion. And thank you very much, Dr. D.B. Murthy Garu, Dr. Bhumesh, and Dr. Janardhan, and scientific chairperson Dr. Neta for giving me the opportunity. But last but not the least, youngsters, please take up dermatosurgery in big way. Be bold and don't undermarket yourself. Patients are not poor, right? If you think patients are poor, you will become poor ultimately. Don't do that. They are very rich. They spend any amount on other things. For them, health is the main thing they don't want to spend. But make them spend and charge reasonably well and be rich. Thank you.
Thank you.
Panelists, Dr. Lahari, Dr. Rahman, Dr. Padmaja, and Nazia for beautiful participation and effective panel discussion too. Thank you very much. Thank you, Satya.
Thank you, everyone. Please join us. Ikkadana. Now I request Dr. Indira Madam to give concluding remarks.
I just wanted to share because I found the whole faculty is rheumatic surgery focused.
I request, I request Dr. Janardhan sir to give vote of thanks.
Hello. A very warm good afternoon to one and all. On behalf of Team TS IADVL 2021, it gives me an immense pleasure to deliver today's vote of thanks on the pre-conference workshop here at Gandhi Medical College campus. In today's event, the most important topics discussed like chemical peels, botox, fillers, pigmentation disorders, hormonal imbalance issues, and transplantation, etc. by an eminent faculty both within the state and outside the state. I thank each one of them for sharing their personal experience and knowledge. I thank each and every delegate for participating and making it a grand success. Looking forward for your active participation for coming today's conference. Long live TSIDVL. Thank you.